We're going to get started with the program. So I'm going to say some opening remarks, and then we're going to turn it over to the first panel with Robert Popavian of Pfizer. So for those of you who do not know me, I've been here with the Chamber for a while. I am Michael Billett, Senior Manager of Policy Research here at the Chamber, and I work on healthcare, labor, and immigration policies. So I want to welcome everybody to today's event, Aligning Incentives for Better Health. The Chamber creates values for our members, the communities where they operate, and our country by advocating for business, growth, innovation, and most importantly, job creation. And this year, with the support of Pfizer and some other sponsors, the Chamber is hosting a series of events to highlight developments in what we're here to talk about today, health and wellness. Some of you, I've noticed, were at the first event, which was held here on April 10th, Innovations in Workplace and Community Wellness, a Roadmap to Program Success. At today's convening, the objective is to highlight the important role that businesses play as purchasers, as well as methods to advance holistic and innovative approaches to improve healthcare. At the Chamber, we take a long-term view while delivering immediate impact. As June is National Employee Wellbeing Month, today's forum highlights social entrepreneurship, entrepreneurs that are drawing upon business techniques and private sector approaches to find solutions to social, cultural, and environmental problems. As this week is Multiracial Heritage Week, the focus on today's event is the largest growing demographic in the U.S., the multicultural segment. The growth of this segment will influence economic growth, consumption trends, and business and organizational outcomes. To put it succinctly, multiculturalism is America's competitive advantage. First today, you're going to hear about the critical role of the private sector in driving innovation. Employers, as many of you in this room know, are the largest purchasers of care, and approximately 150 million Americans receive insurance through private sector health plans. As the largest purchasers, employers are committed to achieving value and achieving efficiency, and this is primarily done through the use of medications, which is of critical importance. Medicines are responsible for preventing and curing disease, improving or maintaining health, and avoiding exacerbations of existing conditions. It's kept millions of people out of the hospital, and then it also saves money through spending offsets in other parts of the healthcare system, and as increases in quality of life and productivity gains are realized. Kicking off the day will be a panel moderated by Dr. Robert Popavian of Pfizer and featuring representatives of Pacific Research Institute, PricewaterhouseCoopers Public Sector, LLP, and Amoca Mobile Health. Speakers on this panel will elaborate on the value of innovations in the biopharmaceutical industry, solutions to the opioid epidemic, and how companies are responding to marketplace challenges. Later in the day, Ray Quintero from Healthsperian and co-director of the Smarter Healthcare Coalition will speak about value-based insurance design. Second, business has always been a leading force for good in America. As a core value, the Chamber believes in partnerships. As a nation, we succeed when we work together, business, communities, and governments. Improving outcomes in the healthcare system requires a multifaceted approach and public-private partnerships to address inequities. In today's society, studies have demonstrated where you live is more predictive of your overall success than your gender, sexual orientation, and even the color of your skin. Teaching individuals healthy behavior at a young age is critical to stemming the prevalence of obesity and chronic conditions such as diabetes before they become adults and enter the workplace. Adam Beck from AHIP will guide us through AHIP's Wellness 2.0 model, which is going to provide a deeper understanding of the role that social determinants of health play in promoting health and health equity. His fellow panelists will highlight innovative approaches to diabetes prevention, physical inactivity, and the importance of improving access to care for the African American, Latino, Hispanic, and mixed race populations. Third, the success of communities' total economic well-being is tied intimately to healthcare as businesses fuel job growth, and job growth, of course, is tied to productivity gains. Employers have an incentive to ensure employees are engaged on the job. Increased engagement on the job does more than boost productivity. Strong employee engagement also promotes a variety of outcomes that are good for employees and customers. Daryl Moon Orion, Mita Shukla, Vita Mita, and Betsy Delser of Middleton School District, Wisconsin, will talk about the benefits of incorporating mindfulness techniques in workplaces and schools. Their presentations will be accompanied by a talk of a community initiative being funded in part by the National Endowment for the Arts, Sound Health, which is the collaboration between the Kennedy Center for the Performing Arts and the National Institutes of Health that seek to explore the intersection between music, the brain, and wellness. Fourth, as an organization, we champion the free enterprise system, the American worker, and most importantly, the entrepreneur. At launch, Sinead Bovell is debuting the weekly advice for the young entrepreneurs, otherwise WAY, known as WAY, Talks in D.C. She's taking her talks from the Big Apple in New York City here to the nation's capital, where she will interview Nick Desai of Heal, which is an app for on-demand physician house calls. The final panel of the day will focus on methods to enhance the health outcomes of employee populations. Employers with well-designed workplace wellness programs consistently demonstrate a positive return on their investment. As you will hear from representatives of Mercer, MetLife, American Express, and VisioNext LLC, workplace wellness programs with multi-dimensional components such as physical, financial, emotional, and social health are increasingly becoming the norm. Closing out the program will be a discussion of the movie Mixed Match. Athena Marie Asclepiadis, hopefully I got your name right, Athena. So Mixed Mirror, she's over there, was going to be interviewed by her companion over there, Randy Rudda, Chief Patient Advocacy Officer, Partnership to Fight Chronic Disease, where clips of the movie are going to be played. Athena has identified a need to find mixed ethnicity, bone marrow, and cord blood donors to donate to multi-ethnic patients suffering from life-threatening blood diseases and applied her knowledge and skill set to raise awareness of this problem. Last but not least, I would like to thank our sponsors, Pfizer, Partnership to Fight Chronic Disease, CTEC, otherwise the U.S. Chamber of Commerce's Technology Engagement Center, which is sponsoring the launch, and the U.S. Chamber of Commerce Foundation's Corporate Citizenship Center. It is now my privilege to introduce Robert Popavian, Vice President of U.S. Government Relations of Pfizer. Robert Popavian publishes and regularly presents on the impact of biopharmaceuticals and health policies on healthcare costs and clinical outcomes. Some of you may be familiar with him as you read his column in the Daily Caller. The rest of Robert's bio is in the program booklet, which you all have, as well as all the other speakers. I hope you all find today's event informative, and now I'm going to turn the stage over to Robert, and he will introduce his fellow panelists.
Why don't you, Wayne, sit here, Oleg in the middle, and Sebastian at the left. So, good morning. I hope everybody's doing well. You know, we're here at a panel, and we're talking about health and innovations in healthcare and pharmaceuticals and so on and so forth. What a better way to start than talking about how to improve outcomes, reduce costs, and be innovative about it, right? Because that's one of the pillars of healthcare, what we need to achieve here. And we have a great panel for discussion purposes today. We're going to be talking about how to reduce expenditures in the healthcare system, how to basically prevent and do better for patients, and most importantly, how to basically improve outcomes from an adherence standpoint and reduce waste in the system. So without any further ado, I'm going to introduce our panelists, and each panelist is going to have about 8 to 10 minutes to discuss the topic that they're here to discuss. And then at that point, after we're done, I will ask some questions, but we will open it up to Q&A from the audience. So without any further ado, to my left is Dr. Wayne Weingarten. Welcome, Wayne.
Thank you.
And Wayne is a senior fellow of business and economics with the Pacific Research Institute, which is based in San Francisco, California, and a principal in Capital Economic Advisors. His previous experiences as a business economist in Hong Kong, and a policy economist for US-based policy and trade associations. Wayne has a PhD in economics, so welcome, Wayne. To Wayne's left is Dr. Oleg Kocheryavenko. Is that good, Oleg? Is that well? Thank you. Well, Oleg is an interesting fellow. He works for PwC. He's a strategic consultant for them, but he has a public health professional with 10 years of experience in global health, working in areas of maternal and child health, domestic resource mobilization, financial protection, and financial instrumentation. He was previously a senior consultant before PwC at the World Bank and head of the health policy at Oxfam. He's a physician, so we have a PhD economist, we have a physician, but he also has a master's in public health and a diploma in international finance. So very well, Oleg, welcome. To Oleg's left is Sebastian Sager. Good?
Yeah.
Excellent. Well, Sebastian is the CEO and co-founder of Imoca Mobile Health, which uses video technology to secure medication adherence. He is responsible for operation, finances, strategy, and company management. This is a critically important issue, right? Because if you think about it, we probably spend or waste about $120 billion annually on non-adherence in the United States, which is about a quarter of what we spend on pharmaceuticals. So if we can get our hands around what Sebastian's trying to do here, it'll be terrific. And his company is right in the forefront. He has a JD, so we have a lawyer too. So are you going to keep us all straight here?
I'll be monitoring carefully.
Okay, thank you. And he also has a master's in business administration. So I'm a pharmacist with an economics degree. We have an economist. We have a physician with an economics degree and JD with an MBA. So you're well represented from all different professions within the healthcare system and the healthcare ecosystem. So without any further ado, I'm going to turn it over to Wayne, and he's going to talk about his area of expertise and research. Wayne?
Excellent. Thank you. And I guess it's kind of dangerous, right? Starting off the morning, everyone's tired, and you have an economist speaking. So I'll try to go light on numbers so that it's just way too early. What I really wanted to talk about, I just finished a paper, which is actually perfectly aligned with our topic here, looking at biosimilars. And how can we get foster a more robust biosimilar market here in the U.S.? And if we take a kind of a step back, because if we look at kind of employer health plans, or employer-sponsored health plans, and everyone here knows, there's a huge problem with costs. And kind of in preparing for today, actually, the Society for Human Resource Management, everyone's probably seen their commercials, they did a survey of large employers. And they found for this year that they expect their costs to go up 4.1% a year, which is bad. It's way above inflation, and it's also bad because it's trending up. It's not we want to see the line going this way, not that way. And what makes it even worse is that that's after you've seen all of the kind of actions where they're moving towards more, lower cost, high deductible plans. I mean, basically reducing the benefits that the employer is getting. So if all those actions hadn't taken place, costs would be going up 6%, actually 6.1%. So we've got this continuation of the problem where we can't get control of healthcare costs in the country. And so obviously we need all sorts of reforms, right? If you want to talk about reforms writ large, Sally Pipes, my colleague at PRI, she's got all sorts of fantastic ideas in terms of kind of those grandiose reforms. But what I tend to focus on, I think, are just as impactful is you need targeted reforms, because there's all sorts of areas of opportunity where we can start to just hit at the waste, hit at kind of the lack of aligned incentives to improve kind of costs and at the same time improve the quality of healthcare. And so that's kind of where kind of the genesis for this kind of research that we undertook started from, and that was looking at biosimilars. Let me kind of start with the question just to make sure we're on that same level. Does everybody know what a biologic is versus a biosimilar and the difference between that and chemical-based medicines? I'm seeing some. Okay, let me go through that very quickly. And it's an economist teaching you pharmacological, so take it with a grain of salt.
Take notes.
Traditionally, right, medicines are chemical-based, right? You have your patented, which are the innovations, and then, after the patents had, expired, you would have the generics, which, because it's a chemical-based medicine, it could be pretty much an exact duplicate of that medicine. We've done, the most important thing in kind of the economics of pharmacology. There it is. Is you have to balance out innovation with competition, right? That's the essential balance we have to strike, right? And we've done that reasonably well with these chemical-based medicines, right? Where 57% of all new innovations in these medicines in the world happen here in the U.S., right? We also have the highest usage of generics. I don't know if people are aware of that, but 89% of all kind of pills dispensed are generic medicines, right? So in these medicines, we're doing a really good job of balancing innovation with competition to control prices. These medicines are fundamentally different than biologics, and a lot of the new innovation, actually part of the 57%, are coming from these biologic medicines. If you hear the news, all the cures for hepatitis C, the cancer, Parkinson's disease, skin infections, all of these are actually what they call biologic medicines that come from live organisms. You're actually developing it from those organisms. And so when you have a biosimilar, right, to these biologics, it's kind of like a generic, but it's a lot more complex. Right? You need a completely different regulatory pathway. They're a lot more expensive to develop. Right? So whereas a generic can reduce prices about 85% is what you see in the market. So if you have a pill, $1,000 would be, doing my math here, 150, 250, 150 for the generic. Huge difference. Between biologics and biosimilars, you're talking about $1,000 to maybe about $700. Right? That is because it's fundamentally more difficult to develop a biosimilar. Huge difference, right? Huge savings potential, but not on par with the generics. Well, where does the problem arise? While we have the most developed generic market in the kind of industrialized countries compared to Europe, Japan, Canada, similar places, we are way behind on biosimilars. Right? Europe has about 40 different biosimilars that they've approved. We have 11. Okay? In infliximab, which is a drug that deals with autoimmune disorders, it's the one I looked at. So you're talking about Crohn's disease, ulcerative colitis, psoriasis, psoriatic arthritis. This is what I hate about medicine, by the way. The words are just incomprehensible.
We make it intentionally.
Thank you. So it's to address all these really problematic immune disorders. In the U.S., right now, the biosimilars are less than 2% of the market. In Germany, it's 10%, right? In Denmark, it's 49%. Okay. Now think about all the different cost savings that are possible if we actually had those markets. And that, in effect, was the question we asked in the paper. What type of savings can we create for employer-sponsored health plans if there was kind of this robust biosimilar market? And you would think, well, if we have a robust generics market, why don't we have a robust biosimilars market? And that was the kind of the question we asked. And then, of course, the subsequent question is, if there are savings, why don't we have the market? Well, the savings, if you look at the actual prices, and if anyone's ever looked at pharmacy and pharmaceutical prices, it's not an easy task to interpret. But if you actually take the prices that are being used in the system, and if you compare it to kind of the biologic, which is called Remicade, versus the two biosimilars, which is called Inflectra and Renflexis, you can see that on a per-patient basis, you're talking about savings, depending upon the disease, in particular, somewhere between $3,000 and $4,000 per patient that we could be saving if we had a higher kind of usage of biosimilars. If you talk about what does that mean for kind of the entire market, you're talking about $333 to $400 million of savings if the biosimilars, those two biosimilars, were 50% of the market. If they were more, the savings would be higher. If it was less, they would be lower. But you're talking about significant savings potential from kind of biosimilars if they were creating market shares even somewhat similar to what we can do in the generic market. And that's just for one medicine. Right now, imagine if we had 40 medicines, right, it wouldn't exactly be like this, but 400 million times 40 is a very big number. So the question then becomes, well, why haven't we had these markets? What's stopping it? And there's a few kind of culprits that we found, and we think it's kind of, in terms of reforms, kind of what we need to start focusing on. The first one is the FDA. We're a free market think tank, so we love to blame the government, and usually we're right. And in this case, the FDA back in 2009, right, when the biological price BPCIA was passed in 2009, they were supposed to create regulatory guidelines because the biosimilars are so different than generics. So you need a completely different regulatory guideline. It's been, 9 years? We still don't have final guidance. And if any business will tell you, if you have regulatory uncertainty, that's just a huge obstacle to kind of getting any type of development, innovation, any of those in any space with this regulatory uncertainty. So that's kind of the first obstacle that's there, has to be addressed. We also have market obstacles. Right? One of the biggest ones in terms of the process of how these medicines are paid, right? Aligning incentives. Right now, the medicines typically are infused at a doctor's office, clinic, hospital. These are purchased what they call a buy and bill process. So basically, the clinic will buy the medicine, then they'll administer it to the patient, and that's when you then go and bill the insurance company. And what you do is you bill it generally the price of the medicine that you purchased plus some sort of percentage markup. Well, it's just basic arithmetic now, right? If you're a clinic, if you have a percentage markup on a higher priced biologic, or you have a percentage markup on a lower priced biosimilar, again, it's, where are the incentives? And the incentives are misaligned because you want the clinics to have the incentive to administer biosimilars, and it works in reverse. The same thing with what insurance policies typically have fail-first policies, right? And in generics, this is working correctly, where they'll say a patient has to be prescribed the generic first, and then if they fail on it, then you can prescribe the higher-priced patented product. Makes sense in terms of costs. Well, for some reason, it works in reverse when it comes to biologics and biosimilars. First, the patient has to fail on the biologic, and then and only then can you prescribe the biosimilar. So again, you have this kind of bias towards biologics and an obstacle to a more efficient biosimilar kind of development. There's other market barriers, contracts that kind of have tie-ins that you have to wonder, is this really fair competition, things of that nature. And all of these obstacles, when you put it together, and then you look at the differences in our use of biosimilar compared to Europe, and you see that they don't have those obstacles there, right? Europe has a pathway that's certain for biosimilars. You start to see that there's obstacles that we can focus on, that we can eliminate, and by doing that, there's hundreds of millions of dollars per biosimilar that we can be reaping, and that's just for the employer-sponsored plans, right? Medicare is another 140 some odd million dollars, and that doesn't take into account Medicaid, doesn't take into account people who are self-insured. So you're literally talking about billions of dollars of savings that we're leaving on the table because of these kind of market and regulatory inefficiencies. And that's really kind of what I wanted to share with you.
Thank you, Wayne.
Thank you.
Hold your questions. We'll get back to Wayne's discussion after everybody speaks. Oleg, you're up next.
Thank you. I think it is important to talk about opioid crisis in the United States and how to align incentives and whose incentives to align for better outcomes. So the director for CDC recently characterized the opioid crisis in this country as the public health crisis of our time. And 115 Americans die every day as a result of prescription and illicit opioid use. Opioid-related overdoses in the United States are the leading cause of death now, and exceeding the amount of death caused by car accidents and guns. And we understand that this crisis, 2 decades in the making, will continue in the absence of a creative solution between the public and private sectors. So why this is important for public and private sectors to interact to tackle this problem. Neither government nor the pharmaceutical industry can address this epidemic alone, nor can they address this in a silo, as this crisis has implications across the patient intervention continuum and also across industries and sectors. Additionally, because this crisis has not only health implications, but also implications for policy and law enforcement across local and state jurisdictions, requiring coordination and engagement across private sector players, pharmaceutical industry, payers, providers, data analytics. Furthermore, this crisis is unique in this country because it affects different socioeconomic strata, and it's also very immune to all geographic and cultural barriers. Therefore, a novel and creative partnership model between public and private sector players is required to address the unique elements of this crisis. So, federal and state governments and local governments have to work side by side with industry experts and academia to find innovative solutions to tackle the problem, and also to advance existing pharmacological treatment for pain and addiction. While also it is important to find new innovative solutions to address the patient as it moves from the pre-exposure to opioids through physical dependence to addiction. Specifically, the data shows that if we address a patient at each stage, it's important to design preventative mechanisms and interventions that are tailored to the specific stage of this continuum. Let's talk about public-private partnerships. Why are they so important? So the U.S. Chamber of Commerce recently published an issue brief in January that asserting that public-private partnerships are required to solve another crisis in the United States, infrastructure. And specifically, the brief states that neither the government nor the private sector can solve this $2 trillion crisis alone. By the numbers, the opioid crisis has cost the United States $1 trillion since 2001, but the figure is projected to grow 50%, about another $500 billion by 2021. The Council of Economic Advisors estimates that in 2015 alone, the economic cost of the opioid crisis was $500 billion, which is almost 3% of GDP for that year. So the financial losses stemming from the opioid epidemic, they are staggering, yet these projections do not account for the invaluable human loss, the loss of families, communities, as well as labor work productivity. So the U.S. Chamber of Commerce have long espoused for several years the importance of PPPs for infrastructure, that PPPs has a critical role to play in solving the infrastructural problems. But in my opinion, the opioid crisis is an infrastructure crisis in its own way in this country. At its core, public-private partnerships, they strive to enhance full and open participation of all players and also communication between sectors while delivering cost-effective and proven solutions, best practices. One such example is that federal, state, and local governments have invested heavily in drug courts and innovative alternatives to incarceration in the form of administering medications for addiction treatment and rehabilitation programs that proved to be very effective. Several federal agencies have identified best practices for ending addiction in this population that is particularly at risk of overdose death. What I wanted to emphasize that it's interesting that the U.S. Chamber understands the importance of treating those in the criminal justice system so that when they leave prison, they can seek employment and other social services. And private sector industry and pharmaceutical companies can help identify best practices from around the country or also around the globe, objectively convene government stakeholders, and manage the delivery of these best practices, and sharing the success stories and scaling up proven interventions across the country. I will provide the example that from this country. So the U.S. Chamber Foundation puts forward an appropriate sense of urgency when it states that preventing the further spread of opioid abuse, especially among our current and future workforce, is imperative to our country's future. Furthermore, the chambers of commerce across the nation, from Delaware to Wisconsin to Ohio, they work on tackling the opioid crisis locally. So the allocation of critical grants can purchase life-saving medication, opioid antagonists. They can develop comprehensive community-based recovery plans and support expanded service offerings for those people in need at outpatient centers, and also help create sober living environments. What's interesting, the Ohio Chamber of Commerce is a very fascinating example. The Chamber has taken note and taken action as it developed the free online course geared towards employers. This multi-modular course offers strategies and overviews of the legal and operational issues that employers may consider in preventing and potentially, when necessary, addressing an employee's use of opioid drug use. And again, the Ohio Chamber of Commerce looked at this problem as the patient, as the person moves across this continuum from the pre-exposure to opioid drugs through the development of physical dependence to finally forming addiction. And I also think, we discussed this before the event, that one of the important aspects of tackling the opioid crisis is education. Education of patients and also education of medical professionals. Potentially there is a need to look into best practices from the countries where pain management is of high quality and does not require the use of opioids unnecessarily. And as for public-private partnerships, it's apparent that PPPs are making a difference in this country in tackling the opioid crisis, but the next step would be to identify, qualify, and scale the best solutions.
Thank you, Oleg. Sebastian?
So there are, as you alluded to, Robert, the problem of people not taking their medication, which is referred to as adherence, is one of the biggest problems in healthcare. There are many others, and there are many other cost savings approaches and a lot of fixes, as you point out, Oleg, that need to take place that are not related to medication. But and adherence is always referred to as this really very complicated problem. But let me point you to a few very, very simple facts that make the problem of adherence, let's say from a macroeconomic point of view, a little easier to understand. So the first point is that medications have advanced tremendously over the last 50 years. They're revolutionary. But it is a fact that if you don't take medication, it doesn't work, right? And I'm not the first person to say this. So in 1985, our Surgeon General at the time, Dr. Koop, said, medication doesn't work in patients who don't take it. And that is an astounding fact when you think about that. We know that 50% of medication is not taken or taken properly. 50%. So you pointed out $120 billion. It doesn't matter if it's $120 billion or $200 billion. It's a lot of medication that goes to waste. But the waste itself isn't the problem, because if it was prescribed, then I guess patients needed those medications. So the problem is that when patients don't take the medication, their health outcomes are for sure going to be suboptimal, because the medication does work if it's taken properly. What I'd like to do is just highlight the problem of medication adherence, why it exists, then tell you about the current solutions that are out there, or the current attempts at solving the problem, and tell you what we do as a company, and finally point to a few misalignments in policy that I think are quite surprising. So how do you make sure? Why don't people take their medication? So they're in that case, that is a complicated question. The reason it's complicated is because we don't watch patients take their medication, so we don't know why it is that they don't do it. So they can forget, they could feel better, they could feel worse by taking medication. They might not be able to afford their medication. So it's a multifaceted issue for sure, and it's a behavioral issue as well. What solutions are out there? All right, you can group them into two types of solutions. There are the indirect solutions. There are the direct solutions. Indirect solutions, for example, the current standard of measuring adherence is the refill rate. Did a patient get their prescription filled? And how timely was that fill? This is the current standard of measuring the word adherence. According to HEDIS measures, according to all currently accepted measures, it's something called medication possession ratio. That's an indirect measure because it doesn't tell you did the patient take their medication. Getting a little bit more advanced, like on the technology side, you could have a smart bottle. You open it, and if you opened it, that may mean, or it could indicate, that you took your medication. Also an indirect method. And there are several others. Commonly, when patients are suspected of having an adherence problem, maybe docs will or nurses will count pills, and they'll say, please bring your bottle. We're going to count how many are left so that we can estimate how many you took. Doesn't really work with opioids as well, right? Sometimes it doesn't work for some patients. Now let's talk about the direct measures. There are only really two big categories. One is biological. I can measure in your blood, for example, that you took your medication. For example, with Hep C medications, you can do that. Or I can take a piece of your hair, for those of you who have it, and measure presence of some medications, but not all. It's a limited use because people weigh different amounts and their bodies metabolize chemicals, biologicals in different ways, so there are limitations there, and you can't test people every day. Now, here is the one solution that has worked for over 40 years, and it works to a 95% success rate. And that is a direct measure called face-to-face observation, right? So this is referred to as directly observed therapy, or DOT. Over 40 years ago, we thought we had the public health crisis of the century, and it may very well have been at the time, and that was tuberculosis. So in tuberculosis, the standard of care is you watch every patient take every single dose every single day, except the weekends. Doesn't happen on the weekends. And from 1950, where there were 80-some thousand cases of TB, to today, where there are 9,000, that killer was stopped in its tracks completely through public health departments all over the country. In terms of opioid use disorder, for many, many years, methadone has been dispensed under direct observation on a daily basis and has worked. The problem with that is, there are like 2.5 million people with opioid use disorder, and there's a limited number of methadone facilities, so you can't do this on a face-to-face basis and solve that problem. So let me tell you what we do. We use video, asynchronous video. That means we use a video recording in conjunction with face-to-face observation to confirm that a patient has taken every dose of their medication. So a patient opens up our app, they enter side effects they may be experiencing, they video record themselves taking their medication. On the other end, a human being sees the file, confirms whether they took their medication, addresses any issues by messaging with the patient, and proven 94-95% medication adherence. So this is in tuberculosis. We've done this in hepatitis C. Piloted now in opioid use disorder for buprenorphine. Buprenorphine is a take-home medication that is not being prescribed enough because prescribers are afraid that patients won't take their medication and that they'll end up back in their office, they'll sell it, who knows. We're not the only solution out there, but here are the policy points I would like to quickly make. We spend $350 billion every year on medication. $320 billion are the health costs related to people not taking it, right? It's about the same amount of money. Our system gives an incentive for every part of the supply chain after the manufacturer to fill the patient with medication. Every single piece of the supply chain, it has an incentive to get the patient medication, but there is no incentive to actually take it. And so I would say, who's bearing all these costs? Well, the government is increasingly paying more for medication, so the government is a big, big buyer. At this point, 40%, they take 40% of medication costs in Medicaid, for example. Private health insurance is paying for medication on an increasing basis, so employees don't have to pay as much. Patients that have Medicaid, Medicare don't pay as much for their medication. So it is health insurance, whether government or private, that's paying for that. And we would do best to look really closely at what's been called secondary adherence, meaning whether patients actually take their medication if we want to save a lot of money and make people healthier.
Thank you, Sebastian. That's super important. I mean, somebody who's been in this industry over a quarter century now, I can tell you that Sebastian's absolutely right, because every year we come out, it's like clockwork, right? We complain about the non-adherence issue. but nobody can do anything about it. And then we complain about the opioids issue, and we just go on and doing the same prescribing and the same habits. And then we talk about healthcare costs, but nobody wants to adopt efficient pharmaceuticals in the marketplace to be able to tackle them. So with that said, I'm going to start the Q&A, but think about your questions, and we want to have you guys ask questions as well. So Wayne, let's start with you. You talked a lot about barriers, or I like to call them inefficiencies in the market, that prohibit the use of more cost-effective alternatives in the marketplace. What policy changes do you foresee coming that can help, would you recommend, to overcome these outcomes?
I think the most important one is the FDA. I alluded to that in my comments. If we need the final guidance needs to have kind of as obstructive as necessary, but no more so. We want to make sure they're safe, efficacy is there, but we don't want it to be excessively long. We don't want it to be excessively costly, and that way you have that type of certainty. I think the Hatch-Waxman Act from 1984 is a good guide, where it created a low-cost regulatory pathway for the generics, and that encouraged greater generic production. I think that's probably the most important policy change that can be made.
Very good, very good. Oleg, I want to go to you next and ask you a question. You talked a lot about the, partnerships, the 3 Ps basically, as you referred to, and it's a powerful tool in achieving, help in the complex issues, basically overcoming complex issues through these collaborations. What approaches can be adopted in the U.S. to overcome this opioid epidemic? Because it truly is an epidemic, or it's a catastrophe, because not only it's a monetary issue, but it's a human life issue. And unless we overcome this, I think we're going to be circling the drain with regards to life expectancy and everything else, because it affects a lot of young patient population in the U.S. Oleg, you want to comment on that?
Yeah, it affects the population under age 50, so the most productive population. I think the most important thing here is to bring all stakeholders at the table, from the public sector, from the government, at all levels, all agencies, and this is what PwC public sector is doing, is building this bridge and managing the stakeholders working around the issue of opioid use, which is drug enforcement agencies, HHS, pharmaceutical companies, healthcare payers and providers. Also, it is important to bring to this conversation the medical profession and academia, and start the conversation on how can we change the clinical guidelines, how can we change the reimbursement model for pain management. Do we need to prescribe opioid medications at any case of even moderate or mild or moderate pain? How can we prescribe opioid medications that are 2 pills versus a bottle of 30 or 90 pills? I also think, so my main comment whenever I go to different countries, I think every country thinks that the situation is very unique and special to their context. While when you work in 35 countries at the same time, you see that everyone has the same problem, and the wheel has been invented so many times. So if we look at the countries with high income status, Great Britain, a lot of countries, post-Soviet countries that have solved this problem a long time ago, it all comes to making healthcare affordable, making prescribing evidence-based, and 3, making patients educated and understanding what they're doing, what they are prescribed, and how they tackle their pain. Because when the patient is empowered to say no to a doctor, that I do not want to take the opioid medications, that is a no for a doctor to prescribe medications. In this country, and I have a personal history of my friends going through surgeries, cancer treatments, when they are put on opioid drugs and they cannot say no, because this is the case of treatment that has to be reimbursed. And to be reimbursed, it has to include opioid medications. But again, to sum up, we do not need to invent the wheel. Best practices are there. We just need to identify, qualify, and scale them in this country.
Which is usually not what we do. We
Exactly.
try to invent. Just since you're not from here, I'm going to give you that advice.
I also wanted to add to Sebastian's point on adherence. It's also important to talk about population health. It's not about one person adhering to medication. It's important for the population health, because what we're seeing now is multi-drug resistant tuberculosis in Eastern Europe. What we see now is reemergence of strains of HIV virus that are resistant to medications. Why? Poor adherence to medications.
Yeah, absolutely. So, Sebastian, you spoke a lot about adherence, which is very close to my heart. And, it's not only tied about patient outcomes and reducing waste and everything else. We're going into a new model of payment in the healthcare system, which is, physicians taking on risk, right? And the risk-bearing contracts and things like that. And one of the pillars is going to be making sure that the patient goes home actually is adherent to their therapy, because you can do everything right as a clinician, as a pharmacist, as a physician, give the right drug, observe, basically diagnose the patient correctly, have them come back, do all the right things, and the patient can go home and not take their medicine. So what would be the best investment that we can make in this area from your point of view?
Right. Well, generally, since, again, go back 50 years, probably because of the number of amazing drugs that have come out, the quality of surgery and other interventions, the length of stay in hospital systems in general has gone down to, from where you had a heart attack in 1960, you'd be there 2 weeks. Now you might be out within, 24, 36 hours.
And we observed that recently with Larry Kudlow, right? Yeah.
Right, exactly. He's back out at it,
right?
When you're in the hospital, try telling a nurse who brings you a tray of medication that you'll take it later. It doesn't really work. I've tried it just to see what would happen, and it doesn't work. And there's, that care when somebody's in front of you is obviously it's the best care, right? When a healthcare worker, clinician is in front of you and can take care of you. Our system's really expensive. We can't afford that right now. But in transitioning to this world where the facility is where you spend the least amount of time for a lot of really good reasons, by the way. In general, it's not a bad development. We have neglected this, the fact that the patient is now at home and they've got to do a lot of things, not even medication, right? So change bandages on their back, or understand whether the wound that they have is healing or not healing. We haven't perfected that by any means, and now, as value-based care institutes itself, and it's a slow process, correct, the risk is borne by hospital systems, in some cases physician groups, and they're going to have to have the tools needed, or they're going to have to invent the tools to manage the patient at their house, basically, or at the office, or wherever. And what investments can we make? I think we can we can put in place or remove regulatory barriers to having physicians work with the patient while they're somewhere else. Those can be telehealth related. The whole system of reimbursements is a problematic space because many of these remote monitoring applications, they haven't proven themselves, right? So it's really hard to say, reimburse for all sorts of these mobile health tools, including ours. It's really hard. The evidence basis is small right now. But we can let them operate under these value-based models and figure out what they have to do over time.
And there are certain ways, like you said, there's ways to sort of look into whether these things actually work, because you can bring the patient back in and do the sample blood test or something like that and see if it actually matches to what you see in the direct observed therapy. But what is the cost associated with that? I mean, that's been one of the biggest barriers, right, also to sort of implementing these adherence programs, because whether it's direct observed therapy or whether it's having somebody come to the pharmacy every month, it's costly to get them in and out of the system. Would you say, what is the cost? Is it prohibitive, or are we talking about, what are we talking about with regards to the cost?
Sure. So, so let's say where the incentive has been given, the solution has been found. So I'd say that refill rate has really dramatically gone up because there's been an incentive for it. If you look at public health, directly observed therapy on an analog, so just face-to-face basis, the estimate is $4,000 over a 6-month period of a TB regimen. So 4,000 divided by 6, what's that, like $700 a month, something like that? So, you know, what do we cost? We cost $50 a patient a month to do that. We cost more if we do the observation, but we're very early, right? And technology, other technologies may get there faster to bring, you know, the question is, yeah, we could probably knock that cost down by over 2/3, but it's early. You know, there's a lot of time left to improve a technology like this or other technologies. So the point is that the healthcare system should be focused on that, on bringing those efficiencies into play. And currently, it's not the case. There is no incentive to make sure that the patient takes their medication at home. We can't sell to opioid clinics because even, you know, we've found the very best in the business, and their hearts are in the right place. They want to treat these patients. They give them take-home buprenorphine. Half of them don't show up after 6-7 weeks. Yep. They're gone. They want to institute a system like ours. They can't get paid for it, but they have a cost associated with it. Why would they do that? I think that, you know, if there's an incentive, the solution's going to follow. Or if there's no disincentive, solutions can flourish.
Absolutely.
And yeah, cost, is it cost prohibitive? I think the other thing is, what disease are we talking about? If we're talking about opioid use disorder, I mean, $15,000 a patient a year is the cost of a patient with opioid use disorder. If they're in treatment, they cost 1/2 of that. We should have them in treatment and keep them there, right? Absolutely. This is the same thing with congestive heart failure, with asthma. I mean, you look just a few miles up the road in Baltimore, 1/3, 30% of kids in Baltimore City have asthma. 30%, that's crazy. They have, you know, of those, 2/3 have to take a controller inhaler. Do they do it? Like everybody else? No. Sometimes, maybe. They go to the hospital. You know, a good portion gets sent out of schools to the hospital every day. There are solutions for that if there's an incentive for them.
Absolutely. And I think one of the things, if you notice, if you go back and look at the reason why patients get readmitted into the hospitals, the number one reason is non-adherence after they get discharged. Because they're maintained and stabilized in the hospital setting. As soon as they walk out, they either can't get access to their medicine or they become non-compliant because there's nobody putting a tray in front of them and asking them to take it, right?
Right. And the risk is now borne by more and more by these health systems. So
Absolutely.
The solutions
So
will have
incentives.
to be, it'll have to be found.
So I don't want to hog the panelists, so I want to know if there are any questions. Oh, okay. Hang on one second. Let us get you a microphone. Thank you.
Hi. Ellen Milheiser with Synopsis Newsletter. Earlier this week, HHS Secretary Azar told a Senate committee, Senate Help, that he opposes percentage-based rebates for medications because it provides an incentive for everybody to just keep raising prices. He'd rather see a fixed dollar rebate. Dr. Weingarten, you mentioned, you know, this kind of thing. Would you agree to a fixed dollar rebate or to the physicians providing these biologics in their offices?
In short, yes. I mean, what we certainly need also is competition to try to grope towards what is the kind of the best solution. I think something kind of akin to what Sebastian was saying. But absolutely, the percentage markup is a disincentive. Medicare has already addressed that, right? Medicare, they have a percentage markup, but it's based on the reference biologic, right? So it doesn't matter if you prescribe a biosimilar or a biologic. Your remuneration is the same. And that's removing that disincentive. So absolutely, that would be a huge step. And in reality, if you think about it, the service that the physician is providing really has nothing to do with the cost of the drug, right? So they really should be, what's the value that they're contributing, and that should be what the compensation is based on. Whether the drug is expensive or cheap doesn't matter.
Thank you. Right there. Next.
Thank you. Eva Powell, Common Purpose Health. I think you all have mentioned really important points, especially about the incentive at the point of taking the medication, which I'm assuming you're referring to somehow finding an incentive for patients, and then also the public-private partnership. And that kind of brings up for me just the need for aligned incentives from top to bottom. And we've talked a lot about top, like the federal level and the large drug makers, and all of those are important. But what really gets at patients' motivations, which is key to, of course, the incentive, is that personal, which is, of course, much harder to define, much more individual, much more difficult to quantify. But people are in communities, so how do we incentivize communities and community-based entities that may help with this whole process? Because what I've seen as value-based payment has started rolling, which is very understandable, is the need to buy up everything. The large health systems, they kind of form their own insurance companies, and then they buy up all the hospitals' physicians. And while there's nothing necessarily inherently wrong with that, I think it's also inherently flawed that you can buy the solution to your problem or build it perhaps when the real solution already exists and it's in the community, and there's likely someone in that community that's providing the service or the nugget of that service who's doing it very well, who already has the established relationships that are essential for any sort of incentive, particularly at a personal level. So how do we advance and kind of speed up this value-based care notion by really starting to incentivize communities and community-based entities, whether that's a local pharmacy or a nonprofit organization that has established relationships? Because I think also you can't talk about patients in a sweeping way. Like you mentioned Baltimore and asthma. Well, I don't know the facts, but I suspect if you looked at the data, those are very concentrated in pockets that have lots of other contributing factors, that if you eliminated those factors, you wouldn't need the drug at all. So that gets at costs. It also gets at productivity. So how do we really, this is much more in the healthcare system issue, but it's the notion of incentives really has to account for all of those things.
So Oleg or Sebastian, you want to address those first, and then Wayne?
I think there was probably several topics there. One of those, in terms of community health, what I would say is, of course, I'm going to go back to directly observed therapy. I'll tell you the secret of why it actually works. This is proven in literature. It's not just the observation that you're watching somebody and controlling them. It's they have somebody that supports them, right? This is proven. So it's very meaningful to have somebody who's in touch with you potentially every day that helps you out. And that's not only in healthcare. Think about sports. You wouldn't train as well without a coach who's driving you in whatever field. It's very hard to train alone, let's say that. So I'd say that back to length of stay, back to less time in facilities, very tiny amounts of time with healthcare people. The healthcare workers are going to become more and more important because there's just if we're going to solve everything with docs and nurses, there's just not enough of them. And a lot of what we need is high touch with the patient, actual time with them. And not all that time is about, what's the best medication for you. It's, have you taken care of this? Do you need this? Do you need that? And directing them in the right way. How you can give an incentive for that, I don't really have the exact answer, but we do know that I think there's no way around more people involved in healthcare, as the issues are quite diverse. And but if we're talking about incentives with patients, I would also think and maybe this is an economic, question, fact is, if patients pay less for care themselves more and more, what incentive do they have to do something that's really actually not fun? Healthcare is not fun. It's not entertaining, and it's also something people kind of want to avoid because they don't like the idea that they're sick, right? So what are the economics when patients aren't paying for it?
And I think you're right. It is kind of a multifaceted issue. I think one of the core things is the disincentives of the fee-for-service kind of model. And so, if we can start experimenting with other types, other options for like general practitioners and other ways of kind of working the system and interacting differently, you're going to get different incentives. And removing a lot of the disincentive. I mean, part of the problem is having kind of nurse practitioners or doctors being able to communicate freer with patients, having the time to do that. So I think if we can move more towards a value-based outcome as opposed to fee-for-service outcome, you're going to start addressing some of those issues as well.
Oleg?
Yeah, I wanted to say that if you look at, in Europe, for example, there are schools of patients, which is informal communities for patients with diabetes or other diseases, where there is peer pressure from other patients to take medications. They monitor each other. They see that, oh, my friend took the medication, so I need to take the medication as well. I think these patient communities should be incentivized to exist in this country, and I think there are very few communities that actually function.
Gentleman back there.
Yeah, thank you, panel. Great discussion. My name is Arnold King with King Consulting Solutions, and I had a question. Number one, what kinds of target reform that are involved that relate to medicines such as pills, asthma, and others? And number two, how is regulatory uncertainty and market also play a role in dealing with fields such as drugs and specialty pharmacy?
So what are the regulatory barriers, basically, that we see from doing your work, Sebastian, you think, that can help out?
Yeah, what was the regulatory barriers towards what? I heard.
That relate to fields, drugs, and specialty pharmacy as far as the medicine is concerned.
So some of the work that you want to do,
Yeah.
What are the regulatory barriers towards the work then?
In Medicare, you can't pay a patient to do something. So now if they don't pay for their medication, like if they paid for their medication, you could give them a discount, right? But if they're not paying for it, on the economic side of things, you'd have to pay them, right? So you can't do that in Medicare, really. You have to announce that over a year in advance. So that's one thing. Another big regulatory barrier is introduced by the fee-for-service model in general. A doc or a nurse cannot provide service remotely because we don't have a framework for reimbursing that. So I wouldn't argue that you need to reimburse that. I'd argue you need a value-based system. So in terms of, interestingly for what we do, most states allow directly observed therapy to be done remotely because they used to do it in the 80s with those phones that you would sit on your wall with a little video camera. That's how they used to do this in the 80s when in like Alaska and Washington State when they couldn't see the patient. So a lot of those things have been already baked into regulation and need to be adjusted a little bit.
Okay. What are the solutions? Do you think that they can be, are they going to be addressed through like any kind of regulatory change that needs to happen, you think?
I would say one very big solution. In general, I think value-based care is going to be a great thing for patients' health. A second thing I would say is that we have to be very careful with the incentives that we provide to the healthcare system. As an example, congestive heart failure patients who are readmitted within 30 days, you won't compensate for that. Okay, we know that killed people, right? In the same way, when you say that medication adherence equals whether the patient has refilled you are giving a huge incentive for opioids as well, for really bad things to happen. Adherence should be, there should be no dispute on what adherence means. And actually, though, if you look at literature, it's really hard to find out what does it mean because everybody's dancing around this problem. Fact is, there is a prescription, and adherence means the extent to which a patient fulfilled that, right? And that should be the definition of medication adherence if there's going to be one that has an incentive tied to it. Yeah. And we cannot continue to say that adherence equals something which it's not.
Which is not. Well, yeah, we want to go to, we'll come back to you 1 second. We have other people that have questions. So why don't we come here and then we'll go to the lady.
Thank you. Stephen Eldner with Mercer. Sebastian, this is a question for you, and I'm thinking of this in the context of incentives that are typically offered in wellness programs, and we see financial incentives as popular to encourage people to participate in wellness, and even with financial incentives of some magnitude, we are probably getting somewhere between 50 to 60% of the eligible population to do things that are good for them, that would make them feel better and be better. Now we're talking about getting people, and let me also say that there's a shift in thinking, or at least a movement toward less reliance upon those external motivators and more on intrinsic motivation. Do it because it's good for you and it's right for you. Now, if there isn't a strong, compelling case for people who are dying to take their medications, how much more are we to expect that financial incentives will increase that rate of uptake? Given that it's only 50% in a population who's doing something that's somewhat pleasurable.
Right. Well, financial incentives being one motivator that works for some people, right? Obviously, kids with pediatric asthma, they're not going to, money's not the way, right? We don't need to pay kids to take their medication. We need to tell them to do it and make sure they do it. I would say that you're not going to get intrinsic motivation from everybody, and you're probably going to get it from some people, right? And those people are probably not the people we're worried about, right? The people who are intrinsically motivated are maybe the 50% that are already taking their medication. We're worried about the other people who can't from intrinsic reasons do it. And their motivation is quite diverse. Money might attract a few people. Community contact with other human beings who care about them, like having somebody who cares about you, whether it's medication adherence, whether it's wellness, whatever it would be, that other people care whether you go to your wellness program, whatever that would be, or that you ate the right, thing for dinner tonight. Having other people care would motivate some people. And the fact of the matter is that to the extent that the system, the health system, bears the risk of figuring out what exactly that is, I think we'll be in a better place. Because in the fee-for-service model, did people care? Yes, they cared in theory, but not enough to make something happen and figure out what it is that motivates people.
I also think when we talk about employee wellness programs, it's carefully crafting both the incentives but also the disincentives, right, in terms of bearing the cost of your actions. Yeah. And sometimes it's not the financial incentive that will motivate, but it's that I have to bear those costs myself that will change behavior.
Well, I'll give you one. I think we've all of us agree that fee-for-service is really not a best motivating factor. I was at a pharmacy recently and observed a pharmacist talking to a patient for the first time that I've seen, telling the patient that you're going to go home with this medicine, just we change generic suppliers and the medication is going to look completely different than what you've taken before. That pharmacist doesn't get paid for doing that, but they should be, right? That should be what they should be getting paid for, not filling the bottle with the pills. But so the incentives for that professional is also not aligned. Any other question? Yes, sir.
So I have a question. In the case of opioids, we know that there's a lot of opioids prescribed that don't need to be. My wife had a root canal. The dentist prescribed before the root canal a 30-day prescription of opioids. She didn't fill it. Is opioids the only prescription where that's a problem, or is that across the whole continuum? And by having people if she had been adherent to 30 days on opioids, that could have caused some real problems. I'm glad she didn't take them. But is it the only medication where we have that problem, where reimbursements based on the fact that he had to prescribe 30 days in order for the insurance to pay for it. How perverse or how prevalent is that issue of the prescription may not be appropriate?
Oleg, you want to address that?
I think the problem is pervasive with other medications as well. It's just other medications do not lead to physical dependence and then addiction. That's the answer.
But look at antibiotics, right? In the whole antimicrobial resistance, and that's a growing problem. Which is a global crisis. So, and you have constantly where you don't really need as much, or you don't need antibiotics at all, but they're being prescribed. So that's another example I think that's important to address.
So the prescription's not that you have to take your medication, 3 times a day for 30 days. The prescription is likely to be taken as needed. That's what you're supposed to do, and it makes it a very complex case. So you are given an oversupply, is the point. But if you follow the prescription, you're not supposed to take all of it. The problem becomes it's subjective, and now it's no longer the prescribed, because we're talking about pain, and pain is supposedly a subjective thing that you can't scale. You ask a patient, it's 1 to 10, but every patient's going to have a different tolerance. So I think that it is a massive mistake. I had a 15-year-old broke his arm and was given, a 14-day supply of opioids. I mean, it's scary, right? So it's not really there. We want adherence to as prescribed, but you just don't want these patients being given that kind of supply. The demand is not there. So on the econ point of view, the demand is not and the supply don't match each other. It's something very wrong and bad recipe.
And there are multiple reasons, right? The reimbursement system is a reason also, because patient can show up with a 30-day prescription to a pharmacy and not want the entire 30 days, but the way that the prescription benefit plan is written, they have to get all 30 days. If not, they have to pay out-of-pocket cash. So the motivation is for them to get the entire 30 days to pay either the copay, which is less. So, any other questions or comments? Yes, ma'am.
Hello. Mr. Seiger, so you spoke about adherence problems and the role that direct observation plays in making sure patients take their medicine. I'm hoping that you could also address what role, if any, the actual price of the drug plays with adherence problems, particularly if a patient can't afford the out-of-pocket costs for that medicine.
So drug price, obviously, quite a complex topic. A couple observations. First, the first thing that bothers me is that if the prescriptions are correct, and the docs and prescribing nurses are ethically required to prescribe what the patient needs, it's not about the price. 50% is wasted. That has an effect. That should have an effect on price in a way. But at least if the demand matched it, so patients took what they were supposed to, then they'd be better off from the healthcare point of view. Drug pricing and adherence in general, I would say, I think it's almost outside of our scope in a way, because we're more concerned about the waste itself. We're concerned about the health outcomes related to med adherence. And I think that if you look at the most expensive drugs that we have right now, let's take Harvoni for hepatitis C. Gilead will provide almost complete copay coverage for those medications, right? Or HIV medications, it's almost the same thing. People are getting their medications in some of those cases. It's the problem of the people who really don't, are right at the border and they don't qualify for some of these programs. But I think that pharmaceuticals have realized that in a lot of cases when they cover that copay, the patient is then, they can survive off the 80% of the cost that the health insurance company is going to cover. So, complicated topic. I think matching demand and supply is a first step to understanding where prices should be. If it's in their financial interest to make sure patients get it, which it is, right? So they're not going to be they're not going to be paid for medication that isn't filled. So, again, the whole system is quite unusual in that there are organizations out there, PBMs, for example, whose full incentive is to make sure that fill actually happens. I don't think it's on the manufacturer here, right? Like, manufacturer produces medication. The rest of the system delivers it. The whole system has an incentive to make sure that the patient's filling it. I think that's a bad incentive to have. But in terms of covering copay, I mean, do you want patients to take your medicine, to take it? Because otherwise they're going to only fill about half of their prescriptions or even less. So.
I think it's a two-pronged approach. That helps the patient take the medication home, but then we need programs like yours to make sure that the patient actually takes the medicine. Right. Taking it home and taking the medicine are two different issues.
Absolutely.
As a pharmaceutical industry expert, I think what we need to do is address the out-of-pocket affordability issue of medicines in this country. And it's a very complex issue because it's not just about the pharmaceutical companies, it's about a lot of different people in the supply chain.
And maybe an analogy that's not entirely fitting, but college education is very expensive right now. You can get loans and have support in order to be able to afford it. You're going to have a debt later in life from that. So sometimes when everything becomes affordable, the consumption increases. Yeah. That consumption, though, is not necessarily actual consumption in your mouth with a drug. It's you have it at home.
Yeah. Any other? Well, we're over time. Sorry about that, Michael. We had a lot of questions. So I really appreciate that the panel came this morning. Thank you very much to the U.S. Chamber for hosting us. Thank you, panelists.
We're going to take a quick 5-minute break. If you don't know each other, this is a great time to network and figure out who other people in the industry are and how you can become allies in the future. That's one of the reasons why Chamber has convenings like this. So we're going to take a quick let's do a quick 5-minute break, refresh, and then we'll get the other panelists up here. So thanks.
Ladies and gentlemen, please welcome Danielle Turnipseed, Vice President, Government Affairs and Policy, Solera Health, Inc. Karen Tab-Dina, Assistant Professor, School of Social Work, University of Illinois at Urbana-Champaign. And Samira Howard, Fitness Influencer and founder of Fitness is Fundamental, with moderator Adam Beck, Vice President, Employer Health Policy and Initiatives, America's Health Insurance Plans, AHIP.
Thanks so much, and good morning. Thanks for being here for this discussion where we're going to dive into a number of issues affecting dealing with social determinants of health and how different communities, when it comes to community health and population health, how we can, particularly in partnership with the business community, target wellness and focus on fitness and nutrition to really reach a lot of the end goals that we're looking at and exploring today when it comes to chronic health. And I get to be up here with another fitness influencer, so that always feels good. Since we just did brief title introductions and you've got bios in the booklets with you, I want to go right into the discussion since we've only got an hour. And first kind of frame the conversation with getting a sense about how this conversation is different when we're talking about interventions for individuals versus interventions for a community. And I think when we talk about a community, very often it's in the singular sense that we refer to a particular community when in reality, I feel as though there's usually multiple communities, sometimes with differing interests, oftentimes with aligning interests or aligning disparities that we may see. But we've got multiple communities, often with a great deal of intersectionality, and that gets missed in a lot of these conversations. So my first question, we can just go down the line, or if someone is really eager to kind of dive in, I want to explore how we should be thinking about communities when it comes to health factors, when it comes to social determinants, and do you think that approach is different when we're looking at a community as a whole versus what the intervention should look like when it's provider to individual, when it's focused on a particular person as opposed to at the macro level. Danielle, I don't know if...
Boy.
You know what? This is what you get for sitting next to me.
In the rib.
Yeah.
No, the question that you're framing, and also the panelists, I can't underscore the need to pay particular attention and dive in when we're talking about community. We can identify a problem, whether it's heart disease, diabetes, but how we're going to go about solving that really does drill down into, who would we like to target specifically. So dealing with diabetes prevention or diabetes in women or weight loss or obesity or cardiovascular, what are the women going to have to do to affect some change? Is it just going to be working out for an hour? Or are they having, job and family and other responsibilities to deal with? Well, the support system for, a group of women in a community who are undertaking an attempt to improve their health, improve their own life first, even before they consider doing it for their family, it may be different than how, let's say, a male may approach it. An hour in the gym for him versus hour in the gym for her. I'm leading so that you can pick it up, because I am no fitness expert by far. But we also have to consider some social concerns as well. As healthy eating and healthy lifestyles are important, it's not enough just to say what people should eat. We have to consider cultural factors. We don't want to impose a typical, sectional plate without being sensitive to maybe a Caribbean culture and staple foods that are involved, or an Asian culture and saying absolutely cut out all of the rice, or we have to tailor our approaches to the communities, but also be sensitive to the factors that members of those communities are responsible for dealing with.
And I'd kind of like to piggyback off of what you were talking about communities. Specifically, I always focus on women in fitness. And since we're talking about social determinants on this panel, a lot of research has proven that women, we are social creatures. We are social eaters. More than likely, if you're out with your friends and you're not really hungry and your friends want to eat, you're probably going to eat something. You're going to order something. So what I've found working with women and girls specifically through my platform, Fitness is Fundamental, is that we support each other. And if you have a group of friends that loves being active, where everyone decides, hey, we're going on a walk today. Who wants to come along? Accountability partners. I have my accountability partner group text right now. But with women specifically, when we talk about our community, that social factor helps tremendously.
So I want to then kind of move the conversation towards thinking this in terms of kind of three phases. We've got, I think, a look at what are some of the problems that we're talking about, what are the sources of those problems, and then hopefully we can get into what are some of the possible solutions or interventions for those problems that we've identified. So I'll start with Karen, and just a very simple question that hopefully then can spur some conversation. What do you think is the biggest problem, the biggest public health problem that we have today?
Sure. I love that the previous panel mentioned opioids. I think we should even take a step back and talk about health disparities. So there's differences in health outcomes by group status, group membership. So we mentioned some about gender differences in health outcomes, but there are also extraordinary differences by race and ethnicity. If you allow me to make a point of history as a professor, let's think about our country. In the United States, we are changing. And as Americans, we embrace this. We're constantly changing. In the last 20 years, we've experienced a demographic shift in terms of immigration, people coming from different countries than in the past, and shift in how we categorize race. So these shifts are nothing new. 100 years ago, we had individuals coming from Eastern Europe, places like Italy, and we as a nation didn't know how to call these people. Are they white? We don't know. They're ethnics. That was the category at the time. Since 2000, the US Census has decided, let's allow people to categorize themselves, and started to allow for 2 or more races as a selection on survey instruments. This changed health services and the way that health systems gathered information about race ethnicity. With this, we're starting to see new patterns emerge in disease and disorder, and this affects a younger age population. So 50 years ago in DC, so if you're local, this might not be news to you, but it was illegal for 2 people of different races to marry, just 50 years ago. Since that shift, when the Supreme Court ruled this practice illegal and people of 2 races could marry across the country, we've seen what is known as the biracial baby boom. So these are individuals who were born in the late 70s, 1980s until now. This is the workforce now. It's a multiracial, multi-ethnic group of people. And we don't know what their health needs are. So you said, what are they? Recent research, and some of my research, is starting to look at the patterns of these folks as a racial and ethnic minority group of persons of 2 or more races. And we're learning that individuals of 2 or more races are more likely to be obese, less likely to have a primary care doctor, more likely to experience diabetes and early onset of diabetes, more likely to avoid care when they need it, so we call this unmet need. And these are just a few of the serious problems facing this population. So when you ask me what the biggest problem is, I think it's our lack of reporting as a country. So when we report health statistics, we usually focus on black-white differences and even exclude Asian Americans because we say, well, it's a small group. It's only 3% of Americans. But we need to start looking at the nuanced differences across all groups in our country and to identify what those health problems are so we can identify how to best address them.
Okay, so reporting. And reporting of health information.
Sure.
I want to come back to that then.
Reporting, accurate surveillance, and making sure that we keep those smaller groups in, such as American Indians and Alaskan Natives are seen as a small group, so they're not included in some health research, and we know this group has the greatest health need. Pacific Islanders, Native Hawaiians are often not included in health research. We know there's great health need, and so maybe we could tie that back to diabetes being one of the major health burdens that we're seeing and one of the most costly health conditions that we're dealing with for minority populations in this country.
I'd like to pick up on that point and focus on one of the issues that my company, Solera Health, works on, and that's diabetes prevention. The prevalence of diabetes across this country is astronomical. We're approaching more than 80 million individuals who are at risk for developing diabetes. And the problem is so huge, especially with the amount that federal programs spend on treating diabetes, that it's imperative that we take a step back and figure out how to prevent something. So it can be a chronic condition, but it's also preventable. And, you know, mixing what Karen talked about, you know, when she talked about the Loving decision, I'm a lawyer, so I knew I'm picking up on when she talked about the ability of individuals to marry across races, and then she discussed the census. That's before we even talked about anything health related. That's politics. That's policy, rather. So getting, you know, recognizing that there's such an intersectionality between policy and the impact that it has on communities, I think that cannot be underscored, and we see that with what gets the attention. Right now, the previous panel talked a lot about opioids. That has the attention. But, you know, what's the last story anybody has heard about wellness on TV? What's the last story that someone has heard about preventive health or wellness, WellState care? You know, we just aren't focused on necessarily all of the right things. A lot of times we're in crisis mode, so we deal with an outbreak and an epidemic. Think about, you know, when we've had to deal with Zika and Ebola. things that never touch the majority of the communities in this country, but all hands on deck, deploy people even to foreign lands when we've got problems here that we know how to deal with, that we, have viable ways of addressing, but the focus just isn't there. The scale continues to go up in terms of, average BMI, average weight, even for children. It's okay now for kids to be a little pleasantly plump, even if they're in school, gym. And before I pass the virtual mic, I did want to say that one thing that I would add, maybe from your analysis with you talked about the mixed individuals, we have to think about the isolation and the socialization that goes with some of the conditions that people are experiencing. The other panel and the questions talked about community. Well, by and large, people tend to form community when they have some similarities, and if we're forced into community where we have differences, do those differences bring us together or do they separate us apart? So again, if I put women and men in a group to lose weight and to exercise, are the guys going to share their favorite recipe, or are they going to bring in, a food to try, or are they going to skip that class? Maybe they will. We don't have to necessarily conform to gender norms, but speaking to Samara's point about finding that network where there's comfort and finding that network where there's support, that also gets to the very social fabric that we're seeing, play out in our communities and in our countries.
Yeah, and you guys are talking about reporting the numbers and policy, and let's tie this back into community. I think for me, especially since I'm always working with girls and children, I think reaching our youth is the preventative measure. That's where it all starts. If you're teaching your children at a young age that it's important for you to be active, that it's important for you to, eat correctly, that carries throughout the rest of their lives. When I was younger, we played sports year round. My parents made sure I was in a sport every single season. And my parents are from Georgia. My mother grew up on a farm, so she grew fresh vegetables in our backyard. So I love veggies, but I know a lot of people my age, women especially, who don't pay attention to eating a vegetable every day. My mother's rule was one green thing a day. That's what you have to do. And I also want to touch a little bit on my personal experiences. So I coached a Girls on the Run team. So I work with Girls on the Run DC. We recently had our 5K last weekend in the rain, but it was fun and the girls truly enjoyed it. But in the classroom setting, before we would go outside and practice, some of these girls, and this was in the inner city, probably, I was working with Kip Quest Academy, and we're getting ready for the 5K, and one of the girls says, my mama doesn't run. Are you gonna run with me? And that stuck with me because they don't have examples. If we're not, especially businesses, if you're not providing programs for your employees that, tell them, hey, your health life is important. These things will go with your employees, translate into their homes. Their children will learn to understand that it's important to be healthy. But, that kind of broke my heart that she doesn't have anybody at home to be an example of, just living a healthy lifestyle or fitness. So that's what I've dealt with specifically, but the youth are so important to me. I think that's where we need to get to make that major change, is focus on the children. That's why.
So with that, and both you and Danielle mentioned youth, mentioned children, with this conversation largely being about workplace wellness, at that point, if we're looking at someone, whether they're earlier in their career, midway through their career, this may sound overly pessimistic, but is that too late? Are we, but I guess then one of the questions is, are there ways, even within the business community, that we can focus on children, be able to reach children and put out information or resources or tools or opportunities to encourage different lifestyles and different fitness opportunities or nutrition or whatever it may be at a younger age? And what kind of difference do we think that would make versus a lot of the programs that we see in the workplace that might take someone who's 55 and offer them some sort of incentive to participate in a program where is it a situation where the diminishing rate of returns is just not going to really affect the costs and change that we're looking to actually affect?
There are definitely people probably in this room, other places, who know about the workplace wellness and fitness opportunities. But I think that we probably all could admit not much gets started before 10 o'clock. You get your coffee, you get your donuts. The opportunity to bring learnings and wellness and to integrate that into the workplace, it's there. It's there at 8 o'clock in the morning if you want to have a breakfast wellness group or a walking group. There's no reason why the first meeting of the day has to be seated or on the phone. Encouraging your employees to wear sneakers at work. It's okay. Because you're sitting under a desk, and if you wear sneakers, you can take the stairs more often. What are we there for? We're there to get the business done, but we're going to bring in a diabetes prevention coach once a week, during lunch or during a time that we poll to say, it works to have it at 3 o'clock before you get ready to leave, or at 4:30, so that you know what you're doing before you get ready to drive home and interact with your family. I think to the extent that businesses recognize the need to be proactive for their employees, and they exercise a real commitment to it. So it's not just posting something in the break room, but if someone is in charge of inviting a food truck, make sure a healthier food truck is available. Or you don't have to stock the break room with sodas. It can be with fruit instead. There are definitely things that businesses can do. Another instance is to incorporate actual wellness programs. Allow your employees to get involved in wellness activities, sponsor them, bring them in, include it as a benefit, and not just bury it, tout it. Have a team goal for your races that you do. Sponsor the $25 registration as an employer and see if employees might want to participate. And it's not necessarily to, promote that someone has gout or is facing an amputation or probably needs to go on dialysis. No, this is a wellness state. This is what we're doing to enable our workforce, whom we value. If we value, we made an investment to hire you, we appreciate the work that you're doing, we have to be concerned. We have to be concerned with your well-being because you're a part of our team. Now let's show it by the opportunities that we offer our staff to be well.
I don't think it's ever too late for people to start a fitness journey. I tell people this all the time. My mother is in her late 50s now, and she's lost about 40 pounds just walking. Every single day she just walks. I think that in your social settings, it's great to share exercises that you like to do. I always tell my friends who aren't runners, I like to run, but a lot of people don't necessarily like to run, and actually, running is horrible on your knees. So I tell people all the time, hey, you need to get out and walk. All over the world, people walk places, they don't always have cars to go everywhere, so they'll walk. So at work, on your lunch break, grab somebody and say, hey, do you want to take a walk around the mall? It doesn't take long. And I think when it comes to fitness education, I think there are a lot of misconceptions out there about what you have to do to remain fit and healthy. You don't have to do an hour of cardio every day. That's actually overtraining, and it's really bad for your body. Between 20 to 30 minutes a day, that's fine. Between maybe 4 to 3 days a week, you don't have to, be The Rock. Like, you don't have to, be Allison Felix. You can just live a normal, healthy lifestyle, and that's fine. There's no pressure here. Really, we just want your heart to be healthy. And so I always suggest walking. If you don't like running as well, you can try Zumba or aquatics. Like, water exercises are wonderful. It's not as harsh on your body, especially if you're recovering from injuries. There are so many options out there, and I think that fitness education needs to be taught in schools so that children, again, I'm always going to go back to the kids, know that they have options in terms of being active. And if employers taught their employees that there are options out there as well, I feel like more people would be willing to be active. And then research has also proven that when people are healthier, they're happier. So if you want a happier staff, add some ways for them to be active throughout the day. Like, I know when I have my morning workout, I come in and I'm touching the sky. Like, there's nothing you can tell me to bring me down. And that's because of serotonin, the happiness hormone, which is released during exercise. But yes, I think that employers have a huge responsibility when it comes to offering people educational resources. I know at my job recently, we had someone come teach us Tai Chi. I was all there for it. So yeah.
And I think this is a good place for Karen to kind of start. I want to transition a little bit away from fitness and talk about social determinants. And I think too often, this is a conversation, I know within the insurer community that we're, I think, very thankful that we're having this conversation a lot more now. But it often, I think, too often focuses either on the Medicaid population or the Medicare population. And very often it's almost strictly on the Medicaid population, which I think presumes a couple of things. Number one, that the Medicaid population isn't working. But number two, that working individuals, including those who may have employer-provided health coverage, as well as obviously those who are working and lack any health insurance coverage, that they don't encounter many of the social determinant issues that we, I think, too often associate with the Medicaid population. And so that, I think, puts a bit of an onus on the employers. How much, what sort of different social determinant issues and how much of them should be within the domain of employers to address?
So I would love to jump on that question. In research, the way that we use social determinants of health is very broad. We're in a like-minded audience where you might understand these things very well, but for point of definition, social determinants means where we live, work, play, and worship. So as humans, these are our daily experiences that are shaping our health. They're either promoting our health or impeding our health. So we're looking at where someone lives, with the opening from Michael Billett talking about geographic location and how that results in health outcomes, to namely insurance status. So on the public health research side, we're looking at insurance and access to private healthcare insurance as one of the major protective factors for health and wellness. And employers play a role in providing private health insurance as the number one form of insurance in this country, or ability to access services. In terms of not having insurance, we know, especially where I am, that there are more risks for not being able to access mental health services as there are when someone has private health insurance. They might have more access to care. I mention mental health because I want to introduce it in this discussion of social determinants of health. In public health right now, we're looking at mental health as one of the major risk factors for enduring a burden of disease that is in excess. So this means individuals that are struggling with things such as depression, anxiety, bipolar, maybe self-medicating with opioid, I'm looking for our previous speaker, are going to be the higher users in the system and have a greater risk for loss in productivity, a loss due to missed days in the workforce as well. So those are some of the major factors that we're looking at within social determinants, again, where you live, work, play, and worship, and how those things are making us sick or healthy.
I mean, look at the incidence of violence in communities. And if you don't have a safe place to walk, you said your mom walks. If you can't go outside your door and walk a mile from your house, 2 miles from your house, if your kids can't go out and play on the basketball court or the baseball field, then they're going to be at home, they're going to be inside, maybe on the couch, and they're not, if they're in an unsafe environment that prevents them from exercising, without going to a membership gym, without going to a place that is restricted by hours. If our communities aren't safe, one, for the physical aspect, but for our mental aspect. When can I go out to buy groceries? Can I buy groceries and bring them home and walk home? Think about economically depressed areas. So the places like that don't have the boutique grocery stores moving in. Why? Because it's an unsafe area. It's the bodegas, it's the corner stores, it's the fast food, is plentiful. You don't have to go too far. You can look in the district and see a map of what's where. And there are pockets and communities that are left out. And couple that, I imagine if you would lay on top of that the stress, the mental health issues that are probably prevalent, not just in those communities, but those children. Those kids don't have a place to exercise and to be active. So, the social determinants, when we're talking about health, you don't have to look very far to find the interconnection of them. And then there's also the whole aspect of economics. Not having enough to make ends meet is quite stressful. And, what do people give up and go without when they're faced with housing and transportation costs? These are definitely things that impact health.
As a model, so we had a research study a number of years ago, and I'm going to mix that with the model that we have in our local public health district, which is one of my research partners. We have diabetic patients, I shouldn't say that, persons with diabetes that are given a treatment regimen to change their food, their diet, and to adhere to medication treatment. So part of their treatment is all-encompassing food, diet, medication. Patients are left with that advice, but they go home back to the same systems. So they're embedded within family systems and with community systems where they're set up to fail. So for the intervention on our research side to be effective, we have to address the family. The whole family is now going to have to adhere to this diabetic regimen of treatment for it to be successful. The whole family is going to have to adhere to exercise. In one study in Detroit, they didn't have sidewalks in many of the neighborhoods, and then the ones that had sidewalks didn't have lights. And you're instructing people to walk in a Michigan winter at 5 p.m. I'm not going outside in the dark to slip on ice and to dodge cars, right? So someone in their normal mind isn't going to listen or adhere to that treatment. So we have these all-encompassing systems approaches. Those same strategies are taking place right now with my local public health partners who took an old storage room and made a gym, I think maybe to improve workplace wellness. They set up a community garden. So there's the mental health aspect of going outside, touching the earth and the land and gardening on your lunch break. Yeah. But then you can also take home these fruits and vegetables. The produce they also leave out for their clients and provide cooking demonstrations for clients who may not know what chard is or how to use kale and arugula or rutabaga in a salad. So they do these cooking demonstrations for their employees and for the clients that they serve. So it's a systems level approach to addressing these social determinants that's in combination with the provider as the workforce and the patients or clients that they're serving.
As the previous panel discussed, around medication adherence, if you want anyone to make a lifestyle change, you're really going to have a good coach and a good community. And, as you mentioned, the vegetables, if you want someone to drink a smoothie instead of eating bacon and eggs in the morning, you might need to see if they have a blender or, a $20 blender and the fruits and vegetables to go in it. And let's not discount the fact that for people that haven't tried this way of eating or this way of living, it might take them participating in a diabetes prevention class where we talk about vegetables and other ways to eat and giving a sample, because people aren't going to spend their hard-earned money on, you know, what's that? I don't know what Swiss chard is. I'm not going to buy bok choy. Why would I eat that? I'm not wasting my money on that. So, you know, part of it is exposure, as you said, with the young girl whose mom didn't exercise, and the same holds true with healthy lifestyles, with healthy eating, being able to sample an item to see if you like it. It goes a long way. So these are small, tangible changes, and that's also something that the employer can do. The employer can put out a healthy option, explain what it is, you know, give us some feedback. Did you like it? We might carry it in the cafeteria. We might offer it, you know, certain days of the week. But we've really got to dig deep and guide people. And the community factor, community aspect of it really can't be underestimated either. There are in-person options, community-based options. There are always, you know, virtual ways where you can log on to any YouTube video and figure it out. It may work for some people's lifestyle, but I'm sure that the gratification that individuals feel crossing a finish line and seeing, you know, people who have supported them, or even when you hit a slump, you know, come on, get back. I know it was a hard week. We can do it. You know, just get back on track. The aspect of communities for the things that we're talking about really cannot be underscored.
I think, and I want to touch a little bit on, we're talking about community and social determinants still. Poverty is a great threat to health. And I think that, I mean, even when we talk about the Farm Bill, if we cut funding, especially to schools, when it comes to supplying our children with healthy foods and, you know, just options like one meal a day, because a lot of kids go to school to eat. You know, they don't have, you know, that option at home. Like, so I guess what I'm trying to say is unemployment and poverty, of course, go hand in hand. And, you know, those families are suffering, like they can't even buy groceries. And so we need to tie this into our policies as a nation to make sure that we are taking care of one another, period. It's as simple as that to me, really.
Let me just say, one of the aspects, you know, for the panel that was here before, for whatever condition that they might have been describing and a prescription for a drug was written, you know, how often does your physician say, in addition to this 30-day supply of pills, you need 2 fruits a day and you need something green every other day? I mean, when do you get a food prescription? When do you get a directive of how to eat? And for the benefit of your health, you're enabled, whether it's through, you know, medical flex dollars, through coupons, through some discount program. I mean, if you think that this bottle of pills is going to be all that it takes to get you from sickness to wellness, you're probably mistaken. Do you need to cut out something? Do you need to add something in? If the answer is yes, then why aren't we using our healthcare system, our healthcare dollars that we as employees either set aside or pay into insurance to allow us to buy and access what the doctor ordered? The doctor ordered, you need to eat better. The doctor ordered that. But can the doctor write a prescription? Can a doctor help me get the kinds of foods that I need? For some people, it is very specific, medically tailored meals, but for others, it isn't. And, you know, my organization has partnered with Feeding America because we realize we just can't be focused on preventing diabetes, but we've got to find those other supports to deal with the social determinants and make those real connections to kind of see people through a continuum.
Can I ask her a question about that?
Okay. Absolutely, phone a friend.
So, phone a friend, yes.
Switching roles.
Yes.
Well, so Adam, you asked about the Medicaid population, right, with low-income Americans. Mm-hmm. Where I am locally, the FQHC is a model for integrated healthcare. I'm a champion for integrated care, reducing costs, improving access. They assess individuals for food. They give them a food prescription, like a bag of food tailored around their needs. If they are experiencing pain, they have dental co-located. They have psychiatry co-located. It's a one-stop shop. You might be there all day if you're a mess, but it's all provided. And I look onto those programs, right? Most of my subjects in my research are privately insured, and they talk about barriers to care, and they're not able to access that level of integration. Do you think we're going to see a shift?
I hope we do.
And what does that look like?
I hope we do. You know, the strip mall model where you've got the stores, and on occasion you might have a patient-centered, location. We've got to do more integrating pharmacies into supermarkets, integrating, what people need to get better, and a lot of it starts with that medical home, but is it open 7 days a week? Is it open while you're at work? Off hours medical clinics that aren't just dealing with like the urgent care, but I'm on the way home, and before I go in, I need to have something checked. Why do I have to have, an appointment for that? Even if there's a copay, but, tell me what it is so I don't ignore it, and I don't have to take off work to sit for, to travel to and sit for an appointment. I mean, we've got to find ways and use those models, like you mentioned, for FQHCs, federally qualified health centers. Unfortunately, we're so siloed that even something that works well is for, either rural individuals or low-income individuals, and you wouldn't get someone with commercial insurance, one, being able to access it, but two, thinking, why would I wouldn't go there. I wouldn't even know that exists, or that exists for people, unlike myself. So we've got to find a way. And I think like I said, some retailers, some grocery stores are thinking about a more integrated approach.
Like a minute clinic?
Like I don't want to call out any
brand?
Any brands in particular, but imagine when you go in and you've had you're facing a health challenge. Being able to drop your prescription off while that's getting filled, shouldn't there be someone that says, oh, you're dealing with prediabetes? Let's be sure that we get you some foods that are low in fat. Let me walk with you because I'm a registered dietitian and I work for this supermarket, just to put in your mind what the doctor said into practice. How do you know with this big old store what to buy? Or if you're going to pull something off the shelf in a can, let me show you, we have salmon over here that's fresh, or we have an option that's fresh. You don't have to necessarily buy everything that's preserved. So put a dietitian, put a RN, put someone, a nutritionist in the place where people are buying the food.
So I feel like, we've identified a number of the problems that we see out there, and also gotten into some of, some very, whether they're individually focused or on a large scale, things that we can do about them. Samira, you mentioned federal funding and public policy. What sorts, along those same lines, what sorts of obstacles do we see to actually tackling these problems? Because it seems like we know what a lot of them are, and we know what can be done. Maybe they're not panaceas, maybe they're not going to change everything for everyone or overnight, but we know some things that can be done. What are some obstacles that we're running into at the local level, federal level, as people, as individuals?
I think we touched on this at the beginning of the panel. The greatest obstacle is, people not caring about, integrating health into, health practices into society, and specifically, we're talking about businesses and companies. If the people up top don't think it's important, then of course they're not going to figure out a way for funding to make it towards that specific realm. So I think that, just like you said, like we have a ton of stories about violence, and of course that's important, and we have the stories about opioids, of course that's important, but we need to push the message that, hey, like overall wellness is, imperative in American society today. So to me, that's the biggest thing. And I think that one of the most important offices in American society is the Office of Citizen. So if you, in particular, want to voice that opinion to your, employer and tell them, hey, like, health is important to me. I feel like it should be important to my coworkers as well. People need to speak up, and health professionals need to speak up and say something so that, like I said, the people up top will care about it more.
Why, I noticed that, obviously we're at the U.S. Chamber, and we're all, living either, here or in Illinois, and we're in the United States. And a lot of the problems that we're talking about in many ways are uniquely American, particularly when we're talking about things like fitness and nutrition. Why do you think for many Americans things like regular fitness are so intimidating?
I think it goes back to education. If you have a daughter or a son that you never pushed to be active in elementary school or high school, like they may walk into a gym and just be completely confused. They may not know what to do if they've never had like a coach, somebody to walk them through the process. I get messages from women all the time, like and they tell me like, what do I even do when I walk into like, where should I start? I'm just like, wow, like. It's so simple for me because I do it all the time. I do it every day. I've been doing it my entire life. But people are intimidated. I think education is where we need to start, which is why it's so important for, people to, or excuse me, your employer to provide like classes, like bring in like a fitness coach or, like you said, a nutritionist. These things are relevant today. Like people are afraid to start these journeys. They just don't have the information, or they might be Googling everything online, and all the information is just so overwhelming that they're like, yeah, whatever, I'll start this next week. The next week turns into next month turns into next year, and those chronic conditions start to develop. Like, this is why the education is key, and that's why I'm always going to keep talking about my babies, my kids. I like to talk about these things early. I've spoken to girls starting at the ages of probably 8, 10-year-olds, and they're so open to the information. They love asking, okay, well, if I eat a tomato, can I eat some rice with it? And what can I, they're curious, and I'm wondering why more adults aren't curious about learning about, better eating and health practices.
What you're doing is so important for our young people, and especially for our girls.
Yeah.
Because the changes that young girls will experience with their bodies is a big deal with them young. But let's not deny the challenges in the workforce for people who are unfit.
Yeah.
There are some jobs that you either won't be able to do or won't be able to do well, or it's not right, but the way that people may see or perceive an individual,
they won't hire.
Or it's not. It shouldn't be that way. Yeah. But people who are able to present and meet either physical challenges on the job, that's the way that society is sometimes. Mm-hmm. And individuals, young people especially, should give themselves the best opportunity at health, at life, and at career, by engaging in healthy lifestyles, early and often.
Are there specific examples of some of this at the, could be, I don't know, at the local level, individual companies, or, retail environments that are maybe making steps towards that more integrated, focus on an individual? I know there's a lot of mergers being proposed out there that may be heading in that direction. But I'm imagining a lot of this at the local level, where you might be reaching a few hundred people, might be reaching a few thousand people. Are there specific examples where we're seeing progress, where we see something working? And how might we go about making some of that scalable?
Tennessee, a couple of years back, had a walking, the governor of Tennessee was all about walking and exercising in addressing their obesity epidemic. And it wasn't just a tagline, but it was walking with the governor. So the governor would go out, and you'd come out, and you'd meet with the governor, and we would talk and walk. I have a meeting tomorrow, and it's at 2:30, and it's in my calendar, and it says, muscle while you hustle. It's a walking meeting at 2:30 tomorrow. After the person has had his lunch, I've had my lunch, we're meeting, sneakers on, and that's the hashtag, muscle while you hustle. Love that. Yes. It's not hustle while you muscle. No, muscle while you hustle. So, that's fine. We're not, sharing a PowerPoint. We're not writing anything down. It's one of those get-to-meets instead of going for coffee. This is the way. And I think the example that the governor put out there as it pushed down throughout the state, some communities have done this with community policing, where they integrate, police officers into communities. If your community isn't safe, we've got to find a way to get you back into the community, and those that are charged with leading a mission have to, see the conditions that people are dealing with. I think, the funding for, you talk about no lights and no sidewalks. Now we've moved from health, we've moved into, infrastructure for communities. So who's going to, fund that to get the lights repaired or get them installed? The involvement of community foundations and funding, and the people saying, this is what we want. We pay taxes here. We deserve to have a sidewalk and streetlights together. So there are a couple of communities that do this kind of work. A number of communities also have mobile units for screenings in communities if there isn't a medical center addressing a particular need, whether it's for infants or mammography screening, things of that nature. Sometimes you can bring the resources temporarily to screen, but that treatment and creating that livable environment, really does involve a champion, whether it's the governor, police chief, fire departments. Where can we find someone to look out for our interests, our best interests?
I think I know my church community, we've now developed a health and wellness ministry, which I really enjoy. That's a lot of fun. And then every year in DC, we also have the Health Expo, which is huge. I went this year, and they have everything from when it comes to mental health, they bring in dogs so people can just pet puppies, and I thought that was really neat. They have fitness classes that people can attend, and those run all day long. They have people selling organic food items that aren't as expensive as the ones that you might see at Whole Foods or Trader Joe's is my store. I don't know about anybody else, but I thought that, and there were so many people there who cared about health and wellness, and it was at the convention center. I thought that was amazing, and I don't know why that's not publicized more. So I think that's a great community event that's happening annually. I like that a lot.
I can add to changes in how we collect health information. So you're asking about targeted solutions. In terms of our least represented groups here in the United States, there are not tailored interventions yet. So one of my recent studies looks at breastfeeding initiation. So Black and multiracial mixed-race women are less likely to initiate breastfeeding for their babies. That's one of our nation's priorities. We don't have a tailored intervention yet because we're still trying to document the extent of the problem. But starting in 2015 and again in 2017, our federal reporting measures, such as reports from SAMHSA and HRSA, have now started to include these smaller groups, such as multiracial Americans and Asian Pacific Islanders. And by smaller, it's not that small, it's about 8 million people. But now we're finally starting to include these groups and learn what the health problems are. So it's a start towards solutions.
So I want to be mindful of our time, and really I feel like this entire conversation comes down to how do we change behavior. And I feel like that involves some combination of more information, more resources, and oftentimes more incentives. So looking at where we're at in 2018, among those, particularly for the business community, for employers, where should the focus be? If there had to be kind of a, in terms of triaging that and making a priority, where should the priority focus be?
I'd say businesses should strongly consider programs that can change, that can allow their employees to change their lifestyle. So lifestyle change programs may come with fitness wellness, may come with diabetes prevention, may come with sleep and stress techniques, may come with smoking cessation, may come with mindfulness. I mean, a lot of people have stressful jobs and you just keep coming back to that stressful job every day, but how do I know how to deal with stress? I know that there's a concrete problem in front of me, but how do I approach this even before I come through the door? I think the commitment that employers can engage in to acknowledging that they may not have the total solution within the ranks of their HR. This is something that we are going to seed out to those that know. It may create a better environment for employees to seek, weight loss counseling, to seek counseling for some type of anxiety or addiction, whatever the case may be, but acknowledge that there is a need, that it's worthwhile investing in changing the lifestyle. Because, as you said, you enjoy exercising in the morning. You're touching the sky. I'm touching my back after I exercise. But you have to empower your individuals to come into your workspace at a better state, at a renewed state. And that may be some aspect of change that your job may not be able to deliver to you, but they can bring the resources for you to make that lifestyle change for yourself.
I think it would be great if employees, if everyone was assigned a accountability sort of nutritionist or fitness wellness person. I don't know if any businesses have looked into doing that, but I mean, even me, sometimes I still have questions. I'm still learning about overall wellness, and I'd love to just be able to pick up the phone and call a nutritionist that's specifically assigned to me and say, hey, I drank kombucha 4 times this week. Can I drink it again? Is this bad for my gut? Just things like that. So I think that would be a good solution. I know in our HR department, we have just one person that focuses on wellness for the entire building. But I think we all need to have somebody that's specifically assigned to us, like a personal trainer, holding us accountable.
Like a life coach.
Yeah, like a life coach. Just how I am to my friends. I give them all their fitness and food advice, and I want somebody to help me out sometimes too.
Well, I'll say everyone needs a friend. Every employee needs a friend. And insurance. So at the population level, I mentioned one of the major protective factors is having insurance if you will receive services. So right now, at the most basic level, providing high-quality insurance to your employees is the way to go. Hopefully, there are more innovative models in the near future. Recent reports came out that a major online realtor company that will not be named, not a realtor, but a major online company is toying around with the idea of providing healthcare itself and foregoing the health insurance system. Maybe that's the wave of the future, but for now, at the most basic level, providing insurance.
I get a call at least once a week about a check that's in my name that I can claim. I get an email about money that's, in an account waiting for me, the scam. I get, your computer needs to be rebooted and I'm working in front of my computer. Why don't I get a call from somebody who is charged with making sure that I'm healthy and that I'm eating properly and I'm not depressed. I mean, that's something proactive than all of the solicitation kind of emails and phone calls that someone might get, to say, hey, every 2 weeks, has anything changed? Are you feeling differently? Do you have an ache or pain that you've been ignoring? Are you eating? Are you getting enough sleep? Do you feel stressed? I mean, maybe a 3 or 5 minute call from a company that my employer has engaged or from my health insurer, it at least opens up the dialogue. So I can say, well, I've been feeling, this way. Who should I start with? I don't have to go see a surgeon, but how do I get some type of assistance?
It sounds like a human resources social worker.
Yeah.
So
There
Henry Ford, he employed those for his social workers for the assembly line. For the assembly line workers, he employed social workers that visited them, made sure they were eating healthy, that their kids were healthy, their homes were clean, to maximize productivity.
The home clean too?
Yes, they went to the home.
All right, well, that unfortunately is all the time we have. Thank Danielle and Karen and Samira for joining us today. We could go on and on with discussion, but give them a round of applause.
Thanks to Adam and the fellow panelists. I'm going to call our next panel up, and I'm going to introduce Ray while they're getting mic'd. In the meantime, this panel is going to be a little different. The other panels were more conversations. This one's going to be a conversations, and you're going to see PowerPoint. So, it's a little different than the previous one. So we'll wait until they get mic'd up, and then I'll introduce Ray. So Ray Quintero is a principal of Healthsperian with offices in D.C. and also the co-director of the Smarter Healthcare Coalition, which is a forum for learning and innovation that allows participants, including the Chamber, which we're a proud member of, to brainstorm, raise issues and ideas, and find common interests in the pursuit of smarter healthcare. So I'm going to turn the panel over to Ray now.
Great. Thank you, Michael, and it's really a pleasure to be here and to have the opportunity in front of the Chamber and in front of all of you to introduce this wonderful panel on holistic well-being in the workplace and communities. We have visuals, so it's a little bit different, as Michael said, than the other panels. But what we want to do is really talk about a few issues that are really related to what the other panels have touched on, and really talking about how individuals, how communities, how employers can really be involved. So what I'll do is briefly talk a little bit about value-based insurance design and the role that it can play in really supporting a lot of what each of our panelists are going to be talking about this morning. And then each of our panelists will go into some great details about some innovative work and some opportunities to really support wellness in communities that is very important to them. First off, the Smarter Healthcare Coalition, it's a coalition of about 30 organizations that are very committed to value-based insurance design. You may be asking exactly what that is. Really what it is, it's really about patient engagement, which has been talked a little bit about this morning, and it's something that is a bit of a hard nut to crack, if you will, but it's something that's extremely important. It's also something that is important for aligning coverage, aligning quality, and value-based payment goals. One of the things that we really want to focus on is integrating benefit designs in order to support issues like workplace wellness, to support mindfulness, to support fitness, like was talked about on the other panel. So as our mission states, we really work to enhance the patient experience, to enhance individuals' experience. Healthcare is a scary thing. That was mentioned earlier today. Nobody likes to access healthcare because generally they think they're sick. but there are other ways in which healthcare can actually be looked at. And the stakeholders that are part of the coalition, as you'll see on the screen, are very wide, they're very varied, but they all have a very similar goal in terms of how they look at healthcare. So their stake is, for example, consumers. They're really seeking engagement, they're seeking support, they're seeking that friend, they're seeking that coach. What they're really looking is they want value and the access, and they want care. And an employer, what they want is they want to be able to provide that type of care. They want to provide that type of access to their employees, because what's most important to them is that they have employees that are in the office, that are in the workplace, that are actually healthy. Because as was mentioned earlier, if they're healthy, they're happier and they're more productive. So that's extremely important. And then from the provider perspective, for example, they want their patients to be able to seek preventive care. And under value-based insurance design, for example, they also want their patients to be able to access chronic conditions, first dollar coverage. And those are areas in which innovations in payment design and payment models, as well as coverage decisions, can be extremely important to the provider community. So all of those really have to connect so that the individuals, so that the patients, so that consumers, so that the employers are all having conversations, because these are all very important. But then there are innovators, for example, and innovators are really looking to make sure that they have opportunities to advance areas like mindfulness, to advance workplace wellness, to advance fitness opportunities, and looking to see how they can integrate those into benefit designs that you don't traditionally think of. When you traditionally are thinking of what your insurance benefits are, you're thinking of the fee-for-service model. You're thinking of going, having your checkup. You're thinking of going and getting your treatment, your antibiotic, your medication. You're not necessarily thinking as a consumer of how that benefit can actually be used for additional services that our panel will be talking about today. So our work continues to really focus on not simply cost. It focuses on high clinical value, for example. It focuses on, as was talked about earlier today, patient-centered engagement. And what's important about patient-centered engagement is adherence. That's how you have patients be adherent. It's a word that patients don't like to hear. They don't like to be told what to do, but what patients do like to do oftentimes is they like to be engaged in their own health care. But they have to understand their health care in order to be able to do that. They have to understand what is being offered to them in order to be productive and actually active members in their own health care. And then supporting holistic well-being is also something that's important to even support fitness, for example. And collectively, this will all come together in value-based insurance design to even support workplace wellness programs, to support holistic well-being, and also to support mindfulness. And what's interesting here is we can also look at social determinants of health and the impact of those, but also how we can use value-based insurance design and insurance models to try to address some of those issues that are related. So what we'll do is we'll turn over to each of the panelists. I'll introduce them very briefly so that they can provide you some information about the opportunities that are available in advancing holistic well-being and aligning incentives, as we've been talking about this morning. So I'll begin directly to my left with Daryl Moon, who is the Chief Executive Officer at Orient, which is one of the first healthcare coaching companies in the U.S., and Daryl started the company about 2 decades ago, and the company still remains focused on population health, which is also working with small as well as large employers. And Daryl's going to touch on, amongst other topics, the correlation between stress as well as mindfulness. So please join me in welcoming Daryl Moon.
Thanks. So do you want to stand up to the podium? You want to just over here? Okay. It's a pleasure to be with you. It's great to be here in this U.S. Chamber of Commerce, where this organization since 1912 has been dedicated to business bottom line. And to be focused on this particular topic, I can't think of anything that the Chamber could be doing that's more important than aligning incentives for better health. Because we live in a country where our industry, our healthcare industry, is not aligned. Employers and employees are aligned. They both want health and productivity. They don't want to be surprised with unexpected costs. They want a healthcare system that's there when people get in trouble. But the healthcare system isn't aligned with them. The healthcare system makes more money the more procedures we do. I used to run hospitals. I ran 10 different hospitals all over the country. And metaphorically, I sat at the bottom of the cliff and I waited for people to fall off so I could make lots of money. And the more people that fell off, the more money I got to make. And ethically, that didn't make a lot of sense to me. So eventually I left to move on the prevention side and say, how do we put a fence at the top of the hill to keep people from falling off the cliff? And who's incented to do that? Well, I don't blame hospitals. I don't blame the healthcare system. I don't even blame the insurance companies. Now, we like to blame the insurance companies, but if you think about it, who's to blame for this misalignment of incentives? It's not the brokers. It's not even the benefit managers at the corporations who are responsible for the second or third largest cost of doing business. I blame the business leaders, which is why this is such an incredibly important topic for the U.S. Chamber of Commerce. It's the CEOs of America, who are willing to give the CFOs a bonus to create profitability. The COOs get bonuses for creating efficiency. The chief sales officers get money for creating higher sales. But do you know any chief HR director or benefits director who gets more money for creating better health? Think about it. CEOs don't even incent the very people who are in charge of the second or largest cost for better health. Now, I'm not talking about incenting them for lowering costs, because the number one reason employers buy benefits is to attract and retain good employees. And if all the incentive was to drive down costs, you just simply take away what people need, which is a system that's going to help them when they get in trouble. But when you incent based on actual better health, that will produce lower costs. And a lot of times we think, well, there's no way to measure better health, so we don't do it. Well, there's lots of ways to measure better health. And the very people who are in charge of buying health care should be focused on buying better health, not more treatment. Does that make sense? So you ask the question, okay, what does better health have to do with mindfulness? Or what does mindfulness have to do with better health? Everything. If you really look at the core of almost everything we spend in healthcare, it's behavior, it's lifestyle. One study shows 87% of everything we spend in healthcare can be traced back to behavior. So if behavior is the root, why don't we focus on behavior? Why don't we do more to focus on changing behavior? Now, behavior is really hard to change. I would submit that it's the hardest thing there is to do. It's a lot easier to rip out your heart and replace it with an artificial one than it is to get to change your behavior. But there are best practices of changing behavior. Let's talk about the brain, because the brain is where it all starts. Now, for any brain scientists in the group, we're not going to get into a lot of detail here, so please forgive me for my very oversimplified approach. But there's layers within the brain. There's the core parts of our brain that are instinctual, they're survival-based, we don't consciously think about them, they keep our heart rate going. We'll call those the emotional part of our brain. And they have a tremendous amount of power over what we do. And then there's the thinking part of our brain, that creative or analytic, or that part that aspires to do wonderful things, to do great things, to be heroes. Our survival part of our brain says, danger, run. The thinking part of our brain says, somebody's in trouble. They need my help. Fear, be gone. I'm going to go be a hero. And so this whole idea of changing behavior really boils down to how do people manage what's going on inside their brain. And there's ways to do that. There's no question that it's all about activating that thinking part of our brain. And we get in a rut. We like what's comfortable and what we're used to. How many of you have woken up one morning or you get into this epiphany and you go, Where'd those 50 pounds come from? I want to be over there, and yet I'm here. I don't want to be here. I want to be over there. How did I get here? Well, we don't like change. Our body sometimes sabotages the change that we want to make. And we get in this rut of just doing the same things. Change is uncomfortable, so we like to continue doing what we always do. Well, the problem with that is that you're not reaching those overall goals. And so behavior is about how do you mindfully help people to move out of that emotional part of the brain, that survival instinct, into the thinking part that actually does that. And I'm not going to get into all the details of how you do that. There's mindful breathing, and certainly breathing, if you think about it. I can't control my heart rate. I can't think right now, I'm going to change my heart rate. But I can think about my breathing. You've all heard the term, take a deep breath. When you're stressed and the survival part of your brain's kicking in and you're doing things you don't necessarily think are very good, but you're doing them because that's what you're feeling like you got to do. Well, breathing, that whole adage of take a deep breath, actually works. It can help kick in the thinking part of the brain to say, okay, there's a better decision I can make here. So clearly, deep breathing, meditation, evoking the relaxation response are all things that we can do to activate that. Setting a goal and tracking the progress on that goal can activate that thinking part of our brain. Having someone else who knows we're working on that goal is incredibly powerful. It could be a friend. It could be a professional counselor. It could be a health coach. Anyone else that knows we're working on something helps us get out of the survival instinct, feelings part of our brain, and into the thinking part of our brain. I'm not going to go into a lot of the details of how to do that. I'll let some of the other speakers talk about some of those kinds of things, but I would like to show you the result of an organization who about 14 years ago, one of the largest auto dealers in the country, decided that they were going to implement a robust well-being strategy focused on mindfulness. And we, in the last panel, talked about how do you get everybody involved with a health coach or a life coach or someone that's there to support them. Not to tell them what to do, because it's not about prescribing change. Behavior is too hard to change to think that you can just prescribe it. But allowing them to move out of the emotional part of their brain into the thinking part of their brain to activate what they want to accomplish. And the health coach is there to support that change. So this organization implemented a very robust program where over 50% of everybody on the plan, both employees and spouses, were calling a coach on a regular basis to get that support. Well, they found that not only their healthcare costs went down, and think about this, imagine a company's trend, medical claim trend, being negative 15% over a decade. So while their competitors are paying $1,500 today for a family plan on a monthly basis, they're paying less than $1,000. They're less than a third of what their competitors are paying. They're able to compete a lot better. The rest of the industry, the rest of the country went up by 59% over that same decade. So imagine being able to implement a strategy that actually saw costs going down because the population's healthier. Their high-risk population dropped in half. Their overall health scores improved by 20%. As an example, systolic, those who were at risk for systolic blood pressure reduced towards where it wanted to be by 60%. Diastolic reduced by 88%. When you can implement strategies like a robust wellness program where people have access to somebody who's helping them to activate the thinking part of the brain to actually change behavior, which is really hard to do, and it's about connecting with people on an individual basis, you can create population health. And you can create population behavior change, which then reduces healthcare costs. So it's not just one example of one company. There are many, many companies that have implemented a similar strategy and has similar results because of, again, activating mindfulness to change behavior. Thanks.
Great. Thanks, Daryl. So certainly changing behavior is important, and part of that is being mindful of what you're doing. And our next speaker, Meeta Shukla, is the founder and CEO of VitaMeeta, and she's also the author of Enduring Edge, Transforming How We Think, Create, and Change. And she'll be talking to us a little bit about an actual framework for mindfulness. Meeta?
Thank you so much, Ray, and that was a perfect setup, Daryl. So I will be, and we have about 10 minutes, so I'm going to be covering a lot. I'm going to zoom out and really sort of take a very holistic, big picture perspective at healthcare, and then just zoom in even deeper than you did into our mind, into your mind specifically, and how we can each transform our thinking patterns, not just as individuals, as patients, but really as leaders and change agents and innovators who are trying to disrupt a system that is often, stubbornly resistant to change. So, again, to begin very high level, the healthcare system today is essentially focused on getting us from a state of disease to no disease or ameliorated disease. And it essentially is a sick care system, even though we call it a healthcare system. The focus is on getting rid of sickness and disease. And for that, we have, incredible doctors and drugs and devices which have really transformed, human lifespan and are essential to a lot of, the extension in human health and well-being that we've seen. At the same time, we know that someone can be free of disease and yet experience a state of dis-ease, of really not being well, whether that's in mind or body or spirit, and that it's really ultimately a state of well-being and wellness where we feel like we're living our potential, we're experiencing a sense of connection and purpose in our lives. That's really what we're aiming toward, and all of medicine and sick care and healthcare is ultimately designed to be oriented toward that. And unfortunately, as we've discussed, it's been wonderful to hear this morning's panels. A lot of the factors have been discussed in great detail earlier today, so I won't get into the details here. But it's a lot of the well-being related factors that fall outside of the purview of the healthcare system that, often get us into the healthcare system in the first place, when solutions are much more complicated, often not fully curative, and much more expensive. At the same time, we know, and my fellow panelists will be getting into this, that there are other aspects that also fall outside of the healthcare system. Work-life balance, having strong social bonds, cultivating mindfulness and resilience, connecting with the arts and music, being in nature, that really revive us and connect us to sort of our most fundamental human essence. And if you think about it from the perspective of mindset, so I spent about 9 years in healthcare venture capital looking at cutting-edge innovations and sort of trying to determine, how can we really invest in the most promising inventions that are out there to transform health. And, for the most part, the focus of that world is still on specific symptoms, and that's for good reason. Science is reductive and deductive because we usually look for a biochemical pathway that we can connect with a symptom against which we can then develop drug targets. This often leads us to define specific medical conditions, which we can then develop a portfolio of drugs against. But what happens is when we only focus on developing innovations through mindsets or lenses, we often neglect the whole person. We neglect, these other factors that were on the prior slide that are everything in terms of how we lead our lives and what really leads to our well-being as a human being. And it turns out, as an investor, I saw a fascinating trend. In addition to this phenomenon sort of playing out in how, we as a system look at the individual, it turns out the same holds true for organizations and for companies. And among startup companies, I often saw that companies or entrepreneurs who were in a short-term or reactive mindset had a very different success rate than those who had a more holistic, big-picture mindset. Or, there were others that were more focused on rules or sort of operating by rigid guidelines. And, if there's one thing that I sort of take away from my years in venture capital, it was that the difference between, entrepreneurs who failed and entrepreneurs who succeeded was that those who succeeded failed more. They had a resilience, an ability to keep going, to pivot, to learn from failure, and to really often build businesses that had nothing to do with the original business plans in which we had invested. So we were really investing in the people, and that more than anything was a contributing factor to success. And it turns out, sometimes even when you have an entrepreneur who's able to successfully develop a technology and build a company, sometimes those technologies fall apart at a third level when they enter our complex healthcare system. And that's because when the mindsets and the culture of that system are focused on, again, short-term survival, reactive thinking, you often get a lot of what we've talked about today. You get, volume-driven healthcare. You get a focus on short-term profits and bottom line. And there is often a resistance to change because of a fundamental fear of change, which comes from our emotional thinking, which is very much in the survival state of thinking. On the other hand, when you move upstream and you focus more on metrics, you're able to get more incremental change and progress. So you have more improvement, but the shortcoming of only thinking through that lens, especially for entrepreneurs, is that you're often thinking based off of what exists already. So you try to improve what is there. And a lot of the greatest innovators and change agents in the world are able to imagine a completely different world. And that's because their minds are not bound by what they know. They're not biased by prior knowledge or experience. And they're not held back by sort of the status quo or fears that might drive others. And that is ultimately what leads to value-based change, because you're able to zoom out and truly take a holistic long-term perspective that drives innovation and transformation in the long term. And again, consistently, I saw that amongst healthcare leaders and innovators and change agents, these were the types of thinking patterns that were shared by all of those who were able to successfully transform industries and to successfully introduce their innovations. But as an investor, I really wondered, we know what is good for us, so why is it still so hard to implement, right? Why, despite knowing what we should do we still not do it? And how can we really turn this into something that is very simple and practical and action-oriented, something that each of you today can walk out of here with, remembering and trying to implement in your own lives? So that was really, as an entrepreneur and an investor, my primary focus. And I realized, so I went off and did multidisciplinary research across neuroscience, the art and science of mindfulness, looking at behavioral health, psychology, leadership and management science, and realized that almost all of our thinking activity actually does happen in these 3 specific states of mind, which I call the 1D mind, or survival-driven thinking, which tends to be emotional and reactive and often correlates to the stress response. More analytical and logical, rules-based thinking, which tends to be metrics-driven, is the kind of thinking that often puts labels and organizes the world into systems. And then there's sort of more intuitive, creative, and holistic thinking, big-picture thinking, the kind of thinking that a lot of innovators and leaders have and carry forward into their workplaces to really make an impact. And just very quickly, if you go back to the slide I showed you earlier, a lot of these factors that take us away from well-being actually correlate to us being in the 1D state of mind, as they do for organizations. If you want to understand the culture of an organization, look at the mindsets of the leaders at the top. It's so often the mindsets of the leaders that drive, what is measured, what matters, what is valued, and what ultimately permeates how people lead their lives and what their lifestyles are like. And the same holds true at the other end, when workplaces and leaders value and implement and try to put metrics around these factors, as we're discussing today, you really see a transformation in not just performance, of which there is a lot of data, but also just employee happiness and satisfaction and well-being in the world. So I published a book on this a few years ago, and basically, there is a specific way to train it, and I've really tried to simplify it. But essentially, training our mind is about developing awareness about what state of mind we're in, assessing if that is the absolute best state of mind we want to be in, and having the agility to switch between the 3 states of mind. And I'll tell you a quick story at the end to illustrate this. But this particular point, I think, is best illustrated with a quote from a student in a class I've been teaching at Johns Hopkins to graduate students on leading change, where this book has been a required textbook in recent years. And this is a healthcare leader who said, knowing there are these 3 approaches to an outcome has made me much more awareness of my actions. I end up asking myself, assessing more often now, what mind am I using right now? Can I, or should I, change my mindset, have the agility to change now? And in recent years, this is really a passion project for me, because I've seen how profound the impact of mindset and changing our mindset can be on individuals and society and organizations. So I've taken it to a lot of different organizations, and it's been fascinating to see whether it's talking to physicians about preventing burnout, or talking to inner city kids about developing resilience, or talking to entrepreneurs and innovators about failing and not giving up. It's really the same fundamental states of mind that drive failure and success across almost all of these fields. And I'll leave you with a very short story, which is very relevant to our field. So So physicians, a few years ago, I was a mentor in residence at Johns Hopkins. I spent a year working with the physicians and innovators, trying to help them think more creatively. And doctors are trained in a, rules-based system, which is a very good thing. You don't want your surgeon having you on the operating table and saying, oh, I wonder what would happen if I tried this new procedure today. Why don't I riff on my surgical technique? That's exactly not what you want. At the same time, when you take that same physician and put them in a brainstorming session to reimagine healthcare, that's exactly not the kind of thinking you want. So what we did is we played around with different exercises, and I worked with faculty at Johns Hopkins and at the business school, and we developed these exercises, and it was fascinating. The first time we gave them to this group of physicians and innovators, they went to the blackboard, they had leaders and rules, and it was very systematic, and we gave them a limited window of time. They ultimately solved the exercise, but it took a while. Then we introduced this knowledge around mindset to them, and they came back a week later, and they solved the exercise designed by one of my colleagues within moments. And my colleague said, I've never seen this before. What's going on here? So we asked the folks in the room, and they said that when we walked in the room, this time, our default was to not use our default way of thinking. So essentially, they walked into the room, they had primed their mind differently. They had the awareness to know that they had a certain thinking tendency. They assessed that that would not serve them best when they were trying to be creative and innovative. And they had the agility to tap into that 3D mind, which is available to all of us. So I just share the story with you to illustrate that, we often talk about the fact that changing our mind or mindset can be hard and that changing behavior is hard. But so much of what happens in our mind actually depends on what we believe about our mind. And if you believe that, if an old dog wants to learn new tricks, it helps to believe if the old dog thinks that it can learn new tricks. So I'll leave you with that. Thank you.
Thank you, Amita. Certainly, mind states are not the easiest thing to change, but I think Amita has presented some tools that can provide that. And one thing that's important is that resilience and agility are certainly something that children really have a lot of, which was a question that was asked earlier, is why is it that children can make changes so easily and adults have difficulty? And they certainly have a lot of that. And our next speaker, Betsy Delzer, is a coordinator of mindful education and leadership development at Middleton Schools in Wisconsin. And Betsy has been trained in mindfulness-based stress reduction, as well as various mindful curricula for kids and adolescents. And she's going to highlight an initiative about the importance of social and emotional intelligence. Betsy?
So I'm coming to you from a totally different vantage point. And I know many of us have been sitting in this room for potentially several hours. And so I'm actually going to begin this time. I'm going to use a few of my minutes for a short practice, if you're willing. So what that looks like is you get to decide. It's always optional. But if you've been multitasking throughout the morning, this might be a time to just flip over your device and drop in. And by that, I mean just adjust your seat for comfort. Maybe feel your feet on the floor. And we're going to just take a moment, just a few moments, to get into the body, out of the head space for just a moment. And so it might help just to drop your gaze down toward the ground or the table. And arrive in this space, in this moment. We can do that by deepening our breath. We know that 3 to 5 deeper breaths help stimulate the parasympathetic nervous system. So just notice the sounds around us for a moment. Doors creaking. The sounds of people preparing. The sound of my voice. And as you notice the depth of your breath, see if it's difficult to grab a deep breath or if it's coming to you with some ease. And then for just a moment, notice the temperature, maybe at the tip of your nose, around your shoulders. And then take a good deep breath for your heart, the other stories that you're carrying into the room. And as you're ready, just lifting your eyes back to me. Thank you so much for taking that time. So I'm really coming to you as an on-the-ground life application participant in this panel that I'm honored to be a part of. I literally was on the ground for 15 years of my career with little kids. I was a public school teacher, and I jacked my lower lumbar spine in an accident and began a yoga practice as a way to feel better and heal my spine. And shortly into feeling amazing and healed and flexible, I was totally hooked on this daily practice. And I saw how it changed me as a partner and as a mom and as a teacher. And so I went to pursue how to teach yoga, because I love teaching, love being with people and being in the heart space. And during that time, just started unrolling yoga mats on a lunchroom floor. So I'm telling you this story so that you can kind of trace the path as to why I'm here with you today. So after a couple of years, I wanted to incorporate more than just the movement practice. It was drawing some of my colleagues to the lunchroom, but I wanted to make our work and our time together more impactful, more meaningful. The reality is, it has to mean something to you. That's why I began with this practice. We can stay in the head about it, but until you begin to practice, that structure and function of the brain won't change until you practice. And so I went to my principal and I asked if we could use some professional development time, and then he gave me 10 minutes of every staff meeting. And I knew it couldn't be just my own horn honking all the time, so I grouped together some friends, community, right? And the group of us organically created a curriculum that incorporates many contemplative practices. Most of our gratitude and reflection practices are rooted in Sean Achor and Michelle Gielin's work around positive psychology and gratitude. And then we have drop-in meditations, just like what we just did, a space and place to just hit pause. So after a year of this, my school district decided they wanted a group like this at every location. So the last panel moderator asked about scale, and it's really about people, right? It can't all just come from one person. So I trained a group at every location in our school district to sustain practices for our staff. And in doing that, was led out of the classroom into this position I now hold under the umbrella of employee wellness. About a year into this mindfulness coaching position, I realized I was spending a lot of time in the periphery, in sort of the branches and the blossoms, and I wasn't attending to the roots, and that is our leadership. And that was something that was shared earlier. So I spend a great deal of my time just helping cultivate emotional and social intelligence among our leadership to optimize communication and connection. One of the things that we do is we talk about mindfulness in a variety of ways. And so as I was thinking about what is drawing me here to DC, I've never been, this is great, right? And this is really unusual. I'm usually with a group of educators and little children. As I was thinking about how and why I'm here, I realized I wanted you to come away with something that you could just stitch in. Some one person in this room could tuck something in their pocket and take it with them. And so I'm offering this idea about mindfulness that's adding to these different components. I love the 1D, 2D, 3D mind and the neuroscience that Daryl brought in a little bit at the beginning, right? Because really what we're doing when we practice this is we're strengthening the neural circuitry and fibers between that thinking brain and the limbic system so that we can react more thoughtfully. Right? We really are aligned to our response. That's what these practices help us do. That's why we're investing in them in education. So I'm borrowing a few components of this definition and understanding of mindfulness from Kelly McGonigal, fantastic health psychologist out of Stanford. You might be one of the million viewers of her wildly popular TED Talk on befriending stress. And if you're not, I highly suggest you check it out. So Kelly talks a little bit about mindfulness for understanding your intention, right? So your intention, just how do you want to show up to this circular table? Who do you want to be? Right? So establishing your core value and then aligning yourself with that intention. And then we pay attention to that intention. So our words, our thoughts, and our actions draw us closer to that intention, that who of who we are, or repel us. And because of the human condition, we make multiple choices in both categories every day. But we have that anchor of our intention, and then we pay attention to that. That's living in a way that's mindfully aware. And then I add to this definition or understanding of mindfulness this component of compassion. So Kristen Neff is a pioneer in compassion research, University of Texas. Spent some time with her recently, and she said something that really struck me, and I'm going to leave this with you. She said, we have many, many differences that we must see, we must observe, we must honor in one another. But we have a couple of things that are absolutely true. These tend to not like the term universal truth, but it is what it is. We come into this life and this lifetime as an infant, and we come in needing and desiring love. That's what we all come into this place, needing and desiring love, and along the way we accumulate pain. That is true for all of us. And so having a compassion practice enables us to reach to one another and see each other, really see each other. More than the tasks, more than the email inboxes, but really see our common humanity. That's another way of understanding mindfulness. So Richie Davidson is an amazing contemplative neuroscientist, and I'm really fortunate to live in the same city, so he frequently speaks in my hood, and I get to go check him out and spend time with him. But he says this, we can intentionally shape the direction of plasticity changes in our brain. By focusing on wholesome thoughts, for example, and directing our intentions in those ways, we can potentially influence the plasticity of our brains and shape them in ways that can be beneficial. And that leads us to the inevitable conclusion, I love this, right? That qualities like warm-heartedness and well-being should best be regarded as skills. So if they are regarded as skills, warm-heartedness and well-being, there are things that we can practice, we can teach, we can learn. And so that's why we prioritize this in education, and this is where we're trying to go in my school district and potentially in these other pockets that you're involved in.
Thank you, Betsy. I certainly have more practice to do. I think I need to go to Betsy's school. I was feeling relaxed after the exercise, and then as I was thinking about my intention and attention, I started feeling a little bit stressed, so I need to visit your school. Our next speaker, Melissa Menser, she's a program analyst at the National Endowment for the Arts in the Office of Research and Analysis. She manages research, Artworks grant program, which supports research projects focused on the value as well as the impact of arts on human communities and societies. Melissa's going to talk to us a little bit about the importance of connecting the arts to economic development. Melissa?
Thank you. Again, my name is Melissa Menser. I'm a program analyst at the National Endowment for the Arts in their research office. I thought I'd start out by saying thank you to all of the fellow panelists and our moderator. I feel so relaxed right now. I want to call you every time I have to do a presentation. But I'd start by introducing the NEA a little bit and then going into some of the programs that we have. So the NEA was established as an independent agency by Congress in 1965. Our current mission is to strengthen the creative capacity of our communities by providing opportunities for arts participation, diverse opportunities for arts participation by supporting projects that focus on creating arts, fostering engagement with the arts, and promoting knowledge and understanding about the contributions of the arts. We award grants to support our mission to organizations of all sizes across all 50 states and 6 U.S. territories. And these awards are made in all artistic disciplines such as visual arts, multidisciplinary arts, performing arts, literature, arts education, partnerships, as well as research. And within the NEA, the Office of Research and Analysis conducts and supports research on significant topics such as the impact of the arts on human development, the social, civic, and economic impacts of the arts, artists in the workforce, arts participation, as well as how technology is continually changing the nature of arts participation. So our portfolio is shaped by 2 overarching research questions. What are the factors affecting the health and vitality of arts participation and arts and cultural assets, and what are the direct and or indirect benefits of the arts for individuals and or communities? And so for this conversation, I'll be talking a little bit about some of the NEA research initiatives that we have that are focused on arts and health. And I'll be specifically speaking about a unique partnership called Sound Health. So for the last several years, the National Endowment for the Arts has led a task force consisting of 19 federal agency and department heads or representatives who meet quarterly to discuss ways to catalyze new research and information sharing about the arts' relationship to health and well-being across the lifespan. This group, which includes participation by the National Institutes of Health, the U.S. Department of Education, and other entities, as you can see on the slide here. And we have produced public webinars and reports about the arts and human development. This task force has also coordinated from time to time on releasing funding opportunities to spur academic research about the arts, health, and well-being. And so these are some of the publications that we've produced, sometimes together with those agencies and sometimes on our own. So these include studies on the arts' role in social and emotional development in early childhood, area and age group of Betsy's interest, about the arts and academic, social, and civic achievement for at-risk youth, a report about the neuroscience of creativity, and a guide for conducting research about the arts and health in community settings. But the one report I'd like to give a special mention about is the one in green, which is at your bottom right. It's called Staying Engaged: Health Patterns of Older Americans Who Participate in the Arts. The research showed that older adults who engage in the arts tend to show higher cognitive functioning, as much as a 7-fold difference compared with older adults who have not engaged in arts activities. They also show lower rates of cognitive decline, lower rates of hypertension, and lower rates of limitations to their physical functioning. These are correlational findings based on evidence from the Health and Retirement Study, which is a nationally representative survey of adults aged 55 and older. So beyond the federal task force chaired by the NEA, we are proud to be a participant in another research initiative involving the National Institutes of Health. It began as a collaboration with the NIH and the Kennedy Center, and it's called Sound Health. The initiative started a couple of years ago when the soprano Renee Fleming began talking with NIH Director Francis Collins about the need to study how music works in the brain and what are the implications for health and well-being. As it turns out, there's a substantial body of research in 2 discrete fields. So there's neuroscience, and then there's music therapy. But the fields haven't been brought together as much as you would think. So the first thing that the NIH and the Kennedy Center did was to conduct a 2-day research convening back in January of 2017. And after a series of dazzling presentations and focused discussions, the NIH decided to, for the first time, to develop a trans NIH funding initiative for this research. And in June, and then results from this workshop were published in the journal Neuron, which is a highly read biomedical research journal. And then in June of last year, the 3 partners held a 2-day event bringing together musicians, neuroscientists, music educators, as well as music therapists to explain about the mechanisms of music in the brain and its plausible effects on cognitive functioning and healing. And the partners are now planning for another event with a focus on music and early childhood development. And so Renee Fleming has been a terrific ambassador for this program. So we hope by participating in this particular effort, we can raise public awareness of music as well as other art forms in scientific terms, but also so that people can understand the lifelong benefits of music engagement. It's also worth noting here that the NEA itself supports many of these kinds of studies through its grant awards to nonprofit organizations, including research institutions. Over the couple of years alone, we've made awards to a research lab at Drexel University to study music therapy and visual arts therapy and chronic stress, and to Vanderbilt University Medical Center to study social and emotional benefits of music engagement for children with autism and their families. We've also made research awards supporting the study of music and neuroscience. And so finally, I want to call attention to a flagship initiative at the National Endowment for the Arts in partnership with the U.S. Departments of Defense and Veteran Affairs, titled Creative Forces NEA Military Healing Arts Network. This initiative serves the special needs of military populations and veterans who have been diagnosed with traumatic brain injury or psychological health conditions, as well as their families and caregivers. So Creative Forces integrates arts therapy, music therapy, dance and movement therapy, as well as expressive writing into military medical facilities. This ranged from Walter Reed up in Bethesda, Maryland, to 10 other facilities nationwide. Increasingly, there's been an effort to connect creative therapies with community-based arts practitioners so that military personnel can continue to engage in arts-based healing after they transition to civilian life. Our office at the NEA has been involved with developing the 5-year research agenda for Creative Forces, and last year we held a clinical research summit at the National Academies of Sciences. Signaling her support for this initiative, Second Lady Karen Pence hosted a breakfast for the summit participants at the Vice President's reception on the same day as the event. And in a few weeks, we expect to post to the NEA website that strategic plan so that you can take a look at that document, as well as an updated inventory of research papers that have been published based on this initiative. Indeed, in recognition of the growing evidence behind creative arts therapies and their role in improving health and well-being, the NEA has declared in its own new strategic plan that it will offer funding for therapies as well as evidence-based arts and health programs. And that's all that I have. And I don't know if I need
Thank you, Melissa. And thank you for the work you're doing and really making those linkages between the arts and health. Amita talked a little bit about some of the barriers and the work that's occurring in terms of employers really having to have the mindful state and leadership to be able to advance some of the work that's being done. But I'm curious from both Betsy as well as Melissa and the work that you're doing, have you encountered any barriers in terms of trying to advance what you're doing in the schools or what you're doing in partnership with the arts?
Should I start? So I think it's really, can you hear me? Yeah. I think it's really important to bring this back to the mission of the National Endowment for the Arts. So as I mentioned before, it's our goal to provide opportunities for all Americans to participate in the arts. But back in 2012, prior to that, we started working with the General Social Survey, which is a nationally representative survey of adults, and they responded based on a number of social opinions, such as I'm totally blanking. Sorry about that. So the General Social Survey is a nationally representative survey of adults' attitudes, perceptions, and opinions in a wide variety of social issues. And so for the 2012 wave, we actually added an arts module. that asks about motivations and barriers for arts participation. And so some of the things that people responded about was, in terms of barriers, is that the social reasons was a big factor in why they did not go to arts events when they wanted to go to an arts event. So not having somebody to go with was a big factor. Another one was time, and another one was cost, among other activities. And I will note that one of the significant reasons for why people want to go to the arts is that social factor. So that's one of the barriers that we've been experiencing in terms of that.
I think the barriers we experience in the schools are around misunderstanding, right? So not really, we try to actually get away from the word mindfulness because it can be grossly misunderstood. And I think also a fixed mindset around the illusion of time. I don't have time for that. I can't fit that in, or that somehow we don't have enough. We don't have enough of it, and that's really highly illusory. So I think another final barrier, I would say, in just the work itself is initiative fatigue. So especially in public education, there seems to be, we have a lot of things coming down the pipe, and there are things, especially after being in this organization for almost 20 years, cyclical, right? So those are some things that I've experienced.
Makes sense. Daryl, can you talk a little bit about the importance of really having that partner or that coach or that companion to really help you through? Because there's been a lot talked about on several of the panels, but even in some of the barriers that we've talked about on this panel, about the importance of having that friend or having that coach to really help you along.
Sure. If you think about our own health and how we deal with our own health, it's often a very lonely island that we stand on. How many people do you regularly have conversations with about your health and how you're feeling? It's a very lonely thing that each of us experience individually. And the secret isn't to call people with a coach and annoy them. Because nobody likes to be annoyed. And nobody likes to be hounded. The secret is to have the person invite that coach on that island with enough trust that they begin to think about what those intrinsic motivations are. So I like to talk in terms of categories. There are the fitness buffs who they're just already healthy and they're going to continue to be healthy in most cases. But they're not the majority. The majority is more of what I call the reluctant group, the reluctant majority that they don't want to be browbeaten, they don't want to be intimidated, they don't want to feel bad for the fact that they've tried to do things and they can't do it. And so in order to engage that very difficult group, that population that are reluctant, you have to, one, get over the hurdle of this person isn't going to tell them what to do. They're going to get to decide what they're going to do, because it's about getting those people to think of what do they aspire to. And it may not have anything to do with nutrition or exercise, but it's what is it that they aspire to, and that friend is there to support them in accomplishing what they want to do. And when that person recognizes that, they actually begin to use that person. And people ask all the time, how do you get such high levels of participation? How do you get so many people calling a coach? It's not rocket science. It was said earlier today. You leverage the power of someone who cares. Most people respond very positively knowing that someone else cares about me and my health.
Which fits very nicely with the intention, the action, and the compassion that Betsy was talking about. Why don't we open it up to the audience for some questions? Right in the back. We'll start there.
My name is Arnold King. I'm the King Consult Solution. Dale, I had a question for you. I mean, you mentioned two kinds of brain. What is the
emotional and the thinking?
Emotional brain and thinking brain, right? What are the differences, and how does those affect healthcare from a standpoint?
I'm not sure I caught the question.
So how do the emotional and thinking parts of the brain really affect healthcare? In your view?
How do they help the person that deals with healthcare or is trying to see healthcare?
It's the connection between behavior and our thinking. So behavior, how we behave every day, how we go about our lives, how we eat, how we exercise, how we interact with other people, has an incredible impact on health. In fact, almost everything that we spend in healthcare can be traced back to behavior. So the thinking of the mind and being able to get out of that survival mode and that fear and anger and frustration mode that so often permeates our lives, and moving into that thinking part of the brain, or that more innovation and improvement and actualization and what we want to accomplish, is the crux of getting people to change behavior. So it has everything to do with it.
I'll just add a quick, to sort of put it through the lens of, and we're really, sort of sharing the same concept. Neuroscience's understanding of, what parts of who we are as human beings map to which specific parts of the brain is I think, still in its early days. But there are certainly regions of the brain that we can trace to emotional thinking in the amygdala and the survival response, and then sort of the prefrontal cortex and the more sort of analytical, logical thinking parts of the brain. And then there's also sort of the deeper, more intuitive, creative thinking, which we don't fully understand where it comes from, which I've sort of referred to as the 3D state of mind. But to make it very real, if you're trying to help someone quit smoking, fear, which is emotion-based, is a terrible long-term motivator for changing behavior. And so often our programs and initiatives with the intention of, helping someone stop a behavior design programs that are not aligned. So there isn't an alignment between, what we want to happen and what we actually do. And then you can try data. So a lot of our programs will try data and throw lots of statistics at you and say, this will kill you and medicine proves it. But still, for most people, even when we know what's bad for us and we know it's not rational, so even our thinking logical part of the brain recognizes that what we're engaging in is not good for us, we still don't change. And it's really when we tap into that deeper sense of meaning and connection and purpose. So often someone will say, I want to live my daughter get married. I want to live to see my son graduate from college. It's these moments of meaning and relationship and connection. When we tap into those, where you can really see, transformation happen. And when you root a change initiative, whether as an individual for yourself or as a leader of an organization, in these deeper elements of our humanity and what matters to us at the most fundamental level, that's really how you align, the initiative you design and the incentives that flow out of it. So often I think we do it upside down, where we start with emotions such as fear. It's the easiest one to tap into, or we go with data because we have it available. But we don't sort of get into this softer terrain that our science can't as easily define and quantify, but which is at the foundation of everything.
I think we have a question right over here on the end.
Hi, my name is John Gallo, and my company is Now I'm Fit. I'm a corporate wellness solutions provider. Plain and simple, I've been a personal trainer, nationally certified for 25 years. I've been an owner of many health clubs. And listening to the board today is very enlightening, because I've been hearing so many challenges we face, and we've also heard so many solutions. And I believe that there is a big disconnect between the challenges and the solutions, and getting the challenges filled. Because owning so many different health clubs in the New York, New Jersey area, from low end to working with Derek Jeter and running his clubs, I've met personally thousands of individuals. And we have the solutions to fulfill the challenges and the problems when it comes to that area in the community, but there is no connection. So with all the challenges there, I've had very few, if any, companies or government agencies come to me or any of my health clubs and leaders and say, we can use you guys to educate everyone and provide them the education they need and be a leader and a role model. And it has nothing to do with financing. So how do we bridge that gap and fix that connection from a community level? And in the second area is the corporate wellness, where I go into companies as a stretch therapist, as a massage therapist with my team, and we work one-on-one. Statistically proven, we have results that we can prove that have made a tremendous effect. But corporate wellness has been old school, and they think corporate wellness is an initiative. We'll give you a discount. We'll give you education. We're so over-endowed with education that people don't know what to do with it, and we need to simplify it. So if any of you can answer, how do we laser focus and have kind of an overall solution for everyone, make it simple for them, and bridge that gap to have those people who can help get to the door and help? Because I know my biggest challenge is, A, even getting someone from HR on the phone, and then try to explain to them what we offer. And if they're not interested in fitness or health, it's a closed door. So how can we get there?
I'd love to jump in there. It kind of goes back to the first thing I said. This conference's theme is the crux. We don't have an alignment of incentives. Imagine what would happen if all the benefit managers in the country were incented based on the health of their workforce. And then imagine the relationship that they would create with their benefit consultants, because then the benefit consultants would also be incented the same way. They would get to make more money, the better the health. And imagine what the insurance industry would look like and our healthcare professionals would look like if they got to make more money, the better the health. So the theme of this conference is the crux. We have to realign incentives, and it starts with business leaders. Until the business leaders of companies who spend the second or third largest cost of business on this wake up to the fact that they're not using basic business skills, capitalism, in the third largest or second largest cost of doing business, just from the incentive standpoint. The incentives are all it's a perverse incentive system. Brokers get to make more money the more insurance costs go up. Insurance companies make more money the more that the costs go up, and they can pass it on to somebody else. Nobody is incented to create better health. And that's what we need, is a better alignment. And I think the U.S. Chamber of Commerce is in a great position to say, business leaders, wake up to your second largest cost of doing business. Use the very tools you use in running business with controlling costs. And it's because they think, well, I can't drive down cost without driving away my employees. No, we're not talking about incenting for lower cost. That comes as a secondary. You incent for better health. And there's lots of ways to measure the health of a population.
Absolutely, that's spot on. Thank you so much.
Time for one more question. Right up front.
Actually, I have a comment on a question. First of all, I would like the slides from all of you. I think that would be very helpful. I have two questions, really. One of them is in terms of, in our corporation, we are very strong with the veterans. And if you would be able to share some of the experience that you have with corporate employees that actually come from the armed forces, and if music or other therapies, not only you, but all of you, if you have some solutions for that. And the other one is, one of the biggest challenges in financial services is the face that we have to our clients, especially the Platinum cards and the Centurion cards. It's the call centers. They are our face. And call centers and people that work essentially from home, data has shown, especially in financial service, are under the highest stress possible. Have you had some research or tools that you can share, or maybe look into the future? Because in terms of the retention, in terms of the absenteeism and the effect that it has at corporate America is significant in terms of that portion of our employees or colleagues. All of you.
Yeah, I'll talk about this for a second. Yeah, so I think that we really need to work around our ideas around stress, right? So there's a great book, it's escaping me at the moment. I think it's called Work Beyond Stress or Work Without Stress. But the idea is that stress is this word that we use that has this like multifaceted definition. We encounter stress in a traffic jam and the death of a loved one. We're using the same word. And so what we need to start realizing and really delineating is what is stress and what is pressure. Right? So a call center, someone working from home who has mounting stress is that mounting pressure. And it's just giving them opportunities to explore really the interior landscape and how they're perceiving what is coming to them and what they have to deliver. So it's an issue a little bit more around perception. There were a couple of other things that I wanted to just mention in relation to some of the other questions. First was about the personal trainer's question over there. And just a moment, just to jog back, I know we're over time, so I'll be sensitive to that. But it really is, it's this idea of culture shift, right? Culture shock and culture shift, disrupting the system. And that's what I've realized in my work, right? So the first year that I was in my job, coming out of the classroom, Seattle Public Schools, Minneapolis Public Schools, I was traveling all over and realizing I was just sort of spreading and scattering seeds in the wind. And so it was when I kind of came away from that work and looked at, like, where can I make the most impact? And it's just diving deep into where I am and where I'm planted and into those roots. And so two of our three pillars of our organization are around staff and student well-being, right? Not really around achievement or the typical things that you find in a school district. So it's starting to really look at how you're establishing culture and community, right? And then the only other thing I wanted to mention was, and I think the gentleman stepped out, but he had a question about healthcare and the connection. And I just wanted to make note of the fact that we do a little bit of biofeedback. And so we have some heart rate variability measures in our classrooms, and looking at our teachers' resting heart rates. And we come into a classroom, I'll come in, and before a 5 to 10 minute practice, their resting heart rates usually in the high 80s, low 90s. And by the end of the 5-minute practice, we're looking at high 60s, low 70s. We've had numbers of our employees go into doctors' offices, and they get in there, so they start looking at your heart rate. And we had one in particular who was pregnant, and she was in a dangerously high zone for her resting heart rate. And she said, can you just leave for a minute? I need to do my breathing, right? Daryl talked to you. You can think about your breath. We're always breathing, but you can think about your breath, and elongating your breath helps slow the heart rate down. So I just wanted to make note of that as it relates to healthcare specifically. And then I don't know if you have anything else to add about the veteran piece.
So the Creative Forces program, we do have a website on the arts.gov website that has a lot of resources, including papers, contacts that you can look at and reach out to various individuals on it. And I'm happy to give you the link and everything.
I'll just add one quick comment to, sort of tie together some of what you were saying earlier. But, so often when we think about changing a system, it can feel very daunting and overwhelming. And that's sort of a pattern of thinking and a mindset. And so much of how we are in the world is how we think about the world, and it's how we respond and react to the world. So even something as simple as, the difference between saying, I am depressed, it's a full association of you and depression, versus I have depression. It is something you're carrying with you, perhaps a burden, versus saying I am experiencing an episode of depression. It's the same experience, but how you think about the experience and react and respond to the experience makes all the difference in, the thought patterns that follow that. And how you approach it and how you think about it. And you can really substitute that word with almost anything. So when we think about changing healthcare and creating incentives that matter, I think ultimately it's about recognizing that changing a system is about changing a culture, but systems and cultures are just people. And each of us, when we think about changing our own mind and how we approach the world and what is and what we want it to be, we as humanity have undergone tremendous transformations. And even something as simple as smoking, which was prevalent, decades ago, has now almost been eradicated, essentially, and we've done it with diseases. So I think it's really about thinking about ourselves and our own minds and starting from there in our communities, and then ultimately culture and system changes ripple from there.
And Amita, you really hit the nail on the head. It really is a cultural shift, but it's also the individual and community approach, and it really does take those partnerships in order to advance the work that each of the panelists have talked about, and it also is important for these partnerships to occur with the employer community and with the consumer community. There's a lot of education that needs to occur, and it's great that the Chamber brought this together in order to continue this discussion. So please join me in thanking our great panelists this morning.
So we're going to take a quick break for lunch. Lunch is in the back, so if you could line up, and then we'll get the next panel, the luncheon interview, underway shortly. Thanks.
Please welcome Sinead Bovell, weekly advice for the young entrepreneur, Way founder and CEO, and Nick Desai, co-founder and chief executive officer, Heal.
Okay. Oh, great. You can hear me. Okay, so thank you so much for joining me here today over your lunch hour. My name is Sinead Bovell, and I am the founder of Way, weekly advice for the young entrepreneur. It's an organization that bridges the gap between millennials and the digital future. And so what do we mean when we say the digital future? A future in which many of the jobs we see today will be replaced by technology. And so how do we prepare millennials for such a future? One, by providing strategy consulting for young entrepreneurs founding their own startups. And two, by conducting monthly Way Talks on the future of business and technology, to not only educate millennials on how industries are changing, but to challenge how they think about the future. So today you're going to experience a preview or a shortened version of a Way Talk, where we look at the future of technology in healthcare. So without further ado, let's begin. We are living in a revolutionary time for healthcare. An industry that was once deemed one of the slowest adopters of technological innovations has now moved to be one of the leading industries in technology-driven mergers and acquisitions. In 2017, there were 44 health-based, digital-based acquisitions alone. Technology has disrupted healthcare from every angle. But there's one underlying theme in these disruptions: shifting the power from the supplier to the patient. Today, we're going to speak to one of the earliest adopters of frontier-driven technology and hear about how it started as a dissatisfied experience in the traditional healthcare business model led to a realization of a market gap, a gap that could be filled with technology. So please welcome Chief Executive Officer and co-founder of Heal, Nick Desai. I'm so excited for everybody to hear about your story. Just even reading it online, I was so fascinated, and it's so organic to your experience. So why don't you provide everybody with a little bit of background as to how you got started and how Heal works?
Great. Thank you, Sinead, and thank you to the Chamber. I'm Nick Desai. I'm the co-founder and CEO of Heal. I have the privilege, because of what Heal does, to give invited talks probably once or twice a month now over the last couple years, and have done so in my entrepreneurial career, but this is easily the most special talk I've ever given, and it's for a very personal reason. My 4.5-year-old son, Avin, is in the audience with me listening to his daddy do his thing on a business trip, so let's give him a round of applause. I don't know how excited he is, but I have butterflies in my stomach, and I never do. We started Heal because my wife, who's a physician, and I'm a serial technology entrepreneur, had a 7-month-old son, Avin, who we tried to get a hold of his pediatrician on a Friday afternoon for something we thought might be serious, an infection or something. We couldn't get a hold of the pediatrician. The service said go to the emergency room based on the symptoms. We went to the emergency room. We sat there from 4:30 to 11 o'clock at night, and the ER doctor didn't know how to use an infant blood pressure cuff. So my wife literally had to show him how. She's a nephrologist, but she knew how to do that. And on the way home, we were eating burritos, and that's relevant to the story. And she turned to me and she said, if there's Uber for driving you around, why can't there be Uber for doctors, right? And ultimately, that's how the idea for Heal was born. And we originally named the company Burrito Labs, and many of the early investors thought they were investing in a Mexican food restaurant, but unfortunately, it turned out to be healthcare, or fortunately. Heal has grown significantly and evolved significantly since then, and we're fundamentally different than the Uber for healthcare in that we're not a gig economy company. Our doctors are a full-time part and a strategic asset to the service we're delivering. And what Heal delivers is on-demand and on-schedule doctor house calls, 8 a.m. to 8 p.m., 7 days a week, 365 days a year. You get a board-certified, licensed medical doctor to your home, office, hotel. Most often, people do it at home. within 2 hours for an on-demand visit, and you can set a Heal doctor as your PCP. We're not just an urgent care on wheels. We're your family doctor in your family room. And the most important part of Heal is that we accept insurance, all major insurance plans. So the cost of a Heal visit is the same as the cost of going to a doctor's office, right? So you pay a $30 copay with your insurance when you go to a doctor's office. You can pay a $30 copay on Christmas Day or New Year's Day or Sunday for a doctor to come to your house. And that's the intro.
And so how many patients and physicians are using Heal today?
We have delivered 60,000 house calls to date, just over 60,000 now. And we have about 110 doctors. We're primarily at the moment throughout California. We are live here in Washington, D.C. and Northern Virginia. So if any of you are sick, hopefully not from the food, after this talk, you can, or sick of me, you can order a Heal house call and use your insurance and have a doctor. The important thing about that question is not the number of patients we've seen, because a routine Kaiser facility will see 60,000 patients in a month, right? And we've done that in 2 years. What's important about Heal is that in those 60,000 patients, we've delivered $41 million in healthcare cost savings to the people who are paying for healthcare. One of the speakers earlier said, people's incentives aren't aligned around saving money, and one of the other speakers made the point about integrating wellness. And my mother always used to say to me, we're from India originally, that recycling doesn't happen in America, right? Because it's not a way of life. It's not a financial necessity. In India, when you buy a thing that comes in a plastic container, you save the plastic container because you don't want to spend money on a plastic container, right? And that's why in our house, there's no Tupperware. There's just old yogurt containers. And anyone in here who's Indian knows what I'm talking about. But the point is, healthcare and quality healthcare has to be a way of life. And when you do it, and when you make healthcare accessible and timely, and you integrate the doctor in the patient's lifestyle, which is in their home, you can have a tremendous potential to save money. And that's what we do with Heal.
And so I imagine when you first entered the market, it seems quite intuitive, the idea of Heal now, but you were one of the first entrants. And so it's a behavior change for us to, order a doctor online. Was there more skepticism on the patient side or on the physician side in terms of bringing them on board?
The skepticism was primarily on the patient side, and I'll tell you why. Because there's a weird psychosis in the American patient that doesn't exist anywhere else in the world, which is somehow, healthcare is really hard to get, and I have to wait 24 days for a PCP appointment, and I have to sit 7 hours in an emergency room, but somehow that's how I know that healthcare is good, right? It's like a nightclub. Everyone only wants to go to the nightclub where everyone wants to go and there's a huge line. No one wants to go into the nightclub and be the first person in there, right? So, I don't know, I don't go to nightclubs, but it sounds like that's a thing. But it's a similar thing, and it's a weird thing. People ask, well, what about the quality of your doctors? What kind of doctor would come to your house? And I always say to them, the doctor you see at the urgent care that's working Christmas is a doctor who got stuck working Christmas at the urgent care. It's not the doctor you want seeing your kid or your parent or yourself, right? So the skepticism was on the patient side to overcome the mindset instilled by hospitals in patients. In fact, every time you read a report in America of best hospital, best healthcare, it's always places. It's not people, it's places. It's Mayo Clinic, it's Cleveland Clinic, it's UCLA, it's Cedars, these are places, they're buildings. There's nothing magical about the four walls of a building that deliver great health care. What's magical is who's delivering the health care. And if we recruit the best doctors because they want to deliver better health care, then the outcomes are in fact better. So that was a skepticism we had to overcome.
Yeah, okay. And so now there's telemedicine apps kind of on all sides of the industry. You have doctors sourcing information, you have patients sourcing doctors. Do you think now it's no longer even just a competitive advantage or a value add, having a medical access to medical facilities on technology? Do you think it's now a competitive necessity, and those who don't do it are going to fall behind?
Yes, it is clear that technology is disrupting the way we access and expect to access care, right? And that's a really good thing. And it's a really good thing in all of its manifestation, whether it's telemedicine or Heal or a chat-based approach, or someone mentioned a phone call saying checking on your mental health for people who might have depression or whatever the case may be. Yes, it is a very good thing. But there's an important difference, which is there's a difference between technology that is disintermediating the doctor-patient relationship or getting rid of or trying to replace the doctor-patient relationship, and technology that is reestablishing the doctor-patient relationship and making sure that there's a human being interacting with you, an extremely well-trained human being, interacting with you about your health care. We are doing that. We are reestablishing the doctor-patient relationship. And a lot of technologies out there, particularly telemedicine, and I speak passionately about this topic, are trying to say, you can talk to a nurse, you can talk to a doctor, one day it'll be a chat bot, and they can give you your prescription. But the problem is, first of all, a data point that may surprise you, when you use telemedicine during cold and flu season, and you cough into your phone, and you describe a flu, 98% of those patients are likely to get a prescription for an antibiotic. Okay. When you go to a doctor's office, that number is 46.5%. When you use a Heal Doctor, that number is 22%. Because most of the time, a cold is just a cold, and honey and lemon are going to do a lot more for you than an antibiotic, right? And the more important part of that is not that. We often say we come for the cold and we catch the cholesterol, right? What telemedicine or a chatbot are not going to do is look at you longitudinally, right? Look at the wellness and look at and talk to you about saying, hey, by the way, who was the teacher that did the deep breathing exercise? That was amazing, right? You know what you would benefit from? 1 minute, 3 times a day of deep breathing in your life. I went through a period when my son was sick of anxiety myself, and I went and saw a mental health psychiatrist. I'm not ashamed to say that at all. And he said, Nick, you don't have depression, you don't have this, you don't need medication. You know what you need? You need to close your eyes and breathe 60 seconds. And he gave me this technique 3 times a day. And I do it to this day. And I sleep better because of it. So we are able to do those things because we're in a patient's home. So technology is disrupting healthcare, but is not singularly a solution to healthcare. It is a part of an integrated healthcare solution.
And that really prefaces my next question, because one thing that really stood out to me on your website and in your business model is that, yes, you were technology-driven, but relationship-based, so the doctor is coming to your home. But we've seen this new wave of entrants that are almost more aggressive, and you can FaceTime with your doctor, and then that's the diagnosis, or Skype. So then I can assume, based on your answer, that Heal would not be the next step for Heal.
No, so we look at telemedicine or FaceTime or Skype, these technologies, as a way to extend a relationship. And it's a great way, and I'll give you a perfect analogy. I give this all the time to people. When I am away in addition to Avon, he has a little brother at home, Kiernan. When I'm away from him, and he's at home with my wife, I FaceTime him every night, and he loves seeing me, and I love seeing him. It's not a substitute for hugging him, right? It's not a substitute for being his dad in his house and raising him, but it's not bad when I'm far away. So there are times where your doctor won't be able to get to your house, or where you have a quick question about a medication, or you don't need the doctor in your house. And technology is a great way to enhance that in-home relationship that's established with the doctor for those simpler questions, for those remote interactions, for patients who might be on the road. Let's say I'm here in D.C. and I want to talk to my doctor who's in L.A., right? It's a great way to enhance a relationship, but not a way to replace that primary in-person relationship.
That's a great answer. And so now, as I had spoken a little bit before, it's this shift in the market towards empowered patient. And it's not even just apps or like Heal or a service like Heal. There's preventative medicine now with wearables and Apple Watches. But everything is now becoming decentralized. Yeah. And that's kind of the main argument for people that are against technology-driven healthcare, is that there's a loss of sight or transparency in healthcare, and it becomes quite decentralized. How do you feel about that? Do you think that there is a risk for healthcare to lose its quality?
I actually don't think so, because I don't think healthcare is very high quality right now. Right? Yes, someone made the point that we're in a sick care system. Yeah, if you have a rare or exotic disease or end-stage renal failure or a bad cancer, the great healthcare institutions and research facilities in America are the place you want to be for care for that. But America is not the place you want to be to stay well in the first place. Right? We spend 2.5 times as much as Japan per capita on healthcare, and our life expectancy is 5 years shorter in the United States than Japan. right? There's a reason for that, which is we're not educating our children about nutrition choices, right? That's not a part of our healthcare system. We're not educating our adults about the choices they make and the simple behavior choices that can affect health outcomes in a meaningful way. And when you hear the conversation in Washington, we are here in Washington, about healthcare policy, I always say people are talking about the wrong P's. Whether Democrat, Republican, whether you're a Bernie Sanders left person or a Trump right-winger, whatever end of the spectrum you're on, people are talking about prices and policies and premiums, right? They're not talking about patients and providers. And those are the right P's. Patient-centric, the only thing we buy in the United States of America where we don't know the price up front is healthcare. That is an abomination. Right? Forget about the fact that it costs a lot. We don't even know what it's going to cost when we walk in to a doctor's office or emergency room or urgent care. You get an explanation of benefits several weeks later, which is neither explanatory nor beneficial, and then you get a bill. And 50% of people with bad credit in the United States of America have bad credit because of medical debt under $250. These are not bills they can't afford to pay. These are bills they refuse to pay because they feel gypped by a system. If Domino's charges me $1 too much for a pizza, they will make sure they refund the dollar or I will destroy them on social media. But that cannot happen in healthcare, right? And so what I think, when I hear about J.P. Morgan and Warren Buffett and Jeff Bezos bringing price transparency to healthcare, or Heal bringing price transparency to healthcare, or healthcare being decentralized and out of the entering healthcare. And I'm not saying all of them, and I'm not bashing Facebook in any particular way, but I literally, while we were waiting to come on this stage, got an email from Lyft. They're going to be presenting at the AHIP, the American Health Insurance Plans Conference next week, where we're going to be talking about Lyft solutions in healthcare. Well, Lyft solutions in healthcare are about getting you to your doctor if you can't drive, and that's important, and that's good. Right? It's not as disruptive as a doctor coming to your house, right? And maybe that's a biased perspective, but my point is, if you built a technology giant that does social networking or does transportation or does goods and services like Amazon does or whatever it is, Google, all the search stuff, Google, the knowledge cataloging that Google does, those are your business competencies. The best companies in healthcare, whether it's Heal or anybody else, are going to be built by entrepreneurs who are obsessed about healthcare, and it's not an add-on or a bolt-on to the thing they were already doing in the first place. It is their obsession from day one. Renee and I, my wife, who I founded the company with, who was going to be the speaker here actually today, but she's at home. We're expecting our third kid, a daughter, and she's not able to travel. So now that she's thrilled, I'm sure that I told all of you that. But the point is, when we obsess and think about healthcare and clinical quality, which is her domain, and technology, which is my domain, every day. And those are the companies that are going to win at changing healthcare, just like Walmart didn't win at the internet of selling you things, and Amazon did.
Very good question. Very good answer, sorry. So now I want to open it up to anybody that has some questions. And you might have to shout because we have the mics up here. So. Oh, we have an extra mic. Okay, great.
Hi, Nick. How you doing?
Good. How are you?
Doing good. I'm Arnold King, and I own a business, consulting business. I got several questions. One, but how does data analysis play a role in your company Heal? That number one. And how does the trends, the healthcare trends in your company make a difference in Heal?
I think I couldn't make out the first question. Sorry.
The first question is, how does the I lost my. How does the trends and analysis in your company play a role with Heal? And my other question is, how does the healthcare trend play a role in your company called Heal? And how does the other thing play a role?
Great.
So I think you said, so how do healthcare trends play a part in Heal? Is
right.
that, yeah. Okay, so I think that was the one.
Healthcare trends are all in the direction of what we're doing, thankfully, for us, right? Which makes us either smart or lucky, I suppose, but it's probably a bit of both. The number of healthcare trends are going on. First of all, independent of healthcare, people are expecting more and more of their life to come to them, right? I don't think my son will ever learn how to drive a car Because whether it's self-driving cars or services like Uber, I think it'll be like me learning how to ride a horse. I never learned how. It's not a mode of transportation. It's not a skill he will need in his life, I don't think. Similarly, in healthcare, services are coming to us. So if my food's going to come to me, and my TV's going to come to me, and this is going to come to me, and my content's going to come to me, well, why not my doctor? Why not my physical therapist? Why not my lactation consultant, right? The second important trend that's happening in healthcare is the miniaturization of diagnostic tools and technologies, right? When we started HEAL, 3.5 years ago, the smallest ultrasound that was commercially available and FDA approved was about the size of a desktop computer, if you remember those little towers that we all used to use. Today, it's a gizmo this big that connects to an iPhone that our doctors carry around, right? That is relevant because it means we can do more and more things in the home, and people expect more things in the home, and we can do more complex care in the home. Another trend that is happening is healthcare is finally, Medicare is pushing this, is finally aligning itself around value and outcomes-based incentives, right? It's not, the measure of a doctor is finally shifting from how many patients did they crank through in a day to what are the outcomes they delivered. So if you see 12 patients, which our doctors do in a day, and spend 30 minutes with each patient, as opposed to 40 patients in 7 minutes, but you catch diabetes early in 2 of those patients. There's a flyer around here that chronic conditions are going to cost $42 trillion over the next 15 years. That's healthcare. That will bankrupt America if we don't catch the 70% of Americans who have hypertension. So these trends, the focus on value, the miniaturization of technology, and the increasing personalization, transparency, and expectation of things in the home are all things that are fueling the growth of HEAL.
Great question.
Data analysis, yes. So look, we look at data, and I could talk for hours about this, but the very short answer to the data question is everything we do is data-driven, and everything in healthcare should be data-driven. And there needs to be more engineers working more closely with doctors to make sure that I married my doctor, she wasn't my doctor before, sorry, but she is a physician. But engineers and doctors should be together and working closely together to make sure that the science and technology and the art of medicine are evolving at the same speed and together.
Yeah. Next question. Do you want to? There's a mic coming your way.
Thank you. It's fascinating to have doctors come to the home. I'm curious on essentially continuity of care. I'm sure you've got EMRs, but the notion of establishing a relationship with a patient, you mentioned you can head off some issues, preventive, if you happen to see something. But do you, when the physician comes to the home, is it someone who comes on a regular basis so they see things, they can coach the patient on, behavior change and all the things that we talked about this morning?
Yes. So yes, you can get the same doctor over and over. If you book your visit ahead of time, typically 24 hours to 7 days ahead of time, you can see your HEAL doctor. You can set for each member of your family in the app who you prefer as your HEAL doctor, and we will show you the next time that doctor is available. If you book for urgent care, then you'll get the doctor in your area that day that can come within 2 hours. The importance of continuity of care, though, is enhanced by the fact that we're seeing the home environment, right? We can see the mildew in the house, or we can see the neighbor's cat. You think your son has asthma, but he's allergic to the neighbor's cat. Or we don't have to ask you if you smoke, and most importantly, we can see the pill bottles. 50% of prescription medications in America that are filled and paid for are never taken by the patient. It costs $200 billion a year to the healthcare system, okay? A pill that's in your bottle is never, we don't have to say, are you taking your medications, or what medications are you on? We say, show us your pill bottles, right? So the home environment adds to the comprehensive nature and the continuity of care, because environmental factors, according to a Harvard Business and Medical School study, determine 80% of health outcomes.
Okay, and maybe one last question, or there's two. Okay, yeah, we can make time for two for sure.
Hi, I'm Ray, coming from the Ohio State College of Public Health, and I have a question about inclusivity. Are your doctors equipped to cater to transgender health issues?
It's a great question. I'm glad somebody asked it. And I'm going to tell you this in a funny story. We HEAL has a Twitter account like every company does. We're not as active or inflammatory as the current resident of 1600 Pennsylvania Avenue. By the way, Sinead is Canadian, so I apologize on behalf of most of us in the room. Sorry, I had to make that comment. I got a tweet, Heal, and I've monitored the Heal Twitter account along with our social media person, but I'm an obsessive founder and I monitor it. We got a tweet about 3 weeks ago, maybe a month ago, from a person. I always look at who's tweeting, right? And they said, does Heal serve the transgender and LGBTQ community equally? And I always want to know, like, what's this person's angle? Are they some right-wing, person trying to bait me into a debate? What's her angle? And I clicked on the person, clicked on the profile. It turns out this person who wasn't transgender is a porn star and escort. And she's asking this question, right? And certainly in the current, not the one we all know the name of, but in this current political climate, I'm certainly not the one to judge what someone does for a living, right? Or who they are. So I responded to that email saying, we treat all human beings with equal dignity and respect and high quality health care. And yes, our doctors are trained in treating transgender, gay, lesbian, and the health issues and mental health issues that affect those people. That tweet led to, because other people follow porn stars that have different political views, for our point, an outburst of crazy far-right tweets basically attacking Heal, right? That led me to saying, listen, if you don't believe that all human beings should be treated with equality, please unfollow us from Twitter, okay? And I said that because I honestly believe that. And that led to us becoming heroes in the gay and lesbian and LGBTQ community in San Francisco, and there was a whole newspaper article about this and all this stuff. So yes, we do treat transgender people, and it turned out to be a great marketing event, that little tweet. So who knew?
Way to stand your ground on Twitter.
Oh, and absolutely. And all human beings deserve health care. And by the way, all human beings includes I don't care what your immigration status is. We never ask the question. No doctor ever would. We don't care where you are. We don't care what detention facility or camp you happen to be in. If you are a patient, we will see you, period, end of sentence.
Very good. Yep. And you had a question here?
Hi, Nick. I'm Connor Grady. Oh, sorry. I'm just curious about whether the doctors that use Heal, whether they do that full-time or whether they do that part-time. And then more broadly, I'm wondering just how you sort of recruit doctors to the service and convince them to either give up time at their hospitals or to give up their own free time to use the app and see patients.
Yes. Sorry about little Avon. He has lost interest in me, clearly. And you want to come and sit up here with me for this last question? Okay, come and sit on my lap. But you got to say hi. Can you say hi, everybody?
Hi, everybody.
Oh. The answer to your question is most of our doctors are working with us full-time. And the answer is to the recruiting question, you can't fix medicine for patients without fixing it for doctors first. There are 300,000 primary care doctors in America, and they commit suicide at the rate of 1.5 doctors a day. There's no profession in America that with an average salary over $100,000 a year that has a greater job dissatisfaction than primary care doctors. Why? The number one complaint from primary care doctors is we don't get to spend enough time with patients. And that's not just a feeling they have. There's a Duke University study that suggested that for the average census of patients, the average pediatrician or internal medicine doctor has, to provide comprehensive quality care, they would have to work 21.7 hours a day, 365 days a year. Okay, they're set up to fail. And we tell them you can come out of that system, instead of seeing 40 patients a day, you can see 12 patients a day. You can use technology built by coders to replace the 55% of the time you spend on bureaucracy and paperwork, to spend your time with patients and answer the questions they ask and answer the questions they don't know to ask. And so we actually have a waiting list of doctors in every market we're in that want to work on Heal. In fact, my wife wants me to arrange a Heal visit for him here today so we can test out our new pediatrician. So that may be my next thing, but we'll see. But yes, you can't fix medicine for patients without fixing it for doctors first. Right, Evan?
Yes.
Yes, okay.
Awesome. Okay, I think that's it. Thank you so much. Great audience, great questions. And thank you, Nick. That was great.
You. And thank you. I just want to take a moment to say thank you, Sinead. I think the work you're doing to inspire and help young entrepreneurs, I appreciated meeting you today, but I think the work you're doing to bring in more entrepreneurs, hopefully more women entrepreneurs, more minority entrepreneurs, into creating businesses is amazing. There was a study I read just on the airplane flight here that women-founded companies are more likely to get profitable more quickly with less capital raised, and we should see more of them. Thank you.
Thanks, Sinead and Nick. We're going to take a quick break to reset the stage for the next panel, and then I'll get up. I need to say that working on immigration issues as well as healthcare issues at the Chamber is extremely important to the business community. We just saw a living example of people from other countries that desire to come here to the U.S. and that improve both business and society. So we are appreciative of Sinead and Nick's efforts, and we just want to give them an extra round of applause for the launch. So thanks, guys. So this is the final panel of the day before the mixed match movie discussion. I'm here to introduce Stephen P. Noeldner from Mercer, where he's a partner. He's a senior consultant in the total health management specialty practice, where he's recognized as a national expert in strategic planning, well-being initiative design, behavior change, and program management and evaluation. So I'm going to turn the stage over to you, Stephen.
Thank you, and thank you to the U.S. Chamber of Commerce and the sponsors of this event. And a pleasure to be here, and a pleasure to be with this panel of expert presenters in various areas of health and well-being. And I think we've got some really interesting perspectives that you'll hear today that play very well with what you've already heard this morning and earlier this afternoon. By the way, I live in Southern California, and I was just going to say HEAL is in my neighborhood, and I'm about to try it. I like that presentation. I'll introduce the individual panel members just before they speak. The format that we're going to use is to have each one speak about 10 minutes, and then we'll have questions and answers. I'll kick that off, and then we'll have questions from the audience as well. But first, I'd like to just start by setting the stage and giving a little bit of history of workplace wellness. And the title of this session, as you know, is From Evidence to Practice. So we're very fortunate to have David Anderson here today, who I've known for many years. I've worked with in a professional capacity, both as a consultant, placing his organization with employers, but also with HERO, the Health Enhancement Research Organization, that David has been involved with for decades. And David has done some of the seminal research in the area of workplace wellness. Some of his research that was contributed in the 80s related to some of the first studies that associated health risks to healthcare costs. And that really opened the door to much more research and many more innovations in employee health and wellness. So a little bit of history. Workplace wellness started in the 1960s and 70s in the United States when I was a mere child. And there were some very forward-thinking organizations at that time, like Xerox, the Boeing Company, Kimberly-Clark. And at that time, there wasn't a lot of research evidence to really support the financial ROI that's so important to many organizations for doing workplace wellness. It was really organizations that believed this was the right thing to do. So that was the start, and there were a few organizations that did this, relatively small handful. But then in the 80s, David and others embarked upon quite a proliferous amount of research that really supported the idea that there was indeed the possibility, with best practice well-being initiatives, to receive a financial return on investment for the sponsor. So what the financial return on investment was cost avoidance for healthcare claims costs. So through the 80s, the focus really became highly focused on physical health, tobacco cessation, and stress management. Those were some of the early workplace wellness. Even though earlier still, in those formative days, there was a broader focus on the broad elements of well-being that we've evolved back to in these days: spiritual, physical, emotional, social. And in recent years, we've seen more and more organizations shift their focus from just that relatively narrow focus on financial ROI. And by the way, that's still important to most organizations and still will be a foundational element for most well-being initiatives. But in addition to that, we have seen that financial well-being has been inserted into that spectrum, that broadened thinking about well-being. Certainly how well-being, the state of well-being, impacts absence, presenteeism, productivity, performance at the workplace. All those things are now contributing to a broader view of the value on investment, or VOI, of these well-being initiatives. So we've got quite a nice sampling of different perspectives that we're going to share with you today in the different presenters. And I'm going to start out by introducing David Anderson. I've already given you some hint that I know David quite well. David was a co-founder and former chief health officer of Staywell. Staywell was one of the pioneering organizations in workplace wellness. David was there for over 30 years. So has done a lot and continues to do a lot. He was also a founding member and the chair of the research committee for HERO, the Health Enhancement Research Organization, and again did some of those seminal studies in the 80s and beyond. David's also on the board of the Health Project, which confers the C. Everett Koop Award every year, and he's also on the editorial board of the American Journal of Health Promotion. He's a licensed psychologist by training and licensure, and he's got some other things going on now, but you may mention that yourself, David. I'm going to turn it over to you. David's going to talk about pillars of well-being, 3 of them in particular: culture, communication, and incentives.
All right. But first I'm going to talk to you a little bit about why I'm no longer the Chief Health Officer at Staywell. 2 years and 30 days ago, I was a Chief Health Officer at Staywell who wasn't feeling so well. And 2 years and 28 days ago, I woke up in the hospital. And I was surrounded by my wife, my 2 children who'd flown in from the 2 coasts. We live in the Twin Cities. And a fleet of doctors. And the fleet of doctors commenced to tell me that I had been admitted through the emergency room 2 days before. I'd had 18 seizures in the hospital, ranging from the baby seizures to grand mal seizures, before they finally figured out a cocktail of drugs to control them. That they had run every possible test they could figure out to try to figure out why I was having those seizures. And the only thing that they'd come up with that they had a great deal of concern about was that they thought I might have a brain malignancy. And that was a pretty defining moment in my life. In fact, I tend to think of my life as sort of before that moment and after that moment. But it was also, despite the fact that one of the drugs over the next month drove me crazy, literally. That's a story we don't have time for today. But despite that, it was really a moment of clarity as well. And the clarity was, it was time for me to step back and to really kind of take stock of my life and figure out what I wanted to do next. Hence, I'm the founder, president, and only employee of a company called Vision Next, which is trying to figure out what that might be. But it's given me time to reflect. And as I reflected on sort of our industry, the work we've done, what we've done well, what's not gone so well, the fact that smoking rates have basically are a third of what they were, and the obesity rates are basically 3 times what they were. And so what have we done well? What have we not done well? The inevitable conclusion that I came to is the only way that we're going to fix this problem at the population level, because we've got great tools, and I heard a lot of them talked about earlier today. We know how to work with people and help them change. What we need to change is the conditions surrounding the people. If the conditions surrounding the people don't get aligned with health instead of illness, we're going to get more illness. And so we need to align around health. And as I thought how that might relate to me, and again, how it related to me in my role at Staywell, one of the challenges for us always was getting that to happen in our client organizations. Because typically we were responding to a request for proposal for certain services, typically through HR. And the reality is that HR is an implementer, and oftentimes they're really great implementers, but they don't hold the keys to culture. The CEO, and I was pleased that Daryl talked about the CEO and the call to action there. The CEO holds the keys to the culture of the organization. And then I look at all that research we've done, and we haven't established that we can move the needle much at the population level because of all of these challenges. But what we have established is the connection between health and well-being And an individual's health, their costs, their showing up at work, and their performance when they are there are just so compelling that it's really hard to even put a number on it. And those of us, who've been in this for a while, if you go to the CEO and say, well, intuitively, what do you think? You're healthy people who are kind of feeling good about their lives, are they more productive? They're going to, well, of course. So for me, it's really thinking about, well, we need to get to the CEO level to change the game. And the compelling argument for the CEO is, your job is to drive the performance of the organization. If you want to be a great performing organization, of course you need a great strategy. You need to figure out a better way. HEAL's probably got a better way. I'm excited about that one, to see what happens there. You need to have operational excellence. So you need to have, talented people who know how to lead organizations. But at the end of the day, you need your employees to perform well. And there's lots of work being done out there. There's enormous amounts of money being spent on what's called employee engagement. And employee engagement is all about getting your people to really rally for the organization. The best definition I've seen is getting your people to be willing to walk through walls for you. That's that's just a great metaphor. And you can do that. And I saw that happen in the early days of Stawell. We had I think, I'm biased, but I think we had a great leadership team, and we were able to get people to feel that way. And we just had a unique culture. But engagement without well-being is the road to burnout. If you don't help your people have a better health and a sense of well-being, all the engagement in the world is just going to lead right into a brick wall. So from the CEO's perspective, that just is so intuitive that it's just hard. It's hard for me to believe that any CEO wouldn't just say, well, of course. And then they would say, well, what do I need to do? What do I need to do? And the answer from me would be, we need to change the culture of the organization. And, probably about 20 years ago, I think, and I'm not sure, but I think I coined the term, the 3 pillars of engagement. And I went out and started giving talks about this. And I talked about health as a core business value because I think it's that important. And I talked about culture being the big pillar. I had these crude visuals, this great big culture pillar, and then kind of a middle-sized communication pillar, and a little baby incentive pillar. And the notion was that's how I saw the relative importance of those things. So as I think about, those things, they're really as relevant to that big E, employee engagement, as they are to well-being. So I think you can use the same strategic framework of culture, communication, incentives to really attack both employee engagement in the short term, but also sustaining that over time by improving the health and well-being of your people. In terms of culture and well-being, the key there is really not to think of well-being as a program that you go out and hire a vendor to come in and do, but really to think about well-being as really a strategy that you're integrating into your broader cultural strategy. So, well-being and culture go together hand in glove. And so thinking about everything you do in terms of your programs within that cultural context and asking the question, how does this contribute to the culture of performance I'm trying to build in this organization, I think will answer a lot of the detailed questions. Communication, and there, when I say communication, people think about, I guess they used to think about brochures, now I think about emails and texts and all that sort of thing. What I'm really talking about there is communication as a strategy and changing the narrative, changing the little story that spins around in people's heads about their role in the organization, their health and well-being, why, the whys. You need to answer that person's whys about health and well-being, and you need to make the connection between health and well-being and the organization and the organization's performance if all of this is going to work together. One of the things that we've been experimenting with a lot lately are stories. Stories are really connected with that emotional thinking part of the brain. it just pulls those things out. And if you can connect that with real life experience, which is sort of up in the thinking part of the brain, a lot of good things will happen. And so we've been doing a lot of work there. Incentives. Incentives are a tricky topic that would take hours to really do justice to. My best advice there is to be very, very careful with any incentive strategy, because incentives are powerful and they can have all kinds of unintended consequences. And I think we've seen a lot of unintended consequences roll out through the financial incentives that employers have done without really creating the culture to support them first. And so as I've thought about, for example, financial incentives, to me, you say, well, okay, it's got to make sense from the employee's perspective. It can't just be something you do to people. You want to use the incentives to really kind of build into your cultural fabric the right way of sort of nudging people along. So maybe it is accountability. Sure, I ought to be accountable for my health, but you know what? The employer ought to be accountable for helping me too. So it needs to be kind of this two-way street. And it's tricky to think about that, and it's particularly tricky as we think about the discussion late this morning about diversity and trying to figure out, how do you roll out an incentive strategy that's going to work for everybody? I think it's kind of impossible, and I think that's why more and more employers today are beginning to migrate towards more of what are being called intrinsic motivators, but really they're trying to find a way of implementing an incentive strategy that's meaningful to each and every employee. So that's a bit about sort of what I've been thinking about lately. I got the good fortune about just under 5 years ago. Stawell went through some difficult years, and a new CEO was brought on board, and the CEO asked me, would I be willing to stay with the company and recreate the culture that we had they remembered from those early days? And I kind of laughed at him and said, no, I don't think that's quite possible, but I do think we can have a great culture here if we go about it intentionally and strategically and really within that framework I just described. So we've been doing a lot of those things on ourselves. We've created what we call a culture learning lab. And we're trying some things. Some work, some don't work, and we're learning as we go. So we're doing well-being. We're doing the well-being program on ourselves that we want our clients to be doing because we think it's the right way to do well-being. But we're also connecting well-being to all of our cultural values. We're having conversations about our core values as an organization. The CEO is admitting in emails she sends out to all employees that she failed to be accountable on something. Accountability is one of our core values. We're doing the things on ourselves that we think are going to be meaningful for employees. She, out of what she described as her big brain, came up with this idea of what we're calling Bean 30, which is a 30-minute shut down the emails, shut down the meetings, and have 30 minutes during the course of your workday, paid time. That's a big deal, where you're just dealing with your own personal well-being in whatever way you need to be doing today. So I know I need to conclude, but I think the key message here is well-being deserves to be and really needs to be a core value of an organization that's aspiring to be great.
Thank you, David. That's, excuse me, I think those are some, coming from the consulting side of the world and working with organizations on their well-being strategies, some of the pieces that you described around culture and communication, to me, are the most important. They're the magnifiers of anything that you can do. There needs to be a rich experience that individuals have through the course of their exposure to the Wellbeing Initiative, but that richness is partly enhanced by the culture that supports it and does it together socially and in the spirit of that esprit de corps and that engagement in the organization itself that I think makes all the difference. So thanks very much for sharing that. And we'll get back to questions at the end of the presentations. I'm going to shift now to Jeffrey Tulloch. Jeff Tulloch, he goes by Jeff, who is Vice President of the PlanSmart division of MetLife. It's their financial well-being product and service. And again, in the context of looking at this evolution of the broad focus on well-being and different elements, we know that, and I hope I'm not stealing your thunder, but we know that 60 to 70% of individual stress is somehow related to financial concerns. So hopefully that's just setting you up and not stealing any thunder.
Perfect. Setting it up perfectly.
All right,
yeah.
Jeffrey.
Yeah, so I guess my starting comments are sitting in the back here for the past few hours. I've being the person centered on financial wellness, whereas just about everyone else in this room is not centered on that. I felt a little bit like the miscast actor in the play. And Betsy, that was until you started talking, and then I went, oh wow, I feel less misplaced. But seriously, it's been really interesting listening to the conversations today, and I get a lot of credit to the Chamber to wanting to include financial wellness in this conversation, because there's absolutely a direct correlation to how financially well we are, or probably better said nowadays, how financially ill we are, and how that is affecting our health. So just to set that up a little bit, what's awesome now, particularly in the United States, other parts of the globe as well, is that we, the employees, have woken up to, I'm responsible, right? So I'll compare that to my parents. My parents worked their whole lives, and when they retired, they had a pension, and now they live very happily, and everything's kind of taken care of. So we've moved from this, generally speaking, this defined benefits world to this defined contribution world, and all of us have messaged, I need help. And that could be around retirement, but it could be about just basic budgeting or saving for some other event, college for your children or a wedding for someone down the road. So employees have started to beat the drum over the last, maybe 6 years, to use the general terminology a little more loudly, saying, I need help. And by the way, it's affecting my productivity at the workplace, because all of us are doing some level of financial work while we're working, right? Whether that's, I'm going to spend a few minutes Googling how much I need for retirement, or whether that's checking your bank account or how your investments are doing. So employees have started messaging this more strongly, that I need help, and I'd like help at the workplace because I spend so much time there, and I get my benefits at the workplace, and I think of assistance here for my financial needs as a benefit. So that's real exciting. That's kind of, this groundswell has started from the bottoms up from the employees. Part and parcel to that, the other side of that coin, employers have woken up to, okay, I'm hearing the employees cry out for help, and wow, if I can assist them, then that can help obviously retain those employees, attract new employees, but it could also drive and increase productivity. So if I can help people become less stressed financially, then they can in turn be more productive at the workplace. So a real interesting dynamic that we have now, where the public, all of us, have said, I need help. Employers are glomming onto that. So absolutely what we're seeing is the workplace is a fantastic place to introduce financial wellness programs, or most companies actually already have financial wellness programs. Maybe it's just 401k, but they they don't message it as a financial wellness program. So that's kind of a little setup of the employee and employer dynamic. For MetLife, the PlanSmart program, we've had this program in existence, for certain parts of it for about 20 years, and other parts of it about 10 years. We didn't start calling it financial wellness until 3, 4, 5 years ago, when that terminology became cool, and everyone started referencing it as financial wellness. So through that program, it's predominantly a mid-size or large employer program that we have. So we have a couple thousand customers where we have this PlanSmart financial wellness program in play. About 40% of the Fortune 500. We see a huge amount of employees every year. And through the years that we've been doing this and a huge number of people we've seen, we've started to really zero in the last couple of years on, all right, it's okay for anybody to have a financial wellness program, but let's kind of try to zero in on what works. And this is the real crux of the situation or the problem. And it's great that insurance carriers like MetLife, other financial companies like banks, entrepreneurs like the gentleman from Heal, they're starting to get into this financial wellness space more and more. So there's a great buzz, but if we don't keep our eye on what actually helps people get financially well, then we're just going to be going down this path of throwing a lot of stuff against the wall and not actually helping people go from, I'm stressed out at work, to, wow, I've got my arms around my budget, and I'm saving a little bit more, and I'm spending a little bit less, and helping everybody go down the right path. So for us, this is the equation that matters. And as I was thinking about this equation sitting here in the audience, I'm sure all of you are looking at this and going, duh, because this applies to health wellness as well. It never really occurred to me because I'm so blinded by the financial aspect. But what we're trying to do is get people to act, right? And numerous people have mentioned this throughout the day. That's about behavior change. And that's really, really difficult, right? And Daryl, I think you talked about needing a coach. I think you referenced kind of needing a coach to change the behavior. So we're trying to get people to act differently. So for me, that might be, I just need to save a little bit more in my 401k plan. For somebody else, it might be, I need to spend less eating out, every week. For someone else, it may be, I'm really underprotected from an insurance product perspective. I need to go that route. So the actions are all very, very individualized. And right now across the industry, the financial wellness industry, the majority of the emphasis is on this first part, the educate part. And the education is absolutely needed. We all go through our formative learning years where we learn basics, maths, English, social studies, so on and so forth. We actually even go to physical education, gym, but we never go to financial education. And we're a pretty bright population, so if we get more education, logically we're going to become more confident in moving forward and making financial decisions that matter for us. So the education is needed. It's absolutely foundational. It's where most of the energy is right now. However, if we just focus on education, we're not going to get there because of this behavioral change dynamic. So the second component is around access. And when we think about access, we think about having the right balance at the workplace of high tech and high touch. Right? So in a specific situation, I may not want to talk to anybody. I want to go online, use a calculator, do some research, get some information. Thank you, I'm done, right? Another situation, it may be really personal, and I want to pick up the phone and call someone or chat with someone. Another situation, I may say, this is really complicated for me. I'm really serious about this. I want to meet with somebody kind of face to face. So the access is realizing at the workplace, having multiple points of access, realizing that it's a population of many, many individuals, many, many needs on an ongoing basis. And then the third component is motivation. And the motivation, in my mind, has two aspects. The first is, David, you spoke about the importance of the company. So the HR professionals, the benefits professionals who are touting financial wellness, they have a huge role. And the word I often use is they need to be more courageous. They need to be more courageous, calling to the people, leverage these resources, more courageous in finding ways for people to access the tools that are available at the workplace. And that drives kind of people being motivated to go get assistance. But then building off of, again, Dave, something that you talked about is around culture. Many people talked about that today. So developing that culture where it's okay to take 30 minutes out of the day and do whatever you want. And if that's trying to get your arms around your finances, or whether that's to do some meditation, that's fine. But driving that right culture specific to financial wellness around, hey, we're here to help you, and it's okay to talk about each other's financial situations and talk about the tools and resources available. So just to close, we're trying to get people to do something, to change their behavior, to act, and in our minds, kind of starting with the education, but we have a lot more work to do around the access and the motivation.
Thank you very much, Jeff. As a matter of fact, some of my colleagues at Mercer have an area of practice in financial well-being, and they've developed some tools and instruments to help assess where people's readiness to change is and things like that. And they find one of the biggest predictors is and I think you've encapsulated it with this, is financial courage. You mentioned courage to try things, but this is actually measurable courage, the ability, the desire, and the willingness to take action on the things that you've learned, your access to those things, and now it's probably that motivation to actually do something with it. So a vitally important piece. We see more and more organizations, and as you suggest, many organizations beyond just the 401k, having many different resources available, everything from just managing a paycheck, day-to-day expenses, to paying for your kids' education, to new debt if you're a recent grad, and so many other things. So great to see that you've got a packaged solution that can help many. All right. I'm going to start out by introducing Dr. Garcia with some of his earlier career. First of all, we all salute you for your service to our country in your former roles as the 14th U.S. Assistant Secretary for Health in the U.S. Department of Health and Human Services, a 4-star Admiral for the U.S. Public Health Service, and a U.S. Representative to the World Health Organization. Thank you very much for all of those things. And in your more recent career, we're moving from early career to present career.
Yeah, exactly.
So Dr. Garcia spent a good bit of time at the University of Texas MD Anderson Cancer Center's Cancer Control and Prevention platform. He was the inaugural executive director of that program, and he was a member of the leadership team for the institution's Bold Moonshots program, which if any of you are familiar with that concept, there's some TED Talks around it and some great background that you can get on that. Currently, for the last little over a year, right, yeah. Dr. Garcia?
Happy birthday.
He has been the corporate vice president for health affairs for American Express, and he's a global strategic leader in health and well-being for American Express and its employees, and with the goal of trying to help increase their overall health and well-being. And today he's going to share with us some of his organization's Healthy Living Initiative, a variety of initiatives, and he's going to share some around performance, productivity, absenteeism, presenteeism, and employee engagement. Dr. Garcia.
Thank you, Steve. First of all, for the people that do not know American Express, don't live life without it, is the first thing I had to say. So you have an idea of the company. We're a millennial company. We're a female company. That means over 60% of our colleagues are essentially millennials and female. And even in terms of international, because we're in over 50 countries, we have buildings and offices over 50 companies, we are very the same. Mostly females, mostly millennials. We have a very highly educated, multiple degrees group of colleagues. We don't call them employees anymore. And we have also entry level. And I mentioned before, I asked a question about the call centers, because it's a challenge in terms of people that have to work 8 hours per day, only 30 minutes of a break, and they are measured publicly against the peer and in front of the managers. And that's by time and productivity. So that's some food for thought here. And it's not only peculiar to us, it's every financial company or any service company as well. When I arrived to Amex, one of the first things that I found out that when you ask employees in the past, colleagues now, essentially why you like to work here. So one of them is financial health, because we want every colleague of ours to have financial health. But the other three principal things are essentially flexibility in terms of how you work. The other one is inclusion. We essentially have at every level, every possible gender, every possible race, every possible ethnicity, every possible age group. And the other one was healthy living. access to the best services related to health. Healthy living is not the classic wellness program that you see. In the U.S., for example, and David actually worked with us for years, essentially what you have is an embedded urgent care center within the building. And we see thousands of patients per day. And we do all the preventive services except colonoscopy. So from mammograms to GYN care to cardiovascular to cholesterol, diabetes, and everything else, we do a screening for that. And but part of the thoughts that we have when I arrived was we had so much data sets, and Amex is all about data. It's all about the predictive analytics, how we can actually look at the data in a different way. And the first thing I found out, we have 7 subsets of data related to health, from the wellness center data all the way to claims, all kinds of disability, all kinds of surveys, all kinds of engagement, but each one of the sets was in a different division. The good thing of my position, I can bring everything together. And then we start having eye-openers. And then one of the things that happened was I was asked to start visiting the people on the 51st floor. And Jay knows what I'm talking about, and David as well. That's one of the most powerful floors in Battery Park in the entire New York City. And the concept there was to explain to them what we had related to health. And a couple of them asked me, Joxel, tell me what is the ROI for, because for us, that's a fixed cost that we have there. You have a big budget, you have a big budget nationally, and you have a big budget internationally. But what that means for us. So I said, well, give me a couple of weeks, I come back, and then I'm going to share with you some of the ROIs. And we start looking at the data, and yes, we have a fixed cost, but we start looking, for example, and we don't like to share data at all, like any other bank, but I'm going to give you just one number. When we compare ourselves with other of our peers in New York and elsewhere, we prevent more people to go to the emergency room than any other of our peers based on the data that we have. And not only that, we were able to measure that if you are in New York City and you're going to go to see a primary care provider, you are going to spend 3 hours going there and coming back to the office. What about if we see that primary care provider within the Healthy Living Health Center? So then we started realizing, like I was talking with Steve in terms of the issue, well, let's start to really measure what presenteeism is, because people talk about presenteeism in a negative way. I went to work with a cold, and I was not productive enough. And I have many different words that you guys use that I consider completely different from my perspective. A lot of people like to talk about sustainability. That is really good. That, for me, means that you're essentially staying in the same place. For financial service, that means you're going to go bankrupt. In terms of resilience, you mean that you were here, you had a crisis, boom, and what happened? You went back to where you were. I like to talk from the healthcare perspective. I'm talking with your example, resiliency. You have the crisis, but you don't go back to where you were. You learn something so important that you were able to create a delta that is positive. And that's how Amex people think. And I think that from the perspective of corporate that you can learn here is that mentality of looking at the ROI, not from the perspective of pathologic disease and cost, but what are you saving and what are you providing to our colleagues. That's one. The other thing for us, and for that table specifically, Healthy Minds. That's a big program from ours. It's associated to our employee assistance program. And that's one of the game changers for us. It allows for every diagnosis related to mental health disorders to have 8 visits with a provider or mental health. So you may have 4 mental health diagnoses. You have 8 visits for each one of them. That's extremely important for us, because if the colleague is not mentally fit or is under a lot of stress, under a lot of anxiety, or has a depression, trying to get access to a psychiatrist in New York, in Phoenix, in Florida, or anywhere is honestly, it's almost a miracle. It's easier to get an oncologist next day in Memorial or MD Anderson than to find a psychiatrist in New York City in 1 month. So having mental health program embedded within our clinics is really important. In every clinic we have mental health specialists. And this is a game changer for us, really a game changer. The other thing that I would say and goes to David's point, is the CEO. We are blessing Amex that the CHRO is essentially not only the partner of the CEO, is the succession plan leader. So companies like ours are thinking for 20 years the succession plan, so they have to be aligned together. So the culture comes from the CEO, the board, and the CHRO. It had been measured before in terms of the importance of alignment, but with the CEO, the importance is it just becomes not a health issue, it just becomes a business issue. Steve, our new CEO, said, there's no divisions. You're not IT, you're not health, you're not finance. All of us are in business, because if any one of us fail, everybody goes down. So the brand is extremely important for us. Having the brand of health and healthy living is extremely important for our organization. And so it had been mentioned before in terms of quality of healthcare and access to healthcare. So that's of paramount importance to us. We are a population health organization. We're a population financial health organization. So social determinants of health is actually easier for me to find in my organization than actually to find from the financial people who is the customer. Because by law, as you know, they cannot ask you your race, your ethnicity, because that would be going against trying to bias against credit. But in health, I can ask those questions. And it helped me significantly when we're creating plans to help our programs or initiatives. And we have one, I think, with Jane that we are going to be launching as well. So it's create things that are tailor-made, not one medication fix everybody. And I think that the other thing that we have, which is really of paramount importance, is we have groups of interest. So we have cancer survivor groups, we have diabetes groups, we have asthma groups, we have parents groups, and they actually give us a lot of feedback. So before we actually get the data from claims or the data from media or whatever, already our own colleagues are telling us essentially what's happening in their own household. And that's extremely important. The other thing is we use our clinics as sentinels. Give you an example. In January, we had more flu than the rest of the entire 2017, in January this year. So we talked with leadership because the absenteeism, it was affecting everybody from the 3rd floor to the 51st floor. So if anyone outside, some of the people here have gone to Amex, it's easier to go to the Department of Defense that actually enter Amex. So a lot of people say, can we have lunch? And I said, yeah, there's several restaurants across the street we can go. But you have to be fingerprint. Every day I had to be fingerprint to enter there. So it occurs to me that if it's flu season, a lot of people don't wash their hands, and worse than that, a lot of people put their finger in their nose or whatever other place, which for me, I have a phobia to the fingerprinted thing because I know that I have boogers from other people before me in my fingerprint. So we changed the methodology now. After you finish fingerprinting, there's essentially sanitizers, very ultra-modern sanitizer. And I mentioned that because it should be in every corporation, as a matter of fact. And And the last thing I'm going to say, and it's part, you guys have been talking about Walmart, Amazon, all that. We're part of the inaugural founding partners of the Health Transformation Alliance. And essentially, we are Fortune 100 companies that are closing together. We're over 40 right now. And one of the other partners has been IBM, and we work very closely with IBM, Watson, and Truven. And mention that because whatever you're doing, whatever initiative you want, whatever impact you want to do into your colleagues and your partners and so on and so forth, has to be based on data. And that data has to be applicable to the different situations. One of our partners is right now looking, I was talking earlier about weather patterns will define essentially the health conditions in different parts of the country. And I'm not talking about weather in 200 years from now or 50 years from now. I'm talking about weather tomorrow or Friday or next week. And depending on the condition that the colleague has, how is that going to affect the productivity at that day? And I think I'm going to shut up right now. Oh, yes, one thing that we do is in Amex, we're very into CVP, colleague value proposition. So essentially what we are doing is using health as a value to indicate how productive a person can be. So with that, I'm Minaya.
Thank you, Jaxel. I was really grateful that you mentioned your CEO's commitment to this as a business proposition, well-being, and all of your departments working together. David and I were, this is a plug for the Health Enhancement Research Organization, not-for-profit, some of the research that was done. And David and I were co-authors on a study just a couple of years ago for stock market study. And we looked at organizations that took the HERO scorecard. It's a best practice scorecard free to organizations to complete. And high scores on those, on the HERO scorecard, were associated with the organization. We essentially took the high scores and built our own portfolio, if you will, and then compared it to the Standard & Poor's 500. And in our study for a 6-year time frame, we saw 58% outperformance by that portfolio of organizations who are committed to wellness best practices. And so it's not a cause and effect relationship, but at least there's an association that organizations who are committed to health and well-being also do better as businesses. So that was important.
If you really want an investment opportunity, look at Coupe Award winners. Another study was done on Coupe Award winners, and they looked over a 14-year time frame and essentially created a portfolio of Coupe Award winners and just ran it like a regular, like a mutual fund would be run. And in their case, they outperformed. I think it was 325% appreciation or something like that, and in the Coupe group, and about 105%. It was the 2000 through 2014 timeframe. So there was a lot of downs during that period. So it's like 320% to 105%. So a 3 times return on investment. So that's again, that's part of the ROI that the CEO is looking at is, I need to drive my stock price higher by creating value for shareholders.
We have a question from the audience already, so we can just go right to the audience. I've got some other questions that we can sprinkle in as well, but is there a mic for this gentleman?
And I'll go call Jordan right now.
What would be your most successful preventive wellness initiative for general health for your employees? And then what would be your biggest opportunity for either improvement or to add something new?
I think that the most impactful that I have seen in my short period of time with Amex, it has to do with when we have any catastrophic event. It doesn't matter if it was Mexico, London, Paris, Florida. We were there and we were impacted. So Healthy Minds really make a big difference for all of us. So that's from the Healthy Minds perspective and the support that we gave to all our colleagues and their family members, because the EAP is for the family as well. From the prevention side, I would say that we have a virtual nutrition support, and we have, in every clinic, we have nutritionists there. I would say that Know Your Numbers, which is a campaign that we have to look at your cardiovascular profile, including your cholesterol and so on and so forth. And then the other one, and that is in your area of, actually I will tell you more if you get me an autograph of Derek Jeter, and then I will actually give you some actually even better numbers. I'm a Yankees fan, man, big time Yankees fan. Yeah, so I think has been the issue of combining fitness and nutrition. We have a fitness center in our building, state of the art. We also do physical therapy there. It's an entire floor. And we also have one thing I would suggest to every corporation is what is called a stealth diet. They cook with low fat. The offerings are always low fat unless the person asks for butter or things like that. Everything is cooked with oil. We have a healthy living menu. So the prevention campaigns and all that is great. It goes back to Jeff's point in terms you can educate as much as you can, but if you don't change behavior. So the issue of talking about nutrition is the education aspect, but then having the stealth diet, it changed the taste that they have, and then they can do it at home as well. So that's one. But the biggest challenge that I have and the opportunity is the fitness center. And the reason is it doesn't matter how much I would like to work in that fitness center. I use the one in my building because the hours. And so the higher you are and the early entry that you are, it's more difficult for people to actually work out in a fitness center within the facility. Is the ones that essentially have a better schedule. So that's an opportunity. That's something, I'm not kidding, we should talk about that as long as you get me the autograph. So no, just kidding. But it's an opportunity in terms of how we can actually move the time for that. Because we can do that with the Healthy Minds, but we cannot do that with a fitness center. So.
I have a question we'll get you in just a second, sir. I have a question for Jeff. And it's a statement first, and then maybe how you would approach it, or how you would react to it. Recently came across a study that was done that introduced this hypothetical situation to the study participants. And it was, you're faced with a $400 emergency repair of your automobile. And then there was a cognitive function test after it. And even though this was hypothetical and it wasn't real and they didn't get the bill, cognitive function was impaired by the thought of having a $400 car repair. And this wasn't a select group of people that necessarily were lower socioeconomic or anything like that. So do you have thoughts about that, and how does your program and the services you offer address things like that, the general concern?
Yeah, so this is going to be, I think, a pretty broad response, but I think that's very real for a lot of people, and I think that's regardless of the financial situation you're in, right? A shock is a shock. I'm not expecting whether it's $200 or $2,000 or $20,000, right? It's a shock. It wasn't planned, so there's stress around that. In terms of how you solve for that, it's really hard, you know. And when we did some research about 18 months ago with employees specifically, everyone said, I get it that I need to plan and save for the long term, but I can't get there because of this kind of short-term stuff in front of me, whether it's just budgeting day to day, paying down credit cards, paying student loans, dealing with the boiler breaking in the house and having to pay for that. So it's going back to the kind of education approach. If you're focused just on the big things, saving for a kid's college education, saving retirement, we're probably missing it. We really need to get back to the basics of dealing with, do I understand my paycheck? Do I understand the basic of taxes? Do I understand basic budgeting? And from there, then you kind of build up in terms of how you help people.
Yeah. And the point is that it's important to be able to help people in those situations because it has an impact on productivity at work. If they're impaired by a hypothetical situation like that, just imagine real situations that can occur every day and what it can do to presenteeism and absenteeism and performance. That gentleman, I think, was the first to raise his hand. If we have a microphone for him, please.
Thank you. My two questions is, number one, how is population health going to play a significant role in your company statistic-wise? Number one question. And number two, how do you choose health incentive for your business? Do you choose then based on the health employees and others? Those are my two questions.
I can start with the last one. We have a very comprehensive health benefits for all our colleagues. That's an added value to be able to work in Amex. We feel very proud. We actually have one of the best family leave opportunities right now. Is over 24 weeks now that we have for both parents. And so we have a lot of benefits. We see that not as a burden, but a way of getting the best possible colleague. We're in a world of competition, so you want to be the best in what you do, but it's like baseball. You can be the best player in the world. If you have back pain or you blew your knee, you were the best possible before that happened. So you have to be healthy and all. You see, the system, from leadership to the entry level, the system is as strong as its weakest link. So it's like in the military. It's like when I went to Afghanistan, I wanted to help the entire healthcare system in Afghanistan. You cannot start going for the big one. You have to understand what is the highest risk that you have. So I would say that we don't see benefits as a burden. It's an attractive offering that we have. I mean, what do you think?
Yeah, I think I'm going to reiterate what I said before around some of the basics and simpler building blocks, and you build from there.
And make sure that the colleagues know what they have for a benefit. Because you will be surprised how many people and how many companies you have great benefits and no one knows. In our company, repetition happens all the time. So I think I drank the Kool-Aid in day number 2, and I was essentially blue already, so, or platinum.
I'd like to quickly respond. Your first question was all around healthcare and healthcare trend, and and my general response would be, if you look out there across the environment, the thousands and thousands and thousands of companies out there that are doing anything from nothing to very little to maybe meaningful things around health and wellness, the overall numbers aren't very good. And to find companies that are just doing outstanding, in other words, their healthcare costs aren't going up as much as others, and we saw the one example that Daryl gave of actually costs going down, and their health trends are getting better. Those are the outliers that win the Coop Award. Well, last year there were no Coop Award winners, 0. I think there were 3 honorable mentions. We don't see a lot of those. I think Amex was an honorable mention. Amex has got a great program relative to the rest of corporate America. And that's the point of that I was making earlier. We have to fundamentally change how we're doing health and wellness in this country. And I do think it begins with employers, because that's where people spend a majority of their waking time. And start bringing some of these really high-level strategies in. But until we confront the notion that it's the culture and the environment and the conditions that we create around people that has the major impact on their behavior. We can help them, but I liken it to swimming against the tide. You can do it for a while, but it's really, really hard. So, realign the tide is the message. So, and I think what I'm saying is you can get there. There are numbers out there. There's good, solid research that says it's doable, but the majority of organizations aren't close yet.
One more point to add, especially for the multinationals and companies that bring people from international markets. Our healthcare system is really difficult to navigate. And if you come from Asia, or you come from Latin America, or you come to Europe, and they start working in New York or wherever we have an office, especially they are millennials, or it doesn't matter how high an executive is. For many of them, it's the first time that they got in their hands an insurance card. For many of them, they have no idea that you cannot go to a doctor's office and just go there and say, I want to be seen, I have stomach pain. No, it doesn't work like that. So one thing that I would recommend is the education that you do to the colleagues that are coming from abroad, because they don't know how to use the healthcare system. And talking about measurements, in pregnancy, when people come from other countries, they don't know about the issues related to prenatal care in the United States. And we are measured in terms of high-risk pregnancies as well. And so that's something that I always like to share, because it's a real thing that we deal every day.
My name is Melissa Habedank, and I'm a public health educator and consultant. My questions are primarily for Dr. Garcia. You have operations around the world. You've talked a little bit about the uptake in New York of some of the mental health clinics on site and the urgent care providers and even some of the support groups. I'm wondering about what uptake is like in the other countries where you have offices. Are there similarities and differences to headquarters?
So we have 26 clinics internationally, and when I say 26, it's more than that, it's a different subsets. We have to go by the law of the state, so if they need doctors to provide care, we will have doctors. If they need nurses, then we will provide nurses. I can tell you that in Mexico, we see in our clinics over 50,000 people per year, and in India, over 100,000 people per year. That's, I think, is a pretty good uptake. And this is something real. And the reason is, in many countries, that's the only opportunity that you have to really have access to care. A lot of people talk about insurance. In many countries, insurance is when you get sick, starting with Mexico. There's no prevention services provided. So they use our prevention services, and then they have double insurance at that time, because they use our insurance as well. But they use their state-sponsored insurance for when they get sick. But for the mammogram, the colonoscopy, the pap smear, they use those. And that's a real example.
Any other questions from the audience? Yes, we want to wrap and get to the... Want to follow up there?
For Dr. Anderson, your company is well established, and the question I would ask you is, for a new company, somebody who is just coming into the industry, what would be your advice in order to break through? Would it be to merge with another company, or would we take a road such as you took and kind of build and continue to grow, and how would you go about that?
Easy, yeah. I'm actually working now with several startups, they've got a difficult road to hoe, because there are the Staywells, so the Optums. I mean, what is Optum? A $27 billion company, but being big doesn't make you good, and there's a lot. There's a lot to be done in this space. And I mean, the HEAL presentation during lunch, I'm going, wow, that is so frickin' cool, Uber doctors, So, there's great opportunities for innovation, I think, and even for example, in the work site, there's sort of the established way of doing health promotion on the work site historically has been people do a health assessment at the beginning of the year, and they might go through a screening, and then there's some outreach, and then there's a few sort of activities, challenges and that sort of thing. And then the calendar turns January again, or September or whatever, and you kind of start all over again. And you look at that and go, well, that's easy to implement, but is that really responding to, the employees' needs? So, my thinking for the industry is if you can get sort of the mindset of looking at it through the filter of the employee and saying, if I were the employee, and what would I want, and what do I need, and what do I feel like I need to be doing? What's my role in this? And of course, you want that role to become more and more active. But I think there's a ton of space now. How you get from being really little to big and staying good at the same time, that's a challenge. But there will be winners. There's going to be a lot of losers. There's a lot of people out there doing a lot of things. But I mean, that's the nature of innovation, And this is a time, it really is. I think, and Stephen, you probably see it from your consulting role. There is a lot of innovation going on right now, and so I encourage you to just open your mind.
Tremendous amount. I can follow up on that. Mercer has an innovations lab, so we are looking at startups and not to invest in them, but to sort of nurture some of them and identify, and we bring together employer groups, large employers, have a seat at the table to take a look at what the innovators are doing, and that helps drive further innovation. But at the same time, and I think we need to acknowledge that the marketplace right now is very crowded, lots of mergers and acquisitions, venture capitalists coming in that weren't there before, buying up two competing organizations and putting them together. So we're seeing a lot in the space, and it's just accelerating. So that's neither good nor bad, it just is. So don't consider it a barrier, just consider it knowledge that could be beneficial if you know how to work with that.
Getting the market's attention may be the biggest challenge right now.
That's it. Yeah. Yep. I think we need to wrap, Michael. So thank you so much, everyone. Again, thank you to Michael and to the U.S. Chamber of Commerce and Pfizer and the other sponsors, and to the great panelists who hopefully gave you some really good insights into things that are being done and could be done. Thank you.
All right, we're going to get started. I know we're running a little bit behind. My name is Elise Cohen. I work at the Chamber of Commerce Foundation. We work with businesses on helping them do well by doing good, and I lead our health and wellness and food portfolio. So today it's my pleasure to introduce our final speakers. I am going to butcher their names, but they already know that. Athena, here I go. Asclepiadis and Randy Rutta, who will discuss perspectives of mixed-race blood cancer patients and reflect on multi-ethnic identities and complex genetics, and share more about the Mixed Match documentary. Athena was born and raised in Los Angeles and holds a broadcasting degree from Pepperdine University. While pursuing her career in Los Angeles radio and voiceover, she began working in the multiracial community on various blogs and websites in the early 2000s. After recognizing a lack of mixed and minority bone marrow donors, she started Mixed Marrow in 2009. Athena was most recently associate producer for award-winning documentary film Mixed Match, and currently operates Mixed Marrow, as well as serving on the board of Multiracial Americans of Southern California and other Los Angeles festivals and events. In 2017, her work with Mixed Marrow was recognized by the Los Angeles mayor, highlighted in Oprah magazine, and she was the recipient of the 2017 Awareness Award from Be The Match. Mixed Match is an important human story told from the perspective of mixed-race blood cancer patients who are forced to reflect on their multiracial identities and complex genetics as they struggle with a seemingly impossible search to find bone marrow donors, all while exploring what role race plays in medicine. With the multiracial community becoming one of the fastest growing demographics in North America, being mixed race is no longer just about an identity. It can be a matter of life and death. Randy Rutta is a senior healthcare executive dedicated to policy to practice solutions that interpret, influence, and improve federal and state healthcare policies to enhance public and private sector healthcare innovation, outcomes, and efficiency. He serves as Chief Patient Advocacy Officer for the Partnership to Fight Chronic Disease, a national coalition of nearly 100 patient, provider, and community organizations, businesses, labor groups, and health policy experts committed to raising awareness of chronic disease in America and globally. Please join me in welcoming them both.
Thank you. Thank you so much, Elise, and thank you, everyone. You know, there's such a benefit to coming at this point in the program because so many great things have been said that we can reference and build on. And Elise just saved you many minutes of my presentation through my introduction of Athena and myself, so thank you for that. I think you'll be really excited to hear from Athena, just to meet her. She is literally inspiring people across the nation and the globe to think about and participate in bone marrow registries. And by focusing on a population that experiences mixed race and ethnicity and challenges that that might carry with it, she is literally inspiring people to be involved in bone marrow donation, and that's saving lives, which is pretty incredible. So it's an honor for me to be here with her and have you see clips from the film that was just described and be excited and motivated and inspired as I have been. As Elise mentioned, I'm with the Partnership to Fight Chronic Disease. We're excited to be a partner and supporter of today's program, and bravo, Michael and your colleagues and everyone who's been participating for an absolutely superb program. The content has been great. The speakers have been great. From the perspective of the Partnership to Fight Chronic Disease, as Elise said, our sole purpose is to raise awareness of the presence of chronic disease and what that means in healthcare in America. You know, 86 cents of every dollar spent on healthcare is going to support chronic conditions, both treatment and management of chronic conditions. People are struggling with chronic conditions. People of working age typically have 2 or more chronic conditions. And what does that mean in the workplace in terms of productivity and global competitiveness, and literally the ability of people to bring their whole selves forward when they also have a chronic condition. And I so appreciate the conversation today, which was focused on wellness, certainly wellness efforts that speak to the entire set of employees, but that's particularly germane for people with chronic conditions who you may or may not know are really challenged by that, or are caregivers to people with chronic conditions at home, and that adds a level of stress and challenge for them that everything we talked about today really is helpful to and provides hope for those individuals. But that burden of chronic conditions in American society and in the workplace is staggering, and it's something that I think the ideas that were offered today, the innovation that was offered today, what we just heard that Amex is doing absolutely speaks to that growing number of people with chronic conditions and that growing prevalence that society, that employers and employees have to manage. So I just applaud that, Michael, for that level of attention. You know, and as Elise said, the focus of Athena is really looking at that diversity, and in the same way that employers have been paying attention to and being creative about supporting wellness in the workplace, they've also been recruiting a more diverse workforce so that that talent and that richness of experience is present in the workplace. In the same way that we as Americans, in a society that's become increasingly diverse, have the opportunity to experience the richness that brings to all of our lives. But it's interesting, and I think this is something that Athena will talk about, is the presence of that mixed race ethnicity, be it racial or ethnic or other kinds of backgrounds, can be very positive in many ways, but it can also create challenges in finding that right match of a treatment to then what it is that you might need to support your health and wellness. And I think that's really one of the things that motivated you to work in this area. She did join forces with Canadian filmmaker Jeff Stearns, as Elise mentioned, and I've had the opportunity to see this film. It's amazing. You'll see clips from it and hopefully be inspired to go to the website and see the trailer and the program itself. But I did get to know Athena, and actually, Michael, you participated in the screening that was held here at the Smithsonian. Across the country at film festivals, college campuses, and institutions, you've had the opportunity to share the film that we'll be sharing today. And it truly is unique and remarkable. So thank you so much to you, and thank you to Jeff, who I know is here with us in spirit. But why don't we get started, Athena, and just maybe you could talk a little bit about how you came to be interested in this area, you became aware of the need among ethnically and racially diverse individuals for addressing this challenge of being in a registry for bone marrow, or even better, if you are having a need, a health need, being able to then find a match through that system.
Well, my journey was a personal one. My aunt died of lymphoma in 2007, so I was really wanting to get involved in something cancer-related in her memory. But I felt like some of those run walks, they were good and all because they were raising money, but I just felt like I needed something more hands-on. And as a non-medical professional, I just really struggled with what can I do that really makes a difference. And it was kind of coincidental that I happened to attend a festival, and I was approached by a young woman's family that were registering donors, and she was also half Japanese like myself, and she was searching for a match. And up until then, I had been kind of involved in the growing number of organizations that were kind of sprouting up of mixed race communities, which is a thing because we as people that are biracial or mixed race, we don't really have a tangible physical community unless you go to places like Hawaii or Brazil. So a lot of them were sprouting up biracial communities online, and that's how people were sharing experiences about being in a dual or multicultural home, and what that means. But the idea of disease or medical kind of things weren't really being discussed. So when I heard she said, oh, she needs a donor that is likely half Asian or mixed like herself, I was really intrigued by that because I didn't know what role, if any, played. And that's, we're told a lot of things that we're the same, and we, blood type is similar across races and things like that. But when it comes to your DNA and your inherited genetics, it's a lot different, and there are trends geographically amongst people. And so that is why I kind of wanted to learn more. I started volunteering with the local Los Angeles group A3M, which is more Asian focused, but I wanted to particularly dive into getting more mixed race donors because I knew it was a very fast growing demographic, and I felt like there weren't a lot of voices from our particular community saying, I want to help mixed race people. And so Chrissy Kobata was my first patient. And at that time, it was only a year or two of her searching. It turned out through the course of filming the film over 6 years, she ended up searching for 10 years with never finding a perfect match. And that spoke to me because I'm like, wow, it's such a issue. And why are minorities and mixed race people not registering at the same rate as Caucasian donors? And a lot of it is access, a lot of it is cultural barriers, language barriers, which I feel like there was so much work to be done there. And my background is actually broadcasting, so in the beginning I knew I wanted to do something media related because I feel like that's the best way to tell stories is through video or through taking the time to see these messages in a emotional way, not just a flyer.
Should we ask that the clip run? I think it shows Chrissy, if I'm not mistaken.
Oh, okay.
Yeah.
No doubt, my mixed race heritage is the reason why it's so hard to find a match. It's not that, it's just, if you're Asian, it's harder to get a match. No, it's just that there are less Asians on the registry. Then you take mixed race people, and there's no one on the registry. So you go from a pool of 11 million people to try and match your DNA against, and you take that down to maybe, 20,000 people. You're essentially trying to find your DNA twin out of 20,000 people. It's impossible.
So I think she really makes that point. So that understanding, you said, wondering why this was the case, led you to create a new organization.
And I mean, from the beginning, it's been like all volunteer run. I have amazing people in New York, in Washington State, not Washington, D.C., that just host drives that go and talk about it. And it's been really a passion project for me because my field is not medical, and I do this because I love it and because I feel like people like Chrissy need a voice. They need somebody, it's quite the challenge when you're fighting your disease and then you're having to pretty much petition the public to save you. It's a challenge that these patients definitely, diverse patients or not, any patient searching for a match really needs the public's help in spreading the word.
So that organization is Mixed Marrow, and the name of the film, as you know, is Mixed Match. So thank you so much for putting it out, and we'll be able to learn a little bit more about your organization. And by the time we finish, definitely share some contact information, how people can go to your site and really learn more. Why don't we see if we can't see our next clip and learn a little bit more about, what have we heard about bone marrow transplants or other transplants? What do we need to understand about the process of finding a match? And we know it's difficult, so maybe we can see this next segment and that'll give us some insights.
Let's say you have a parent that's Caucasian and a parent that's Chinese. Well, you could inherit two types of HLA from each of your parents, where that HLA is very common within the Chinese and very common within the Caucasian population. Where they're not common is together, and that's what makes it very difficult to find a match on the registry unless you have a group of multiracial individuals that have been recruited that happen to carry those similar haplotypes.
Stephen mentioned that there are millions of HLA combinations, and in order to replace a failing immune system, as in the case with many blood cancers and diseases, it's important to find a donor who has the exact same genetic HLA markers. This helps reduce the risk of graft versus host disease, where the new immune cells attack the body, and ensures the blood stem cells engraft successfully after the transplant.
So what you're seeing there is Jeff Stern's work. He was an illustrator originally, very focused on children's programming, and I think that is his focus right now, but clearly found you, Athena, and found this cause to be very, very compelling. How many people are waiting for matches at this point? What's the scale of this need?
Worldwide, there's 50,000 people a year that are needing matches outside of their family. So you only have a 1 in 4 chance of matching a sibling with the same two parents, which a lot of people are shocked to know that that's how hard it is just to match a sibling. And then next they would sometimes proceed, if they can't find a public match, with a partial match. But of course, the more of an unperfect match, the more risk there is of the body rejecting it. So that was kind of what was said there. But, there's different populations, not just mixed race people that have challenges, like I mentioned. Latinos, Black communities, they also have diverse mixing in their histories, and so they're kind of similar. So the more variables of what you are, a lot of people are doing those 23andMe tests or ancestry tests, and they're finding surprises in their ancestry. Or, a purely Caucasian patient is like, why can't I find a match when there's like a huge amount of Caucasian donors? And then to their surprise, they might have inherited some really rare genetics that came from, some ancestors or, some secret things that maybe their family didn't really share with them. So that's something that we want to be there for diverse people like that are having challenges. And I mean, I've heard that there are some that may not have matches that are currently alive and registered. So that's why it's our duty to try to do that, as well as look into other advances that have come across, like cord blood donations and other things like that.
Yeah. We'll talk a little bit about the sources of these donations, because I know it's something I was going to ask you later about the fact that there's a bone marrow or blood donation, but then also cord blood. What's the difference, or what do those terms mean?
So there's two types of ways to be a public, public adult donor. One is through the arm, which is PBSC, peripheral blood stem cell donation, and it's much like platelet donation. It's done through the arm, and then the other 25% of the time is bone marrow donation, which is what most people are kind of cringe over and hear the word bone marrow and get really scared. but it actually is not as scary as people think, and our film kind of shows the route that a donor has to go through. You're put under general anesthesia, you're not cut open, it's a needle. The time to recuperate is not as bad as people, I think, imagine. Movies and TV kind of dramatize it for the entertainment factor. So that's done damage to the registry, I believe. Those are the two main ways adults can, between the ages of 18 to 44 can donate. But expecting mothers now can actually donate their baby's umbilical cord, and something like 90 to 95% of umbilical cords are actually thrown away in medical waste when they could be used to save a life. And there is a difference between private donation of cord and public. So most people hear, oh, you could privately bank your cord blood, but majority of the time, it's not even usable for your own child. The way it works, the science, the way it works, it'd actually be beneficial for somebody else. So not a lot of people know that, and unfortunately a lot of companies play on fears, and it's a business. So we encourage, if every mother just publicly donated if they could, there'd be just such a huge wide bank full that nobody would maybe have to wait.
Our facility's set up to be able to accept that or support that decision of a family?
Yeah, most big cities have quite a few hospitals now, and there's more arising every year. Not every hospital participates, so you would have to ask your doctor. I've heard of people being so compelled to want to that they've switched hospitals or try to look at mail-in kits. There was like a Duke University trial to mail. Somehow they keep it preserved, and then they have it sent. Yeah. So.
Okay. And you mentioned the registries, and I heard you talk about international. So are registries typically set up on a national basis? Are there international registries for people living abroad?
Yeah, I think cost-wise and insurance-wise, I think they obviously are going to check in your own country first, but the U.S. does cooperate with quite a few other countries, and they will ship it by plane over, and most people would just donate locally at their local hospital, and then they would have a carrier bring it over on a plane. And we've seen that happen quite a bit, and actually people from other countries turn to the U.S. because we have such a diversity here, and maybe they don't have a large registry in their countries, but it's very shocking to learn like places like the Philippines don't even have a registry at all. So essentially anybody needing a Filipino match or a donor, the best bet would be like Hawaii or somewhere in the U.S. to find that match. So.
Well, so you were talking earlier about just how people's backgrounds are varied. They may be aware of that. It might be something that they discover through some of the new genetic testing. Why don't we play the next clip, because I think that addresses some of that, and then I'd like to talk to us a little bit about what it means to sign up for a bone marrow registry.
So my story became race-based. So as we were propelled into advocacy, it was always with a focus on recruiting potential donors of Chinese background and of mixed background. In the end, it took almost 7 years to identify a marrow match, and even then, frankly, it's an absolute miracle that they found a match for me. It was a big surprise when they told me that my match was Caucasian. But the fact is also that she wasn't a complete match. She was what they called at the time a 5 out of 6 match. So they're always, always, always looking for a 6 out of 6 perfect match, because that means the risk of rejection is minimal. So a 5 out of 6 match was risky. But what's interesting is that my donor, Julie, she's actually getting her PhD in entomology, and she was able to identify that, in fact, she has Chinese ancestry, back through her lineage. And so that's why I think it's always important just to emphasize that absolutely anybody, no matter what race, should be tested if they're eligible.
So what were we just seeing there, Athena, with it looked like swabs and information people are filling out? Is that typically what a registration recruitment site would look like?
Yeah, so we host drives at college events because, that's the best kind of demographic we're looking for is young, healthy donors. So college events, cultural events, things like, depending on who we're kind of advocating for, that would have the best chances in that community. So that one was at UCLA, and she was a business major at the time. But yeah, we don't discriminate when we register people, as much as, like, I might say I want to try to raise the awareness for mixed race or minority donors. That's not to say I'm not going to register a Caucasian person, and because they could match, especially if the person's mixed with Caucasian or that person doesn't know their whole ancestry. Sure. And a lot of people don't know what they are. If their family's been here for a really long time, we don't know the full. We only know maybe 3 to 4 generations back. So there's a huge story that a lot of people carry within them, and they don't know they have that. So yeah, I never discriminate. I don't think that would be wise. But there is definitely a push to try to do them in cultural communities to try to help the odds.
Close some of those gaps that have traditionally been out there. You touched on this earlier, but I think our next clip is going to talk a little bit about the fear or what happens where someone might sign up for a registry and then maybe when the call comes in, not be certain about that. Why don't we take a look at this next clip, and then maybe you could talk a little bit about what we just saw.
Luck would have it, we actually found someone who had just received that call.
So I joined the registry in 2012. I got the phone call, I want to say, maybe a month and a half ago. I was really only on there for, I think, a year and a half. She let me know, like, the possible procedures, either stem cell or bone marrow donation, and, what each one entails, how long they take, what the recovery time is, and stuff like that. And she was really surprised that I was so excited. She was like, you're really serious about this. You're really excited. I was like, yeah, this is an amazing opportunity, and I can't imagine saying no. And she was like, you'd be surprised how many people get told that they're a possible match, and they decide they want to back out.
Initially, when they're called as a potential match, 50% of donors say no. 50% say no, or they ignore us. People join for different reasons for the registry. They join for maybe they know someone that's sick, so they only want to help that one person, or they did it because their friends did it, and so they wanted to look cool or act like they could go along with that as well. And in the long run, they didn't really want to do it, or they're scared. We don't want to give patients false hope. They know how many potential matches that they have, and about half of those fall off. So we want to have them committed, obviously.
So that's certainly been your experience as she's describing. You've seen that happen.
Yeah, and I do think there is a cultural component, I specifically in Asian communities, which I've dealt with. There's a lot of fear, especially with family pressure. A student might have signed up at their college drive, but once they actually are selected and called and said, hey, you matched somebody, they take it very seriously to hear what their grandparents or parents' opinions are. Whereas I feel like typical maybe Americans are maybe a little more independent in their decision making. So there are some cultural kind of things like that. There's also a lot of minority groups. Some of them don't trust the system. They don't want to sign up in general, because they're just like, what are you going to do with my swab? What are you going to do with my blood? And so there's a little bit of that as well. But yeah, it's sad that quite a few people that do initially register change their mind, and fear is the big thing. And one of the themes that was discussed earlier in some of the other panels was caring and having this idea that it has to matter to each person. And until it really hits your own family, I feel like cancer is such a prevalent thing, but specifically bone marrow donation, you're relying on a stranger to volunteer, to undergo something, to save your life. But if it was your sister, your brother, your mom that it was going through that, you would hope that that stranger, wherever they are, would do it. And you would do anything to make that happen yourself if you could donate to them, but it's kind of high stakes when you're relying on someone you don't even know. And so I just always try to tell people when they're signing up, like, think about if it was you or if it was someone you loved, you would hope that they would do it. And that's what makes this whole thing so amazing and beautiful, is that it is the kindness of somebody from their heart that's donating to somebody they don't know just because it's the right thing to do. It's not based on any other ulterior motives. They don't get paid to do it. But every donor I've ever talked to, especially the ones that ended up being able to meet the person they saved, said it was the best thing in their life they've ever done. how many people in the world can say they saved somebody's life?
Literally, yeah.
And lots of the time, they're the only person in the world that matched them. So it's pretty incredible that sort of way we can cure disease. We obviously rely on doctors and research, and that's huge, but an average person can do a miraculous thing. And so that's why I think this whole journey for me has been so meaningful, is meeting these people and just being amazed by how many amazing donors there are that are just so giving. And a lot of them are just so nonchalant. They said, well, why wouldn't I do it? A lot like Alexandria, who you saw, she that's her whole premise is, I couldn't imagine saying no, but there are quite a few. I mean, a lot of people weigh different things, or they hate needles, or, they think, oh, what if something happens to me? And there's always that risk, but there's also a risk to drive your car down the street too, so I don't know. I think if your heart is in the right place, you'll have good vibes around you. So.
Well, particularly with you as an ambassador to making it easier for people to register and then actually for these matches to occur. We've been talking all day about the role of the workplace, the role of employers, and you just mentioned cancer. That would probably be one of the most devastating diagnoses that would affect a colleague or a workforce. So what is the role for an employer in supporting awareness of this, maybe even supporting outreach to build, the bone marrow registry to help employees match? What have you seen where employers have been comfortable, proactive, supportive in this space?
Sure. Of course, it's very delicate. I mean, there are some stigmas with certain people that they don't want to talk about their disease. So obviously, you tread very lightly on how you would approach an employee and if they even want help, But obviously, if they do and they're searching for a match and their story becomes public, I've seen folks at like Google that did drives across their campuses and actually made all their employees like learn about it or hear about it, or sent out mass emails saying that one of their own employees was dealing with this, and that was incredible because a lot of those people have large impact and are big in social media. And so I think awareness is the number one thing you can do, because you never know how many people you can inspire by just spreading the word. It's great to have numbers and people swabbed, but that's only one swab you're doing yourself. But if you post it on your Facebook, you have all your friends, and then if they share it, all their friends, and that's a free source of advertisement. So I always encourage that as a number one thing that people in the workplace can do, is just share about it. Obviously, monetary donations, or in-kind donations is something as an organization we try to support patients. So while they're in their hospital stays, we send them like care packages, things like that, and that costs something to operate. But I think just the emotional support is the biggest thing as well. You want to make sure you're there for not just them, but their families. I mean, it's incredibly difficult to have the stress weighing on you that you need to find a match, and then you have a family maybe to care for, and and then hospital stays, or if it's a parent of a child that's sick, they're there for hours and days even. And so I've heard of really amazing employers that have given extra time that maybe normally wouldn't. And then on the donor end, I know the state of California actually allows for time off if you are a donor. I'm not sure state by state which ones are not participating in that, but just that willingness to let your employee go and do this good deed and have the sufficient time off for that, not taking it out of their vacation.
So it sounds like there's a mix of things that might be very employee-centric. A crisis literally in healthcare occurs for an employee. They've learned about it for the first time, or it's a critical time in their health treatment where an employer could become involved. But it also sounds like it might just be a matter of, are their policies sensitive to the fact that this is occurring for any employee in any way should it come up? Or do you have resources that could be part of just the employee health education process, or something that helps an employer take maybe a more passive but clearly very important education role?
Yeah, I mean, I've talked at several places of employment, and I feel like it's just really case by case. Some people's treatments are more aggressive than others. They're different stages, and depending on if they're the patient themselves or a family member, and then depends on, I think, each individual fit where they're coming from. But I think overall it's just that sense of compassion and like empathy, knowing like people go through these things and it's unavoidable, and you try your best to try to be in their shoes.
Well, it sounds like it's another aspect. We talked earlier about creating community, and this is just another lens by which community can be created in an area that people may or may not have any knowledge about, which is good. I think we have a clip coming up. It's concerning Imani Cornelius. I think you know her, and why don't we see the clip, and maybe you can talk to us a little bit about what we're seeing there with Imani's experience.
Sure.
You ready? She says it's a big bag. Okay. Are you ready? Do you want to ride? Are you ready at slow or over 2 hours? Slow. Start time 12:19. There it goes. The before stuff, like the chemo and radiation and then the side effects and all that, that's the complicated part. But when you actually like get it, it's simple because all it is just an IV going in.
So what did we just experience there with Imani?
She was getting that was live footage of her donation. She had been searching for a couple of years. She was diagnosed in, I think, middle school age or maybe elementary actually, and she was biracial and she was having a hard time finding a match. And she actually I think her family kind of credits Robin Roberts from the Today Show. She had a large search and really concentrated on getting more African Americans on the registry. And it was around that time that she found her match. And it was actually a police officer in New Jersey that saved her life. And she's in Minneapolis. And at this past fall, we actually had them meet on stage for the very first time, and she got to meet the person that saved her life, which was really, I think, touching and incredible for him. And he didn't know it was all documented in our film, so seeing that side for him was really, I think, emotional. And I think he didn't realize the magnitude of what simple thing he said he did would actually do for someone. And it saved, her parents, years of all the stress and, the loss of a child is incredibly difficult. And I've dealt with families that have gone through that. And it's just that sigh of relief that now she can move forward with her life. And she was just she was just given an opportunity to go pick out a prom dress that be the match the National Registry set her up on. And so she was like in a little promo thing with them. So it's incredible that now she's able to move on and move forward with her life. So.
And was that a totally unique kind of experience around her and kind of her story, or is that what you see in terms of people hearing that there is a match found and being able to move forward? Is it a pretty exciting time in a family's life, I would assume?
And especially if it's years of searching. I mean, there are people that get diagnosed and then they have a match that is there. They're just lucky with that. Sure. And out of curiosity, I had my DNA run to see if I had any potential matches. And me being Japanese, Middle Eastern, Caucasian, I was like, oh, for sure, there's not going to be anybody. But odds are I inherited really common genetics. And so I was shocked that actually I had matches. But it made me sad because I'm like, oh, well, for every person that does have a match, there's like tons that don't. So it was, and I don't even need it. And I matched, I had matches. But yeah, there's a ton of people that, they're waiting for that call that they have a donor. I mean, it's like that with any, I think, donation for organs and things like that, but it's not as difficult to match organs as it is for marrow because you're replacing the whole immune system. So people realize how difficult it is. So.
Well, having seen these clips and having you share that, what else would you like to share with the group before we kind of open things up for questions about how do you learn about registries? How do you connect with events in your own community? If you have a family member who might be facing a diagnosis like this, what would be that next step that you could take with them to be supportive?
Yeah, I think just the main thing is awareness and education, and I think there's just a lot of communities that don't know a whole lot about this, and if you're not in the medical world, you may not learn anything about it, but it's just an incredible way to be selfless and to save a life. And you could just post something if you're kind of research more about the process. If you're questioning if this is for you, or people are kind of wary about the process, do your research and ask questions and just spread the word, and that way more lives can be saved.
And so if there are follow-up questions here, and we'll open it up for discussion, but what about your organization's website? How might people see the trailer or even the full movie? What would be those avenues for folks here in the audience?
Sure, it's mixedmatchproject.com, and we have resources. We have bonus clips. We filmed over 200 hours worth of footage. We filmed it over the course of 6 years. So there were a lot of stories we couldn't include in the hour-and-a-half documentary. So we're going to be releasing that footage over time. So I have cards if people want to see me after. I actually brought a few DVDs if people are interested to purchase a DVD, but it's also available on our website as well.
Great.
And it is touring collegiately. We are screening at 60 different college campuses this year. So.
That's amazing. I mean, Athena flew in last night, got here today as opposed to yesterday by virtue of the time she finally landed. I mean, I really appreciate you being here and sharing your story. Any comments or questions? Here's a question or comment.
Hi, okay, good, it's on. So I am also mixed race, so thank you for representing us in our journeys. I do have a question about the short-term versus long-term solution. So I feel statistically more and more people are going to be mixed over time. And it's almost like it's an infinite thing, depending on, I guess it's finite based on all of the possible races in the world, but it's kind of an infinite, endless number. And so are there any long-term solutions or resources in the works to maybe tackle not relying on a 5 or 6 out of 6 match, but instead, like that's not the key variable that's needed. It could be more of a generic application of DNA as we're just going to get more and more complex and more mixed as we go on.
How it's going to play out. But cord blood is one of the newer ones that, babies are being born, and it's not, it's not really risking anybody as much as it would as an adult donor. That commitment is way easier, I think. So yeah, that's the case. But I think number one, it was mentioned before, reporting statistical information is just does not exist in in a lot of different medical hospitals and medical research. Mixed race are very lacking in as a percentage. I mean, it's not counted. And a lot of the excuses is, oh, there's just too many mixes. But I mean, we're going that route if you look at the census. So it's only going to be more of an issue if we don't respond in some way of targeting that. So there have been, people in biomedical research and things like that are trying to increase that and open that up and make it more of an issue. But there's not as many voices like mine that are out there, and so I think it's going to take time, but yeah, there is an effort to do that, and there is effort to have legislative change and or funding to go toward more research. So I think I'm more on the front lines of actually getting donors, and I do this actually part-time, so me, myself, anybody that's, I always encourage people that volunteer that have any kind of knowledge or connections, I'm always willing to collaborate and
Just share with the group the number of employees at Mixed Marrow.
Oh, 0.
Yeah, 0. This is a
completely volunteer
effort. Yeah. But that's a really good point about research to change the equation, change what's possible through, being able to open up to more people matches that work. Whether it's following this traditional method or there's a new way to do that. Any other? Here we have a question. Yeah.
I know you mentioned that you're working with some U.S. universities to do screenings. Have you collaborated or started conversations with any universities abroad to have them do screenings or volunteers do campaigns there?
Yeah, we've been having requests to maybe dub the film in different languages. I think it had a screening in Japan, but it wasn't, it was at a conference. But yeah, I think that would be our next route. We're trying to tackle the US first because the registry I work with, you can only swab based on our kits here. We would have to go through their registries there. It's a little bit difficult in that way, but the message is pretty universal. So yeah, we do, but it takes money and time to transcribe the whole film, and then so it's going to be a little while before we get it across. But I mean, I think in English it wouldn't do too bad because a lot of people speak English across the world. But yeah, there's been interest from China and Singapore because we went to a national Be the Match kind of cooperative registries were there. So we met some of the registry leads that had interest there. So yeah, eventually it will.
I'm trying to remember, is Be the Match featured? Do you have some footage of that in the film? I thought so, yeah.
Yeah, so Be the
so
Match
that
is
you'd
a
find that
national-
interesting.
Yeah, that's a national U.S. registry, and we function under them. And yearly they have an event every year where they have their national kind of group get together, and then also international registries come together and try to collaborate on ways we can work together.
So I think, you know, the role to play, I think I would not be surprised if you don't have many more advocates here with you after making that presentation than you did coming in the door. And I think employers, you know, from what we heard of earlier panels, clearly have an interest, you know, in the most vibrant workforce possible, be it one that's racially diverse, talent diverse, and then supporting those individuals in their health. I'll see if we have any other questions. Michael, I would just ask you, you got to speak right at the beginning, maybe you're going to speak again, but you were at the Smithsonian. What did you see there in terms of people reacting to the film?
Part of this is society is changing, and the Chamber's trying to get with the changing times. And part of the theme of this event, when I organized it, was to make sure it reflected how society is. I think part of this is, for a long time, as Dr. Karen Tabb was saying, was that there was a lack of reporting. One time, you could be mixed race, but you considered yourself African American. There was only one box to sort of click. And as somebody in the policy field, there's an opportunity here that exists, because the opportunity is infinite, as Sinead was saying, because this is going to go on for the remainder of time. The best part of being in any sort of city, including Washington, D.C., is just the international and the local people and the politicians are all intermingling together. And I think in the rural areas, it's a little less so, but that's slowly changing. And diversity really aids organizational thought and competence at the end of the day. And the biggest part of being part of the film screening, and Jeff was there, and Jeff is the director, and by background, he's an animator, and he did most of, or not all, his company in your film. And I think part of this is a recognition that, you know, the status quo is no longer acceptable, that we can no longer live with the fact that healthcare costs are unsustainable. We have to get a better handle on, at the end of the day, on lowering the cost by improving the quality of health. And the only way you do this is in a community angle. And from a disease prevention standpoint, the best angle is if you're sick and you can help, you have an obligation, or you have, if you're a compassionate person, you have sort of an understanding that just raising awareness is the first step of education, and education is the key to the rest of this. So I thought the movie was extremely well received. In fact, I was even, a little tear-jerky at the end, and I was a little shocked myself. And it's just very powerful. So I know you're selling a couple DVDs, so if you're interested, I would recommend you purchasing them from Athena. So.
Great. Hated to put you on the spot, but I mean, it's just, there's nothing like that firsthand experience. Well, if there are no other questions, then why don't you join me in thanking Athena, not just for her remarks, but for this amazing volunteer effort that's making such a huge difference. Thank you.
Thank you. And thank you. Thank you
Sure.
and thank you to the U.S. Chamber of Commerce for inviting me. I appreciate it. Thank you.
So thanks for everybody that stuck around till the very end. This is a total team effort here at the Chamber, even though I'm the program manager, and every speaker is smarter than myself, and I'm proud to say that. The thing is, at the end of the day, the event management team, the event team that set this all up, our facilities team that does an excellent job, the catering, everybody remarked about how good the food was, so I'm hoping they enjoyed it. And then we got the Wizards of Oz in the back that are doing all this great stuff with the video and the display and the PowerPoints, and we can't thank Joe and his team enough. So with that said, go back to your offices, think about how you can help out in society. As businesses, businesses exist to make a profit, but the people that make a profit are those that are helping out in society. So they go hand in hand, and Elise Cohen from, the U.S. Chamber of Corporate Citizenship Center, that's part of their mission here at the foundation. So engage with her if you haven't, and thank you also for CTAC, and Jane Newman stepped out, but Pfizer, and also Randy and the partnership for sponsoring this event, and I look forward to staying in touch with many of you in the future. So thanks, everyone.